Right. So we want to finish 2 cases, that's definite. Third one may or may not be. Tomorrow, of course, the 3 cases in case the third one is not done. Most of the cases are going to be, we have handpicked these cases because anything simple going to be done by these experts may not be appealing to them because we want them to come again and again. Challenging cases, they should choose India to come and then do, and then make us learn. So this is the kind of lineup. Seba will present the first case, I think. You are going to present now? Okay. You may actually present that case so that let them have, or after the first talk? After the first talk. Okay, may I invite now Dr. Santosh to start off with his talk. This is on the conduction system from the perspective of physiological pacing. After his talk, I would request him to go to the lab after going through the case presentation and then maybe a small discussion. And then, we will see how things go ahead. So I welcome Dr. Santosh Padala.
Good morning, everyone. First of all, I would like to thank Dr. Pandurangi for this invitation. And I'm very happy and excited to be a part of the first National Physiological Pacing Symposium. It is truly an honor to come back to the home country and talk about our experience on conduction system pacing. I have no disclosures. So a little bit about myself. I was born and brought up in Hyderabad, did my med school at Kamineni Institute of Medical Sciences, graduated in 2007. Went to residency, finished my 3 years of internal medicine residency at UConn, did 3 years of cardiology fellowship at Albany Medical Center, and then I was fortunate enough to join EP fellowship at Virginia Commonwealth University under Dr. Kenneth L. Morgan. And it was during this time I came across this guy who's the most hardworking co-fellow, and that's none other than Parikshit Sharma. He was my senior EP fellow during the training. And after the fellowship, I stayed back as faculty at VCU, and this is my 3rd year as faculty there. So I'm going to talk about the anatomy and physiology of conduction system today. So back in the 19th century, there was a huge debate as to whether the cardiac impulse propagation happens either via the myocytes or the nerves. It was not until 1906 when Tawara, a Japanese pathologist, for the first time described the existence of specialized myocytes which make up the cardiac conduction system axis. So this is the original publication figure from 1906, and you can see the specialized conduction system axis in orange. You can see the AV node continues as the His bundle, which you can divide it into 3 parts, like non-penetrating portion, the penetrating portion, and the branching portion into right bundle and the left bundles. This is a depiction from McAlpine's Atlas. This is a very simplified version of the cardiac conduction system. This is looking from the RAO view. This is the right atrium, right ventricle, and the orange is your conduction system. You can see the AV node continues as the His bundle, penetrates the membranous septum, gets to the left side, and then you can see the right bundle coming down, branching out into Purkinje fibers, which supply the pap muscles. When you look from the left side, this membranous septum is closely related to the non-coronary cusp and the right coronary cusp. And you can see the His coming out of the lower border of the membranous septum and then divides into the right bundle and the left bundle. The left bundle again further divides into left anterior fascicle and the left posterior fascicle. Again, most textbooks show this line depictions, which sometimes can underestimate the complexity of the cardiac conduction system. Let's look at some anatomical landmarks. So this is, these are the images from Sabine Ernst and Yen Ho anatomy textbook. So this is, again, the right atrium, the right ventricle, the septal leaflet of the tricuspid valve. One of the important landmarks we have here is the triangle of Koch. You can see the septal leaflet of the tricuspid valve, the tendon of Tadaro, and the base is formed by the CS os. One of the components of the triangle of Koch is the compact AV node. You can see here, which as it continues distally, it becomes the bundle of His, and then it penetrates the membranous septum. This is looking from the top. You can see the pulmonary artery, the aorta, and the mitral valve and the tricuspid valve. So this is the interatrial septum between the right and the left atrium, which can further be divided into anteroseptal area, where you have the His, the mid-septal area, where you have the compact AV node, and the posterior septal area, which is actually the pyramidal space. Notice the relationship on the right and the left side. On the right side, you have the septal leaflets and the anterior leaflet of the tricuspid valve, whereas the left side, it's closely related to the right cusp and the non-cusp. And again, this is from the left side. You can see the aorta. This is like your pasternal long axis view. So the right cusp, non-cusp, and this is the membranous septum, where the His bundle comes onto the left side and divides into bundle branches. These are a few more images looking closely at the membranous septum. This is the right side view, this is the left side view, and you can see this blue dotted area is the membranous septum on the right side, membranous septum on the left side, and the red dots are the course of the conduction system. In the lower panel, in here is the long axis 4-chamber cut view. You can see the right atrium, left atrium separated by the interatrial septum. You can see the RV, LV separated by the interventricular septum. The interventricular septum can be divided again into membranous septum, which is marked by the arrow, and the muscular septum. This area is zoomed in here, and you can closely again see the membranous septum here marked in blue dots. Notice the relationship between the membranous septum and this black dotted area in figures B and D. The black dotted area is the central fibrinous. So it's very important to understand the anatomy, because it's going to help us during conduction system pacing. So it's also crucial to understand the histology of the structure surrounding the cardiac conduction system. So here the histology is shown at various levels. This is, you can see the membranous septum, and this is the muscular septum. Here you can see the membranous septum is again divided into two parts by the tricuspid valve hinge point. Above the tricuspid valve, you have the atrioventricular membranous septum. Below the tricuspid valve, you have the interventricular membranous septum. So I don't know if you can make it out, but there's an asterisk here that points to the area where the His bundle penetrates from the right side to the left side. So the His bundle typically penetrates, in most of the cases, at the lower border of the membranous septum. Again, there might be some variations, but majority of the cases, it penetrates the lower portion of the membranous septum. As you go further down, you can see these are stained with Mason trichome. The green is the fibrous tissue, and the red is the muscle. And you can see the asterisk, which is the His bundle. Notice its relation to the fibrous tissue. Okay. So what does it mean? So again, if you look closely at the penetrating bundle of His and take a histology at this level, you will see the red area is the His bundle, and it's completely encased by the fibrous tissue. This is very important to know because, since it's encased by the fibrous tissue, which is electrically non-conducting, that's probably one of the reasons why you have higher capture thresholds with the His bundle pacing, as opposed to left bundle branch area pacing, which is surrounded by dense septal myocardium and not fibrous tissue. This is the left bundle branch in the human heart. This is, again, a picture from 1906 Tavares publication. And you can see this is the left ventricle. These are the aortic cusps, membranous septum, and then the left bundle comes down, divides into left anterior fascicle, left septal fascicle, and the left posterior fascicle. And you can see these fascicles then arborize into several small Purkinje fibers, which go on to supply the pap muscles and the LV subendocardium. Same network can also be seen in bovine hearts. Again, here is a beautiful image of the left ventricle showing the left bundle dividing into left anterior fascicle, which is traversing towards the left, towards the anterior pap muscle, left posterior fascicle traversing towards the posterior papillary muscle. Notice the rich intercommunications between the fascicles provided by the Purkinje fibers. And you can see the dense network on staining. This was a publication from Nature. It's actually very beautiful in that in this publication, they were able to map the entire cardiac conduction system using high-resolution, contrast-enhanced micro-CT imaging. The spatial resolution was incredible. They were able to look at single cardiac myocyte. By doing that, they were able to delineate the entire cardiac conduction system. So these are some of the images from that publication. On the left side, you can see the histological representatives. On the right side, you can see this is a micro-CT imaging, and you can see, based on the contrast uptake by different structures, the conduction system was able to be identified. So this is the compact AV node marked in red here. And as you come down, you can see the penetrating bundle here. And as you go down, you can see the right bundle coming along the ventricular septum. And these are the short axis views where they were able to delineate the left anterior fascicle, posterior fascicle, and septal fascicles. They also did some 3D anatomic reconstructions. So this is the His-Purkinje network looking from the right side. So this is your right atrium, tricuspid valve, right ventricle. Again, looking from the right side. You can see the green marked area is the AV conduction axis. So this is your AV node. As it continues distally, it becomes a His bundle, penetrates the membranous septum, comes onto the left side, which is below the right cusp and the non-coronary cusp, and then it divides into right bundle and the left bundle. You can see the right bundle is marked in red. Its thin ribbon-like structure comes down and fans out into Purkinje fibers. And then the left bundle, you can see it better from the left side here. So this is looking from the left side. Again, you can see the right bundle in red. The left bundle is a thick band-like structure, which again divides into left anterior fascicle, septal fascicle, and the posterior fascicle. Note how the left posterior fascicle is thick and band-like structure compared to the anterior and septal fascicles, which are thinner. These are again some more images from their publication. You can see the sinus node in turquoise color, and then the green is the AV node. This is looking from AP view. This is the right bundle and its branches, and the left bundle. This is with myocardium overlaid on top of the conduction system. And this is one of their examples of cardiac isochronal map during impulse from sinus node. So when we talk about conduction system pacing, when we talk about His bundle pacing, we are targeting this small, precise target zone. Okay. And when we talk about left bundle branch area pacing, we have a wider landing zone. You can either get the lead at the basal septum close to the left bundle, or you can sometimes go down as low as mid-septal area. Again, it's very important to understand, again, the anatomy and the histology, I think overall favors left bundle branch area pacing over His bundle pacing. If you think about it, the His bundle, it's a very narrow, precise area, requires higher precision, and now you're screwing in the lead, and if you think about the histology, it's surrounded by the fibrous tissue, whereas the left bundle branch, it's a wider landing zone and has a dense septal myocardium. So that was the anatomy. We'll also talk a little bit about the physiology of conduction system. So when we talk about the site of bundle branch block, where exactly is it? So if you take a patient with the right bundle branch block, what is the most likely site of block? Is it at the AV node, is it at the His, or is it in the right bundle branch? Okay. Is this one? At least late until my cardiology fellowship, I used to think that when patients have right bundle branch block, the block is in the bundle branches. But now we know that the block is actually, majority of the times, it's in the intra-His portion. So this is the concept of the longitudinal dissociation, where the fibers which are predestined to become right bundle are blocked in the His area. So if you can get your pacing lead distal to the site of block, you will be able to recruit the right bundle or the left bundle. Again, if you take a patient with left bundle branch block, where is the most likely site of block? Is it, again, at the level of His? Is it at the left bundle branch, or is it distally? This was a publication from Rod-Tung where they looked at all patients with left bundle branch block. They were able to map the left side of the septum using a multi-electrode catheter. And what they found was that in about 46% of the patients, the block was located in the intra-Hisian region. And about 20% of the patients had block in the left bundle branch. And in about 35% of the patients, there was intact Purkinje activation. So these are the patients who have baseline left bundle branch block at baseline, but about 30-35% had intact Purkinje activation. That tells you that in those patients who have intact Purkinje activation, even if you put a His bundle lead or a left bundle branch pacing lead, it's not likely going to correct the widening of the QRS. So those are the cases still which won't be able to be corrected with His bundle or left bundle branch area pacing. And when we talk about conduction block, is it real block or is it just a delay? So here I'll show some examples. So this was a patient with right bundle branch block, and you can see in the V1 rhythm strip. So this was the baseline rhythm. Every time after a PVC, following a pause, there was a narrow QRS beat followed by right bundle branch block. So this tells you that the right bundle branch block at baseline was functional. So how does this happen? So if you see here, the patient has a right bundle branch block beat followed by a PVC. After a PVC, there is a long pause, which allows the right bundle to recover from its refractoriness, and you get a narrow complex beat. Following this, the sinus impulse comes on time and finds the right bundle refractory, and you get a right bundle branch block. So this is your classic long shot leading to Ashman phenomena. So the refractory periods of the bundles depends on the previous RR intervals. So for this narrow complex beat, the refractoriness of the right bundle depends on the previous RR, which is long. So the right bundle refractory period is long. So the sinus impulse finds right bundle to be refractory, and you get right bundle branch block. So how do you explain the perpetuation of right bundle branch block? That can be explained because when you have right bundle branch block, you have the impulse coming down the left bundle, goes transeptal, penetrates retrogradely into the right bundle. So when the next sinus impulse comes in, it finds the right bundle refractory, and the right bundle perpetuates. So the long shot leads to right bundle branch block, and the concealed repetitive penetration leads to perpetuation of the right bundle branch block. And you can see the short long results in resolution of the right bundle branch block. It's like reverse Ashman phenomenon. This was another interesting case we had. This patient actually was in his 70s, presented to us with recurrent syncopal episodes, and he had baseline left bundle branch block. When we brought him to the lab to do a EP study, you can see he had a premature ventricular beat, the morphology of which was almost similar to his baseline left bundle, and following that there was a long pause. Basically, you had a peel back of refractoriness and normal QRS complexes. So this was repetitively demonstrated, and you can see here with the His bundle electrograms, you can see this was a His extrasystole leading to peel back of refractoriness of the left bundle and normal QRS complexes. It can get even fascinating. Here you can see an example where patient had sinus rhythm with atrial bigeminy. Every time with the PAC, you can see there's a right bundle branch block, sinus beat with narrow QRS, PAC with left bundle branch block. So there was alternating right and left bundle branch block. So the way you explain this is it's due to alternating long short phenomena in the bundle branches. And this is again a functional block. This is a ladder diagram for that. So why do conduction system pacing? So we all know that patients who have get our chronic RV apical pacing over time, 15 to 20% of the patients can develop pacing-induced cardiomyopathy. This is due to both interventricular and intraventricular dysynchrony created by the wide QRS complex. Once this was realized, people started implanting high up in the RVOT or in the RV septal area, but still the outcomes were not different. Even when we do traditional biventricular pacing, you're pacing at two non-physiologic sites, that is the RV apex and the CS. That probably explains the ceiling effect of biv pacing in patients who require cardiac resynchronization therapy. Whereas if you look at the His bundle pacing, you're pacing at the His, it comes down the bundle branches and activates the ventricles, providing the ideal modality to create electrical and mechanical synchrony. So when we put His bundle leads, where exactly are the leads? Are they above the tricuspid valve or below the tricuspid valve? This was a publication from CIRC. This patient actually ended up dying from a non-cardiac cause, underwent autopsy, and you can see the His bundle lead is above the tricuspid valve. And this is transillumination of the membranous septum from the left side. You can see again the His bundle implanted at the membranous septum above the tricuspid valve. These were the histology specimens, again proving that the His bundle location was above the tricuspid valve. Again, it can be demonstrated on the transthoracic echo, in the apical four-chamber view, in the CT scans. Majority of the cases, it's above the tricuspid valve. This was one of the cases from our lab. This patient had a His bundle lead. After a few years, he had severe right-sided heart failure due to severe TR. He was taken to the lab for tricuspid valve replacement. It was a mini thoracoscopic approach, and you can see there was marked tricuspid annular dilatation. You can see the septal leaflet, the posterior leaflet, and the anterior leaflet of the tricuspid valve, and you can see the His bundle lead above the tricuspid valve, again telling you that that's not the cause of his tricuspid regurgitation. Finally, left bundle branch pacing leads. This was from the canine models, recently published in JCE, and you can see here, looking from the right side, this is the His bundle lead, and this is the left bundle branch area pacing lead. When they looked on the left side, you can see the arrow points where the helix of the left bundle pacing lead is, and when they did the Lugol's iodine staining, you can see the left bundle branch and all its branches, and you see how close the helix is to the bundle branches. I'll just end this talk with this video from, again, the Nature paper. Depicting the human cardiac conduction system. It is slow. Sorry. I think we can skip it. That's fine. I think I'm done. Thank you.
Check.
It was an excellent presentation. I really liked it. Yeah, I've been politically correct. So it was really nice. It was very, very
Thank you.
good. And I really appreciated that Ashman's phenomena which you showed. It's amazing. I was telling Dr. Sharma that I passed my DNB on the basis of Ashman, so I owe it to that.
Nice.
It was a beautiful explanation.
Thank you.
That's great. Yeah, so if there are no questions, I think Seba can present the case which Santosh is going to be handling. Oh, yeah, go ahead. You can be staying there. Okay, come down.
No, Dr. Prakshit is there. I read his article and yours and by song. So regarding the longitudinal dissociation of infraescient tract versus is there really connection between the both bundle branches by cell-to-cell conduction? So the two theories still exist. So with your recent CT microimaging, do we have any update on the exact anatomy of infraescient tract, sir?
That's a very good question. Thank you. When we started doing the left bundle branch area pacing, it's sometimes fascinating that you put the lead in the left bundle branch area, you pace it, you expect it to be like a QR or a RSR prime pattern, but sometimes it's completely normal. So how do we explain that? There is a paper from Lazaro et al. Back, I think 1980s or 1990s, where they demonstrated some transverse connections between left bundle and the right bundle. So it is possible that when you're pacing the left bundle, it can get through those transverse connections and come down the right and left, resulting in narrow QRS. Again, there are only, I think, 2 papers, one in Canines and one was Lazaro's very small papers showing possible transverse communications.
So you're pacing the left bundle, you're getting a narrow QRS. So in a patient with complete left bundle branch block, if you're pacing, and there is a complete both retrograde as well as antegrade block in the left bundle, but still you're getting a narrow QRS. So that means that it cannot go up and go into the his bundle and come down. So there should be some interconnection.
Yes.
So clinically also, I think there is some interconnection, but probably yet to be proven by histopathological studies.
Yeah.
I do not think it is interconnection theory because even these fascicles, if you look at the microdissection, I think single fascicle is also shielded with some kind of a cover, which is supposedly to be not leaking.
Yeah.
So what I consider all those phenomena are absolutely with where your lead is and what is the kind of output and what, in addition to the fascicle, you are capturing.
Yeah.
Rest of it is just the theory you can propose, but they are destined to be insulated till such time they activate the myocyte. That is how they have been designed.
I agree.
Yes.
Yeah, these are all the hypotheses. One is transverse and one is, as Shanmuga said, go up the bundle, come down. Other is virtual electrode effect where you pace the left bundle and you get stimulation on the right side.
Said in your talk, some of the areas where you pace the left bundle, you will not be able to produce a narrow QRS. Is there some way to predict this? Which left bundles you will be able to produce a narrow QRS and which you will not?
No, so so far we were, again, if it's underlying atypical left bundle branch block, if you think it's an IVCD, you won't be able to narrow it. But most of the typical left bundles by Strauss criteria, you should be able to narrow it.
Yeah, I think that's the question that we're all trying to answer, right? Can we know before we take a patient to the lab that this is the kind of patient that would be ideal for resynchronization with conduction system pacing? whether it be his bundle pacing or left bundle branch pacing. And I always challenge myself before I go into these cases. In fact, we've been doing something new where we put a vision wire, which is a corded wire, into a lateral CS branch, and then start pacing the conduction system with your other access to know if you're pulling the lateral wall in with narrowing of the QRS. So it's not just that you're going from a QRS of 180, 190 milliseconds to 130, 140 milliseconds. You're also demonstrating resynchronization of the lateral LV. So that's one thing that we've done, and we've realized that even those QRSs that sometimes seem like on surface like they might be IVCD, they oftentimes have a combination of IVCD and underlying left bundle. And so even a narrowing of 40, 50 milliseconds might be enough to pull that lateral wall in. So we don't really know the answer. That's the holy grail for conduction system pacing CRT right now.
Check.
What is this case, and what we would have done in our hospital. That also is being shown. So Seba, you can present your case. So the light could be off here.
Okay, respected faculty and delegates, we are going to see the case of 67-year-old male who is diabetic and hypertensive, who had underwent RFA for RBOT-VT during 2014, during which his EF was 35% and normal coronaries, normal LGE CMRI study, no history of recurrence. Presently, his EF is 30% and presents with NYHA class 3. Also have an history of hospitalization 3 weeks back for heart failure. And this is ECG, which is showing sinus rhythm, LBBB QRS of 180 millisecond, leftward axis. The QRS morphology suggests conduction disease. So this is a plan we are going with. LBBB correction with dual chamber pacemaker, or CRT with quadripolar or bipolar LV lead, or hot CRT with quadripolar or bipolar LV lead, with addition to AICD implantation, where DF1 type if required. So over to Dr. Santosh.
So is it an ICD or a different pacemaker? I'm sorry.
ICD.
So it's all up to you. This is the ischemic dilated cardioma. Sorry. So patient is ready to have a defibrillator class. I will provide defibrillator. There's no evidence, strong evidence against one inside. He has had EVCs to begin with. There were two actually, and then they have been ablated. Patient has no problem with respect to the finances. I think defibrillator is a choice, but if you argue that this is a non-ischemic dilated cardiomyopathy, there's no episodes of VT or etc. in the last few years. If you think your physiological pacing works really well, Ullas, be relaxed, then you know what, we'll be happy. He will donate the money to us by undergoing a dual chamber pacemaker.
Yeah, ideally, if...
No, he's rich enough to buy most of us here, so no problem.
Ideally, if, I would, at VCU, if this patient, I see him, we would obviously offer a CRTD,
yes.
Given long-standing non-ischemic cardiomyopathy with EF of 30%, NYHA class 3 symptoms. It looks like typical left bundle branch block. So, ideally CRTD with A lead, RV defibrillator lead, and a CS lead, because still in US, the guidelines with EF less than 35 still mandates a coronary sinus lead. And if the CS fails, then a bailout, a left bundle branch area or a his bundle lead.
So in our practice, in this particular scenario, it has been always he's optimized the CRT. All our last some 8 to 10 cases, we have put RV at the RV apex for sensing for only the shock, the his bundle, and then DF1 lead and a complete set. Such narrow QRSs I have not seen in the past. Because his addition there has really made. So in our hospital, it is going to be hot CRT with the DF1 ICD. That's what we would do here in our hospital.
Sure.
So you would think that could be the best thing, or you start with, ideally, I think his bundle pacing, starting, correction, you also give me a hint.
So this is, can we go back to the ECG, please? So I think this is going to answer a lot of questions on what might work really well here. So the first thing, I always look at V1 and V6. Those are my lateral leads. So V1 has a little small R wave. So whenever you see a small R in V1, that means there is some septal activation from left to right. That means that the block, if it is truly left bundle branch block, is not very proximal. Okay, it's a little bit more distal than where you think. So it's either going to be distal his bundle, or it's going to be distal enough where you're going to need to go to left bundle branch pacing. So you can use your ECG to have some sense of that. The good thing is when you look at the lateral leads 1 AVL V6, there is no Q waves, which tells you it's more likely to be a typical left bundle branch block. This is not an IVCD pattern. Now, again, that's probably 80-90% correct. We've still been fooled from time to time, so that's just my hinge. So I think the question of whether or not we go with a CRT system or a pacemaker system is up to a discussion between you and the patient, right? I know here in this part of the world, we don't have the liberty at all times to provide a CRT system or a CRT defibrillator system. Now in the US, a patient like this, 100% would get a defibrillator. Okay, so that's just going off of guidelines, but we have to take into account what our patients can and cannot afford. So if the patient can afford it, then yes, protect the patient, provide them with a CRT defibrillator, and the question becomes what type of resynchronization strategy. That's really the big question here, okay? After you've already made the decision on whether you're going to do a pacemaker or a defibrillator, what is your resynchronization strategy? Should it be a bi-V or should it be some form of conduction system pacing? So Santosh is right in saying that currently based on guidelines, just because of the fact that we don't have enough data, we don't have randomized controlled trials, large-scale randomized controlled trials, you can't throw away something that has always been the gold standard, but you also have to take it with a grain of salt because we have large-scale randomized controlled trials with bi-V because that was driven by industry. We don't have large-scale controlled trials for conduction system pacing because there is no industry support for it. Okay, so time will tell. We don't know the answer as of yet. But I'll show you some data in my upcoming talk that will hopefully tell you that there is a signal towards a better response rate with conduction system CRT than with bi-V CRT. Whether or not that pans out in large-scale studies, we don't know the answer to that. Okay, so everything we're talking about is definitely there's a lot of excitement towards it, but there are no large-scale randomized controlled trials looking at resynchronization between conduction system pacing versus bi-V pacing. Okay, so yes, I think when you look at ECG criteria, then there is a good chance that conduction system pacing will result in narrowing of this QRS and good resynchronization. And we also know that conduction system pacing resulting in resynchronization probably results in a higher CRT response rate than bi-V CRT does, but we still have to be careful. And so I think thinking about hot CRT where you also have a CS lead available becomes a good strategy. But in his case, how would you do hot CRT, Ullas? How would you perform hot CRT in his case? Okay. Yeah, so then that really means, I mean, based on what Dr. Ullas is saying.
He's right. Our issue is, again, DF1 is going back again.
I'm not, yes, correct.
The past, yes. Bulky.
So I don't prefer DF1 leads because now we've moved away from them, less hardware, less risk of issues.
So in fact, we had some problem also in one of the cases too, but now we learned that. See, as long as
It's not that one.
another port,
You're opening Parik's talk?
No. Like I'm just changing the aspect ratio.
Oh, I see. Was it bad there?
Sure, and the more pins and more connections you have, there will be issues down.
Along with the precision, so it's not exactly fitting.
So for those of you that don't know hot CRT, I know Santosh is going to give a talk tomorrow on hot CRT, but the idea really is you have, of course, you have an RV defib lead, but then you have a lead on the conduction system, whether it is his bundle or whether it is left bundle branch pacing, that results in resynchronization. And on top of that, if you add LV pacing, it's like multi-point pacing at different parts of the ventricle. You know, you're septally pacing, resulting in a narrowing, also pacing the lateral wall. So it's called His optimized, or now you can call it conduction system optimized CRT. So you're optimizing everything by eliminating AV delays as a component as well, because if you pace the His, you don't care what the AV delay is programmed to. You know, if the intrinsic beats you, as long as your His is being paced, your intrinsic's not going to beat you. You can actually synchronize that with the LV and pace the LV and the His bundle. So that works better in patients that have permanent AFib or persistent AFib where you're not planning to put an atrial lead. So you can put the His lead in the atrial port. But if you have 4 leads in where you have an atrial lead, a conduction system lead, an LV, and an RV lead, how do you plug that into a CRT can? And so like Ulas was saying, you can actually use a DF1 lead and put the LV or the His into typically the LV would go into the pace sense of the RV. So that's one way to configure it. So that gives you more options. And that tends to work better for IVCTs. So that is a situation in which for an IVCT patient, His optimized CRT, that's the reason Dr. Vijay Raman originally came up with this idea, saying we know if a patient has a right bundle branch block or a typical left bundle branch block with conduction system pacing, we can seem to overcome that in about 85 to 90% of cases. But what about IVCDs? We can't seem to do anything for them. So if you do a His optimized CRT, those patients actually seem to do well. So that was the idea.
Yeah, I agree. You know, in this case, the paper they published, the heart CRT paper, all the patients had failed correction with His bundle pacing or partial correction. So if we put a left bundle or a His bundle lead in this patient and we get a complete correction, I think there is no point in doing a heart CRT, I guess.
So Santosh, great. The patient is yours. You do what you think is the best. Now, I invite a few of the delegates here to join Santosh. Aparna must have already. No, here. How come? You didn't know, but still, you became the cath lab in charge. Come. Would you like to go now or later? Later. Yes, you can go. You see, we can accommodate 3, 4, maybe 5. Okay. Whoever is interested, can join. There, I have my two of my colleagues. So you will be the primary operator, assisted by one of our colleagues there. Okay, these people would probably watch and suggest. I hope you do not mind. These are all the pioneers in India. Yeah. So guys, have good times there. Okay. Yeah. And you know what? I'm going to be sleeping here, by the way. Okay, so 1 or 2 more can go. This is the same thing every time a case goes. Delegates are welcome to join the lab. All right, so before we proceed, is there any discussion on his talk or some discussion, or shall we invite Parikshit? Okay, go ahead.
Regarding DF1 and DF4, I still feel DF1, I don't think there should be any battery issue with DF1. No, that is related to the device. If you use an older Protecta versus Brava DF1, I don't think battery should be an issue. And I feel that another issue which is to an advantage of DF1 is that, especially patients like this, I am very sure that this patient, even if you give a defibrillator during your initial implant, when you're doing a replacement, he is going to have a normal LV or near normal LV and will not be requiring a defibrillator, provided he doesn't receive any therapies or has any episodes of VTVF. So to downgrade a device from CRT-D to CRT-P, and I've done that in many of our patients, and that becomes again a challenge with DF4. You have to again put another lead. So that's an issue again with that. So I am actually very happy with DF1 leads, to be honest.
So it helps us. It helps us to proceed. We've got large options. Fair enough. Yeah.
I would go in for a CRTD. But in a patient like this, what history you have given and 30% EF with this kind of an ECG, I would rather go by European guidelines, where the cutoff is at 30%, rather than AHA, SEC guidelines where cutoff is 35%. Because so many times we have seen patients, we have to, at the replacement time, we have to downgrade them to CRTP because their ejection fraction improves beautifully, even with CRT. Yeah. And so now we are into his bundle pacing, which is much more better criteria to resynchronize the heart.
Anita, it's a wishful thinking that this sponsor is going to be responded.
So the patients who are who are at the highest risk of having VTVF with a non-ischemic cardiomyopathy are the patients that are younger, that have much lower EFs, typically 15-20% or lower, and have demonstrated some form of VT or non-sustained VT in the past. So that's the subset of patients that is at the highest risk. So, and in this patient, when you look at the course of events, of course, we ablated the VT or the PVCs, and that was not a potential etiology for the drop in EF. It has to likely be the left bundle branch block because the cardiac MRI didn't show any scarring either. When you see some form of scar on the CMR, particularly perivalvular, perimitral, peritricuspid, then you think of a primary non-ischemic cardiomyopathy. When you don't see scarring, and there is a left bundle branch block that's been present for years, be very suspicious of this being dysynchrony related EF drop. So I completely agree that this patient has a very good chance of recovering their ejection fraction. And with the resources we have here in India, I would this patient can afford it, that's a different story. But I would probably just start with a dual chamber conduction system first. If you get a good result, take it and go home. Yeah. If you don't, then put a CRTP or D depending on whatever you decide to go. Yeah, unfortunately, scarring and how relevant that is with regards to making some of these decisions has become a bigger issue more recently with a lot of data coming out, and a lot of it is primarily from the hypertrophic cardiomyopathy population. So in that subset of patients, they use a 15% scar burden based on some studies, but I don't think there is a lot of work that has been done to say this is the burden of scar that you need to have to say this will recover or this won't recover. And some of it also depends on the duration, right? So if someone's had a myopathy for 10 plus years and they have scar versus someone that has a myopathy for 10 plus years and has no scar, what does that really mean? Like this guy, if he has no scarring and he has a myopathy that's progressively worsened with time, that tells you a story. This is progressive worsening with a dysynchrony. You took care of the PVCs. That's why I'm hinging more towards this patient should be a good responder. There is not a lot of data there. There is not a lot of data. The hypertrophic cardiomyopathy, we have 15%. So we do tend to use that with the rest of the patients as well, but I don't think there's a lot of data there.
See, in this case, that CMRI was actually done during that time.
Yeah, that's what I was about to ask you. If you were to repeat a CMR.
2000 PVC ablation, I think.
2013.
13 or 14. That is during that time.
Yeah, so if you repeat another CMR now and that still doesn't show you scarring, I would bet this patient would be a responder.
Yeah, but as you said, there are some decisions made on patient's preference. Okay, and then the patient says that I can afford. And then when we know a little bit of science that lower the ejection fraction, higher the chance of sudden death, I think shared decision making also matters. Affordability matters more than probably the science. So, but he wouldn't mind if it just be done with the dual chamber, pacemaker for him. He wouldn't even mind also. So if there are no questions, we can start off with you take your time, and then, maybe there can be some interruption if they would like to connect with us. Yeah. We go, very, very informal way.
I've been given a half hour, but I can go on for 3 hours.
Yes, yes, yes. So thank you, Parikshit.
Okay, so I have an interesting topic, and I thought about this a little bit about how do I really go about talking about the evolution of physiological pacing. It can be a talk for a full day because we're talking about the entire history of how we got here, essentially. Okay, so this doesn't advance slides. All right, so those are my disclosures, none of which should be relevant for this talk. So what we're going to review really is how did we get here? How did we get to this point where physiological pacing has become, something that every one of us wants to learn and perform. We'll talk about his-bundle pacing primarily for how does this prevent adverse outcomes? How does this potentially reverse some of the clinical outcomes? And what are the challenges that we have today? That will then lead us to left bundle branch pacing. And then finally, we'll talk about where do we really go from here? What does the future hold for us? Which may be something we still don't know. So how did we get here? We're all aware that conventional RV apical pacing results in structural changes within the ventricles, and this in turn then leads to adverse clinical outcomes. And those include increasing incidence of atrial fibrillation, increasing incidence of pacing-induced cardiomyopathy, heart failure, and an associated increase in mortality. All of this information comes from studies such as the MOST sub-study, the DAVID trial originally, and many other studies that have been more recently performed. This was just a compilation of all these studies that we've looked at, and if you look at these studies that talk about pacing-induced cardiomyopathy, you see that the range of pacing-induced cardiomyopathy in all of these studies varies from as low as 10% to as high as 60%. And that's variable depending on the population that's being studied. Are you studying sinus node dysfunction patients that are pacing very little? Are you studying patients with complete AV block that are pacing 100% of the time? And how do you define pacing-induced cardiomyopathy? Because some of these studies actually define pacing-induced cardiomyopathy as a drop in EF to less than 50%, while there are others that define it as a drop in EF to 40% or lower. So all of these definitions and patient selection determine what is the incidence of pacing-induced cardiomyopathy that you see in these studies. So as we talked about, the DAVID trial was the first one. This was ICD patient population, where they programmed these patients to either dual chamber pacing, which back in the day, this was back in 2002, they used to consider dual chamber pacing was the physiological pacing, which we now know it isn't. And they programmed them to either a VVI backup mode at 40 beats per minute or dual chamber pacing mode at 70 beats per minute. And what they found was that there were poorer outcomes with time to death or first hospitalization for heart failure in those patients that were paced in the ventricle. Similarly, the MOST or the mode selection trial really looked at pacemaker cohort of patients for sinus node dysfunction. What they did was they took 2010 patients and they divided them into saying, all right, we're going to pace you in a dual chamber mode with a longer AV delay, or we're going to pace your RV alone. And clearly those patients that were paced in the right ventricle alone did poorly. This was a sub-study from that same mode selection trial, which also demonstrated that with the increasing burden of pacing in the ventricles, you can see the higher burden in the bottom. This was 40% or more or less. You can see patients that were paced 40% or more in the ventricle were likely to develop heart failure with a 2.6-fold higher incidence. This is the sub-study that actually where our guidelines talk about 40% as the, that's the gold standard. If you're paced 40% or more in the ventricle, you could get a BIV. This is where it comes from. So 40% showed that the incidence of heart failure increased by 2.6-fold or higher. And again, if they were paced 80% or higher, then the incidence of heart failure increased even more. Similarly, we also saw that the incidence of atrial fibrillation increased with increasing burden of ventricular pacing. So that then led to, and there were a few other more recent studies that actually demonstrated that even 20% pacing burden might be enough to cause a high enough burden of pacing-induced cardiomyopathy. So that then led to the search for alternative sites. And so we started looking at non-apical pacing sites, which was pacing RV septum or RV outflow tract. And this is just a meta-analysis that looked at the non-apical pacing sites compared to the apical pacing sites. And what it really showed us was that if a patient has a low ejection fraction, 40, 45% or lower, then RV non-apical pacing might be better. But for those patients that have a normal EF to begin with, there was no significant benefit with RV non-apical pacing compared to RV apical pacing. So we were still, perplexed with what do we do for those patients that develop that pacing-induced cardiomyopathy, and so that led to looking at biventricular pacing as a potential option for that cohort of patients. So BLOCK-HF was the first study, Ann Curtis, New England Journal of Medicine, 2013, a US-based study that really looked at patients that had AV block, so their likelihood of pacing in the ventricle was higher, more than 40% anticipated pacing. They also included patients with a long PR interval, long first-degree AV block, where we know it may be difficult to program around with dual-chamber devices, and those patients that have had an EF less than 50%, because we know that patients that have a lower pre-implant LVEF are the most likely to develop a pacing-induced myopathy. And what they found was, looking at a pre-specified endpoint of heart failure, mortality, and LV end-systolic stroke volume, biventricular pacing in orange did better than RV pacing alone. Okay? So BLOCK-HF was a positive trial for biventricular pacing. But then, at the same time, the other trial that was ongoing that no one ever talks about and has not been published to date. This is important. As we look at science, we need to know what the data tells us. So BioPace was a simultaneous trial that was ongoing in Europe, outside the US study, with many more patients. You look at the number of patients in this study, 1,810. You look at the number of patients in BLOCK-HF, it was close to 600 and something. So 1,810 patients with a normal EF or a low EF, 571 patients had a low EF in this cohort. And what they found was bi-V pacing or RV pacing, there was no difference in hard endpoints of mortality or heart failure hospitalization. This study was presented at AHA, I believe, ESC in 2014, and has not been published to date. This was an Abbott-sponsored study. Okay, this is an important study that needs to be published because this data is important, right? This data actually tells us bi-V pacing may not work for this cohort of patients. But the current guidelines now use BLOCK-HF and include that cohort of patients as an indication for bi-V pacing. What happened to BioPace? No one wants to talk about it. So that then brought us to conduction system pacing, and the first thing that we actually started performing was His bundle pacing. So let's talk a little bit about the history. So what is permanent His bundle pacing? It is implantation of a pacing lead at the bundle of His, distal to a site of anticipated disease. This is the key point. Unless you do your due diligence to find that location of disease and place that lead distal to that site of disease, you're doing a disservice to your patient. Okay? So that's the most important aspect. Now, what are we trying to achieve? We're trying to preserve, in a patient that has a normal QRS, we're trying to preserve that normal QRS, or normalize. In a patient that has a bundle branch block, we're trying to normalize biventricular activation. So either to preserve biventricular activation or to normalize biventricular activation. And the hope is that this preservation of biventricular activation or normalization of biventricular activation would then prevent some of these adverse clinical outcomes that we've seen, and maybe even correct some of the adverse outcomes that have already occurred. So let's see if that's even possible. So this is what it would look like. Here's just an example of a patient with a relatively normal QRS, right bundleoid, but a normal QRS duration with a very long PR interval. And you know that this patient, at least in the US, would end up getting a dual chamber pacemaker, also had AV Wenckebach and symptomatic, and is very likely to pace in the ventricle almost 100% of the time with a PR interval of more than 400 milliseconds. Okay? When you have a PR interval more than 330, 350 milliseconds, just realize no avoidance of ventricular pacing algorithm is going to avoid ventricular pacing in these patients, okay? So this is a classic example of someone that would end up pacing a lot in the ventricle, and this is what his bundle pacing would look like in this patient population. So this is an example of selective his bundle capture. And this is paced, and this is the intrinsic QRS overlaid on top of the paced QRS. So how did we get here? So we know that the initial recordings of his bundle were performed by Ben Sherlag in the dog model, in an open heart model with the dog, or a canine model in 1967. It was his group that then went on to performing recordings of the human his bundle using endovascular catheters. Subsequently, it was Dr. Narula in the 1970s that actually used multi-electrode catheters and recorded multiple his recordings in the human heart. It was also him and El Sharif that later on, in 1977 and 78, went on to first describing the theory of longitudinal dissociation within the his bundle, and we'll talk about that in a moment. So the first permanent pacing at the bundle of his was actually performed by Dr. Deshmukh. Again, we should be proud. There's a lot of brown people in EP that have done a lot of good work in this field. So Dr. Deshmukh works up in northern Pennsylvania. In fact, when I was interviewing for cardiology fellowship is when I met him for the first time, way back in 2008, 2009. And he published this paper back in 2000. So he did these cases in 97, 98. He used extendable retractable leads with pre-shaped stylets with a mapping catheter from the groin to know fluoroscopically where the his bundle is, and then he took these leads and tried to place them there and tried to achieve physiological pacing. Again, he took a very sick cohort of patients. These were all patients with a low EF, dilated cardiomyopathy, permanent atrial fibrillation, so oftentimes their atria are gigantic. And he was successful in 12 out of 18 patients, which was 65%. Not the highest success rate, but for the first experience, commendable. Again, these patients actually demonstrated a significant improvement in the EF from 20% to 30% on average, but there were also 2 lead dislodgements. So that became a little bit of a cautionary tale. Subsequently, there were multiple groups in Europe. There was Barber Picardo from Spain, there was Archetta from Italy, there was Zanin from Italy. All of these groups performed work on his bundle pacing in the early 2000s, 2006, 2007, 2010. So why are we here 2 decades later? We haven't really still gotten that further along this way. So why hadn't it gained popularity then, and why are we talking about this now? So back then, the success rates based on all of these studies were about 65 to 70%. So if you're going to spend 2 or 3 more hours doing a dual chamber pacemaker and get a success rate of 65, 70%, maybe not something that everyone's going to want to do. The other issues were that a lot of these studies would actually require putting a mapping catheter from the groin. In the US, for no dual chamber pacemakers do we actually put a mapping catheter from the groin. Okay, so it's not common practice. The other issue was also a lot of these studies then started reporting putting a backup RV pacing lead. So what's the purpose? You're actually putting in a bi-V device when the patient just needs dual chamber pacing. It's not something that's going to be a selling point. And then there was not a lot of data on the benefit of his bundle pacing over conventional RV apical pacing. The other thing that was also happening that I haven't put on this slide at the same time was a lot of money and a lot of effort in building the bi-V pacing platform. Okay, it was the early 2000s where biventricular pacing became the next big thing. And so no one was going to invest into this any further. So what's changed and why are we here talking about this? So newer tools and delivery systems. I should say one new delivery system and an old lead that Medtronic got lucky with. Okay, that's what happened. The success rate suddenly with his bundle pacing in our early reports were about 80%, and now we have success rates reported about 95 to 97% in experienced hands. We don't use any additional steps. We will not routinely put in a mapping catheter. Even if we choose to put one, we'll put it from the device pocket rather than getting a separate groin access for it. And unless it's a rare circumstance, we do not recommend putting backup RV pacing leads in all of these dual chamber pacing systems. So we moved away from a lot of that. Also, a lot of data has emerged over the course of the past decade on the benefit of his bundle pacing over conventional RV apical pacing. And again, like we talked about, there's limited data on the benefit of his bundle pacing for cardiac resynchronization. So that's why we're back here talking about this and how do we advance this field. So the tools, I think, one of the titles was talking about the tools that we have. So I'm just going to touch upon this. I have another talk that is dedicated towards how do we perform the implant, and we'll dive in a little bit deeper on that. But I just want to highlight some of the tools we already have and some that are about to come out within the next few months. Okay. So the go-to lead that we use at the present time, and the only reason we do this is because we have a lot of data with it. We only start using systems when we have a lot of data about safety and we know what the potential issues can be. So with the 3830 Medtronic lead, we have the most amount of data. It's been used close to 8,000 or 10,000 times, and we know what the limitations are, we know what the positives are. It's a lumenless 4.1 French lead, and the advantage that it's for French, so it does not cause a lot of stress and strain on the helix when it's implanted at the his bundle. And because it's lumenless, it requires a delivery sheath. The other thing also with this lead is that it has an exposed helix. So it is not extendable, retractable, it's an exposed helix, and so you have to rotate the lead body to get a bite into the conduction system. The delivery sheath that you guys are all hopefully familiar with is the C315. It has two curves. The primary curve, which is septal, the secondary curve, which points it towards the RV. The other sheath that we have available in the US is the C304, which is now also becoming obsolete because Medtronic in May of 2019 at HRS came out with the new sheath that we helped them develop, which is essentially just a minor modification of the 304. It's you can actually rotate this sheath with this knob, and it can get up higher on the AV annulus, but it also now has the septal curve. The original 304 did not have the septal curve. The disadvantage of this sheath is it's a much larger caliber. It's 8.4 French, so it's like a CS delivery sheath, and it can also cause more trauma to the conduction system. So we're a little bit careful. I only use this as a backup if the 315 fails. And so I know it's not available in India right now. This is still not the go-to for a lot of us. So newer tools, Boston Scientific just came out with their set of dedicated HIS delivery catheters. These are, aside from Medtronic, which again, the 3830 was not designed for his bundle pacing. It was designed for pediatric implants. It was first released in 2004, 2005 for implantation in pediatric cases. They got lucky with it because it works very well for his bundle pacing. No company has a dedicated lead for conduction system pacing as of date, and it's going to be years before that becomes the case. Okay, so all of the newer, everyone wants to get into this race because everyone realizes that there is a lot of excitement about conduction system pacing. So Boston Scientific came out with their set of delivery sheets. They have a range of them with different shapes and curves and lengths, and they recommend using their Ingevity lead, which is an extendable retractable lead for implantation at the his bundle. We have also tried to use the fine line, which is the sweet tip, as some people call it. It is closer to the 3830, but it does tend to get stuck much more in different parts as you're pulling the system back and forth. So we've tried to use the Ingevity more than the fine line. The other system that is about to come out is this Biotronic system. It is already available in some parts of Europe where they're doing some of their early work, and it should be coming out in the US by the end of the month, and I have some cases lined up with this. I actually helped them design these sheets. So again, this is a set of sheets, delivery sheets, to help implant their Solia lead, which is also an extendable, retractable lead at different parts of the conduction system. It's, again, I have to caution you. This is a word of caution for all of you who are interested in doing conduction system pacing. Please, please, please do not take an extendable, retractable lead and start pacing it at the his bundle or at the left bundle just yet, unless it is a non-dependent patient. unless it's a patient with sinus node dysfunction and you know they're not going to pace in the ventricle. We do not have any data on long-term performance of any of these leads. We are working closely with industry to do the studies so we understand how these leads perform. You have to realize these are bigger caliber leads, they're extendable, retractable helixes, their thresholds might increase much more, they might actually frankly dislodge. In fact, some of the early work, the work that Dr. Deshmukh study did, the work that Barbara Picardo study did, actually used extendable, retractable leads. Barbara Picardo did all their work in Spain with the 2088, the Tendro, the St. Jude Tendro. And that cohort of patients actually demonstrated a higher his bundle capture threshold, and they have never published any long-term data in terms of what happened to their thresholds and follow-up. So be very careful. You will be pressured by your industry counterparts that we have our delivery system now, so go do it. Please be careful. You do not want to have a bad outcome for your patient. So please do not do it in a patient that's dependent. Okay? That's just my word of caution. So yes, I'm showing you all these tools that are coming out, but I am not telling you that go and start using them right away. This is just some tweets. Deep, I wanted to highlight Deep is a fellow from here at Triple M who's working with Rajiv, and they've done some work with the Biotronic delivery system, and also Sergio Richter has done some work with the Biotronic delivery system. In fact, OASE actually recently posted a tweet on a patient where he did with the Biotronic extendable retractable Solia lead what we think might be a left bundle branch pacing. So again, not something I would recommend doing yet. We don't know what the long-term performance of this is going to look like. So again, when we do these cases, we actually use the PSA to look for your A, His, and V. And we'll talk about this more when we talk about how to do the implant. And then we also use our EP mapping system with filtered and unfiltered electrograms. And you can actually see a nice A, His, and V. The advantage of the unfiltered electrograms is you can actually see a His injury current corresponding with the His signal. We'll usually set it up where there's a set of injury cables going to the patient. That then goes into the EP pin box, and then from the pin box, you can actually slave it to the PSA. And then the most important tool, whether you're doing any form of conduction system pacing, whether it be His bundle pacing or left bundle branch pacing, the 12-lead ECG. Now, this was another thing that has evolved a lot. In the original descriptions of His bundle pacing, we used a lot of terms loosely, or we called it pure Hisian capture, para-Hisian capture, direct His bundle pacing. In our first paper, we called it direct His bundle pacing. And then over time, we realized that there are multiple people doing this, and everyone uses their own terminology, and we decided we need to come up with standardization. Standardization on how to report, standardization on how to perform, standardization on pulse widths, all of this needs to be standardized. How does the follow-up be standardized? So this was a consensus document we published in Heart Rhythm in 2017 with a series of experts, and we defined this as selective and non-selective His bundle pacing in patients with AV nodal disease and infranodal disease, and how that might differ slightly. So this is just a reference slide here. All right, so now let's look at the data. Fine, His bundle pacing looks good. We know that it can be done. The success rates have gone up, but does that really have an impact on how these patients do? So can this prevent some of those adverse events that we talked about with RV pacing? This is a table from a paper we published in Nature Reviews that summarizes all the data there is available on His bundle pacing for dual chamber systems. This was the first study we performed, and it was published in Heart Rhythm. This was when I was still a fellow with Dr. Vijay Raman. This was work done in 2010. And again, I'm highlighting. You always have to be aware. People can show you slides. I can make this look nice and pretty, but this is non-randomized. Okay? Everything needs to be taken with a grain of salt. There are no randomized controlled trials to date on His bundle pacing except for 2. And both of those, the maximum number of patients are 40. Okay? So what we did here really was we took two different sites in the same health system. One site, everyone got his bundle pacing attempted. The other site, everyone got RV pacing. And what we we found a success rate of 80% with his bundle pacing. And we followed these patients and we looked at those patients that were paced more than 40% in the ventricle. And what we found was that with his bundle pacing, very small chance of developing heart failure, while those that were RV paced, a significant difference between RV pacing and his bundle pacing when it came to incident heart failure hospitalizations. Again, the study was in no way powered to assess for mortality, but you can start seeing there's a little bit of separation of curves as you start following this cohort for a longer term. We then looked at their long-term follow-up, 5-year follow-up, and we published the long-term follow-up in 2017. We brought all of these patients back and performed serial echocardiograms. So this was their long-term follow-up. If you take all comers, whether they were implanted for sinus node dysfunction or AV block, you see that with his bundle pacing, the baseline EF is in blue and follow-up is in red. You see that the EF remains stable, while with RV pacing, the EF declines. Now, if you were to take those patients that were truly paced in the ventricle with 40% or more burden, you see that the EF declines even more significantly in the RV pacing group, but does not change significantly with his bundle pacing. So, at least as a cohort, there is no significant change in LVEF and follow-up. This was the largest series to date, which was presented as a late breaker at ACC in 2018. This was again Dr. Vijay Raman's group. And they took 332 patients with his bundle pacing versus 433 patients with RV pacing. This was work that was done in between 2013 and 2016. So 2 or 3 years of gaining experience with these implants. And you see that the success rate for his bundle pacing actually went up to 92% in this study with a much larger cohort of patients. And again, similar results, pre-specified endpoints of heart failure hospitalization, mortality, or need for upgrade to a bi-V pacing system. You can see that his bundle pacing did better than RV pacing. If you took those patients that were paced 20% or more in the ventricle, that difference or the separation between the curves was even more significant. Now, we talked about how RV pacing increases the incidence of atrial fibrillation. This is work that we just finished and is going to be presented at Heart Rhythm this coming year, in May. So just wanted to give you a glimpse of this. This is new onset atrial fibrillation amongst patients with his bundle pacing in blue versus RV pacing in red. And if you look at patients that were paced just 20% in the ventricle, look at the separation of the curves in the p-value. Okay, so his bundle pacing not just prevents pacing-induced cardiomyopathy, but also decreases incident atrial fibrillation. So that was for prevention of some of the adverse outcomes that RV pacing can cause. What about reversal of some of the potential issues that have happened with RV pacing or that occur with cardiomyopathy? So here's a case to highlight that. This was a 75-year-old gentleman. He's actually one of our CICU nurses' dad. He went to Florida and had some sinus bradycardia, so they put in a dual chamber pacemaker. He also had some history of atrial fibrillation with a low burden. So he gets a pacemaker, and then his daughter reaches out to me and says, I really want him to follow up with you when he's back here in Chicago. So I said, sure. So surprisingly, you bring him in for a device check, and he's pacing 89% in the ventricle. It's like your device was implanted for sinus node dysfunction. Why are you pacing the ventricle? His PR interval was over 400 milliseconds. So we paced, I switched him to an AAI mode. I said, forget the ventricular lead, let's just make you AAIR. And he started having AV Wenckebach. That's the issue when a patient has sinus node dysfunction and you don't pay attention to the PR interval, or if a patient is elderly and you don't pace them at a faster rate to see if they start Wenckebaching at 80, 90 beats per minute. They're going to require ventricular pacing. So this is what happened with him. This in blue on top is his trend of ventricular pacing burden. In green is his ejection fraction, and in red is his AFib burden. So this was when he got his device implanted. His EF was 60%. His AFib burden was only 6% in follow-up. And I made all the changes, and he had AV Vencubox, so we had to program him with, I programmed him with VIP. This was a St. Jude device, so that we can avoid ventricular pacing, and he still paced 99%. And his EF started going to 50 to 55%. His AFib burden started increasing simultaneously, then it dropped further. And so his EF continued to decline and his AFib burden continued to increase. So now what came first, the chicken or the egg? Was this AFib that was causing him to have tachycardia and worsening cardiomyopathy? Or was it pacing that was causing all of these issues? So we decided to control the AFib, put him on amio, hoping that that'll prevent AFib. He just couldn't tolerate it. So with a low EF, his renal function was borderline. We couldn't do Ticasin. So amio was the only option, and he couldn't tolerate amio. So then he said, can we do an AFib ablation? So we performed an AFib ablation on him. And after the AFib ablation, his EF still remained low. So we brought him in, and we said, what would you do in this scenario? Now you have an EF of 30 to 35%. And you've seen this happen. What would you do? Upgrade him to a BiV, right? That's what we always did. And some people in the US would actually upgrade him to a BiV defibrillator. They do that all the time because patients there don't have to worry about affordability. But you still have to put in a BiV device. It's still more expensive. So what we did here was, we took the old RV lead out, we put a new lead at the HIS bundle, and we called it a day. This was his bundle paced ECG, and that was his intrinsic QRS overlaid on top. The T-wave changes are because of memory from RV pacing. And this is what happened to his EF. So this is where the AFib ablation was performed. His EF remained down, and then we performed the revision to the HIS bundle position, and his EF is completely normalized. He's NYHA functional class 1. Okay? So this is a classic example of an adverse event from RV pacing and pacing-induced cardiomyopathy that completely reversed with just revision of a lead to the HIS bundle location. This was a paper we published. This was a multi-center experience between Dr. Vijay and myself. And we looked at 85 patients that had similar experiences, 79 of which we could easily reposition to the HIS bundle, even if the patient does not have an underlying escape, which majority of these patients do. If you wait long enough, if you leave them at BBI 30 and wait for a minute or two, you'll start seeing an escape coming through. And you can map the HIS. If you still don't have an escape come through, you can pace map and find the HIS. So that's what we did in all these cases. And what you see here is this is pre-RV lead implantation. This is after RV lead implantation. Their QRS gets really wide, and with HIS bundle pacing, it narrows down. This is their EF at baseline, which really declined down from 54% on average to 34%, and then with HIS bundle pacing went up to 48%. And this is NYHA functional class improvement after HIS bundle pacing upgrade. Okay, so this is what you guys can offer to your patients here, because this is all our patients can afford. That's why I think that this is where conduction system pacing can really help our patients here in India. All right, so that was pacing-induced cardiomyopathy. Now talking about what we just touched upon, which is diving into the case we're about to do, left bundle branch block, right? This patient is a classic example, 94 years old. She was my first consultation. 2016, when I first joined Rush as a new EP faculty, she was my first referral for a BiV, okay? And she's 94 years old. She's a non-ischemic cardiomyopathy. Her EF used to be 40 to 45% a few years ago, just like this guy. And her EF has declined now down to 20%. She has a left bundle branch block, and she has NYHA class 3 to 4 symptoms. Now, she's referred to me by a cardiologist for implantation of a BiV ICD at the age of 94, because that's what we do in the US. Okay, so not everything that happens in the US can be translated into our patients here. That is something you have to bear in mind. So the other interesting thing is she walks in to see me for consultation with 3 of her sons, all 3 of whom are physicians. So now suddenly that consultation goes from a 30-minute consultation to a 1 hour, 30-minute consultation. because my first job was to tell them, I'm not going to give your mother a defibrillator. Okay, and they thought that's what she's going to get. The other issue was she weighed 41 kilos. I could see every one of her ribs. So imagine putting a CRT defibrillator can in someone like that. That can's going to erode. Okay, so this is what we decided to do for her. Dual chamber His bundle pacing. This was her paced ECG with complete normalization of left bundle branch block pattern and a paced QRS of 90 milliseconds. This was her EF at the time of pre-implant, reported at 20%. 3 months post-implant, we repeated another echo, and her EF, after looking at multiple views, was reported at 50 to 55%. She's NYHA functional class 1. She's now 97.5 years old and is still functional and walks in to see me every year with a cane because of rheumatoid arthritis. So, His bundle pacing for bundle branch block. Again, because we're talking about the evolution of physiological pacing, I just thought this would be a nice one to show. So 1977, this was when Dr. Narula first reported the concept of longitudinal dissociation. What is this? It basically tells us that there are fascicles within the bundle of His that are predestined to become the right bundle branch block and the right bundle branch and the left bundle branch. And disease is often localized within those fascicles. And how did he show that? With multi-electrode catheters, closely spaced multi-electrode endovascular catheters that were placed along the right side of the septum, recording multiple hisses. You pace the proximal poles, you don't narrow the QRS. You pace the distal poles, you narrow the QRS. Because you're distal to a site of disease that is actually within the His. So the disease is often localized within the fascicles that are about to become the right bundle branch or the left bundle branch, and these fascicles are often dissociated from each other within the His bundle. So he first described this in 1977. 1978, El Sharif performed similar work and shows that yes, Narula was right. This happens. Then it was not until 2005 the first case of actual correction was performed with the St. Jude tendril and was published in PACE in 2005. In 2010, Dan Luskarten reported a series of small number of patients in heart rhythm, showing that 9 patients with left bundle and 1 patient with right bundle with a 90% success of narrowing with His bundle pacing. Then in 2013, like I said, Barbara Picardo did some work with the tendril lead and showed that you can narrow left bundle branch block. And not just that, these patients demonstrated improvement in their LVEF and improvement in functional class. But again, a very small cohort of patients, just 9 patients. Now see how this field has evolved. 2015, Dan Luskarten. This was the first randomized controlled trial on His bundle pacing versus bi-V pacing for CRT. In 2015, Dan Luskarten studied 28 patients. Unfortunately, only 12 of those patients completed follow-up, and it was beautifully designed study. These were patients that all got an LV lead and a His lead using a Y adapter. He plugged it into the can, and then each patient acted as their own crossover. So for 6 months, they got bi-V pacing, then 6 months, they got His bundle pacing, or vice versa. And he demonstrated that whether you had His bundle pacing or bi-V pacing, both of those cohorts did really well when it came to response rates. In 2017, Agiola did some work in heart rhythm where they looked at, can we actually perform His bundle pacing in lieu of a failed CS lead, and demonstrated that they were successful in doing this in 76% cases. Now you have to realize some of these studies that report success rates of 75 to 80% are not very carefully selected left bundle branch block patients. They include a lot of IVCDs. Santosh showed you a study from Rod Tung where he showed that disease is distal and you may not be able to narrow it. That is patients that have an intact Purkinje activation, suggesting that this is not a true left bundle branch block, suggesting that it is an IVCD pattern. It's intramyocardial disease or delay. So in carefully selected cohort of patients, you can get a much higher success rate, but you really need to do that due diligence. So then we did a lot of work we reported our first series multi-center experience in 2018. This was 106 patients with 36 patients with left bundle branch block, 12 with non-left bundle branch block, with a 90% success rate, and I'll show you this paper in a moment. We then also reported our experience with his CRT for patients with a low EF and right bundle branch block. This is a unique cohort of patients. Right bundle branch block will not benefit from CRT, but his CRT seems to do very well for them, and I'll show you that data as well. And then Dr. Wong published his data again in Heart Journal in 2018, demonstrating a significant improvement in EF and NYHA functional class. And then Arnold did some acute hemodynamic work that was published in JACC in 2018. And then Dr. Vijay Raman published in CIRCE on heart CRT. And then there was another study that was published that's called his sync that I'll show you as well. So this is really all the data there is ever since. Sure. We'll pause. Let's see what they're doing in the lab, and we'll come back to this. Are we going to be able to hear them, Ullas?
Yeah, hi, Aparna. Aparna, you're taking control or no? Aparna. She can't hear me. Yeah, so who can hear Aparna?
Yep.
Yeah, I think, no, she can't.
So we have the hookups for this one?
Yeah.
Is it connected
Santosh-
to the Pruka or is it connected to the analyzer?
Santosh, we can hear you. Can you?
Yes.
Oh, great. Hi, Santosh. So, Aparna,
Yeah,
taking control?
absolutely.
Oh, great. So, okay. Aparna could not be heard because I don't think Mike is with her. Santosh, you can speak to us. I think we are listening.
Okay. Okay.
Can't you hear me?
So how are we connecting this? Okay.
Santosh, you can speak to us.
Okay, so we have a RA lead.
His mic can be adjusted a little bit. His mic.
Can you hear me now better?
Oh, much better.
Okay.
Yeah, go ahead.
So we have the RA lead in the RV as a backup, just because it's a left bundle branch case, and when we are doing his or left bundle branch area pacing, you might develop transient, you might damage the right bundle and result in complete heart block. So we have the backup pacing, the RA lead in the RV for now. We are trying to get his bundle lead now. So just a question, is he hooked up to 12 leads or is it just the 5 leads? 12 leads?
We can hook up the 12 lead.
Can we look at the 12 leads? This is unipolar. We are advancing his lead now through the sheath. Fluoro, please. So you can see my his sheath is just in front of the his catheter. So we'll try to record a his.
Yeah, Sabri could bring in his bundle signals there on
Can I
the
see the
12 lead.
signals?
At the 12 lead.
Oh. There's no screen in front of us. Okay. Yeah, so just put the left bundle or his recordings.
So we can bring both of them, unfiltered as well.
Yeah.
And then can you bunch up the ECGs on the top and leave some room for the filtered, unfiltered on the bottom?
Let's see, you had a very good hit bundle in the previous one, the yellow color one. That's what. So he wants that. He wants.
No, that's, I think, I'll just look at my signals from the 3830 lead. How is it now? Do you see anything? No, 1 second, that's my bad.
You're disconnected.
Here, it's hooked up uni now.
There's a hiss.
So there's a his. Why? So we are at the his location. So why don't we pace and see?
So one thing is when you see a hiss, then we
There's
normally
a-
synate, just so
Yeah.
you know where you are.
Farik, I have the his bundle
catheter, but
lead
you
there.
don't always have that.
Yeah, we have the his catheter there.
Can someone measure that
So
HV
why don't
for us?
that's Farik made a good point. Why don't we see and just save the reference this spot as his spot? Okay, we'll save this as a reference. Okay, and now let's pace at 5 volts. So what are you pacing at now? I know, what output are you pacing at? So phi at 1, it looks like we have selective capture without left bundle branch correction. Do you agree, Parik? You see the stem
Yeah.
followed by a latency. Pace at higher output. Are you pacing at 1 millisecond pulse width? Yeah. Okay. Pace at higher output.
Go to 10.
10 results in some narrowing, but still. You see the morphology?
What output is this?
This is a 10 at 1.
Okay, yeah, this looks narrower. So can we go off pacing for a moment? The one important point here is you always want to start, before you start pacing, you want to measure your HV interval. Okay, so let's go off pacing and measure our HV here.
I think, Parik, you want it to be distal. So the question is, what's the point of measuring HV interval?
So if the HV interval is very long, then you know you're going to be proximal to disease.
Yeah, you see the A too, so I'm a little bit more proximal, I believe.
Yeah,
Right, you see the
so
A, his, and V.
Just
so
just a teaching point, but because just if you see a hiss does not necessarily
Yeah.
mean, even if this patient doesn't have a left bundle branch block and the QRS is narrow, that's not a site you may want to accept because it suggests that there is still disease distal to your lead. So you want to go distal even if the QRS is narrow. In this particular case, we're going to go distal to see if we can narrow the left bundle. But in a narrow QRS, you may still not want to accept this spot with a
Yeah.
QRS, with a HV interval of 75-80 milliseconds.
So you want me to just, I can go slightly distal
Yep,
and see what we get, okay?
yep.
Off pacing, please. Yeah, output is high, and so that's slightly distal. What's the electrogram looking like there? Yes.
It's not that different.
There's still, I see the A. I can go a little bit more distal.
Yeah, so I would just extend the lead out a little bit further. It's okay.
There,
We're
that's a
already-
little bit more distal for sure. Pace. I don't see the his.
It's not as superior because
Yeah.
if you think about the conduction system, you're going to be running
Slower.
superior and anterior. It's not going to be at the same plane. So you got to go higher and more anterior. So there is.
Yeah, you got a his here. How much is it?
So I'll just clock and extend your lead out here, Santosh.
HV is bad here.
No, pull the lead back in, then clock and then extend it out.
I think I'm fine. with
There's
that.
AV block.
Pace. We have
Let's
a backup
pace here.
pacing, right?
Pace.
How come we didn't pace with the? But is it pacing though? No, it came back now. Okay, we can raise it up to 50. That's fine. 50. Yeah.
Yeah, so you were close to the conduction system there. This HV is long again here.
So Parik, you want me to try further higher up?
Yeah, so what I would do, Santosh, is pull the lead in, clock the sheath, and then as you clock it, it'll point superiorly and just extend the lead out you might find a distal portion of the hiss. The idea is just to, you have a slight hiss there that might be shorter. I don't know if that's real.
Yeah.
See that?
Yeah, that's distal.
See that? That's a short HV.
Is it like split
Can
there?
you update and measure that HV, please?
Is there a split? No. No, is it split there?
See that? That's an HV of 45 milliseconds.
Very. Do you see a split there?
Okay, now can we pace here? You're not as stable because it's not present on every beat, but at least we might see a narrow beat. So pace at 5 at 1.
Slower, please, once. Just a second.
Did you move?
No. It's like at the valve. See that how it's jumped?
Go to 10.
Yeah, I clogged a little bit and pushed forwards. Yeah.
Go to 10 volts.
So that's 10 volts. So we still have selective. Oh, that's
No, it's non-selective.
Yeah. This is not. It's myocardial.
Okay. So, I mean, we found a distal site with a shorter HV interval, which is almost 30, 40 milliseconds shorter.
Off pacing, please.
And we've still not been able to overcome. So this, like we suspected, this disease might be just distal to the distal hiss,
No,
or
we
at the
have
junction
it.
of the hiss and the left bundle. And that's where so in this particular case, we might,
Okay.
you could do a little more mapping more superiorly and see if you find something. I would even, sometimes I shouldn't say this, but I play darts. So I actually push the lead in different angles to find, in the general vicinity of the hiss region, and see if I can find a spot where I can narrow. So
Then why did you hesitate to say that?
Throwing darts on the conduction system is not something I would like to
Right.
say.
No, but that is what we are doing. We
I know.
are we are achieving this by really screwing it up.
I know, but I'm still respectful because I'm
No,
very
but then
passionate.
you screw, but still you tend to be respectful.
I think it's at the valve. It's like just moving. So
No, that's how is this technique.
Okay, Ullas, this is supposed to be a PG conference,
No,
okay?
no, I thought you don't screw in the lead.
I think so we had.
No. What I'm trying to say here is, we went so far great. We crossed the kind of a block at the Hessian area. At this site, I really would like to play around. In fact, I would like to screw.
You could
and then-
actually, Santosh, if you want to, if you can get back to that distal location, maybe get a little bite into tissue.
Exactly.
Might
You see, I
stabilize
think we
it and
need
be
to be,
able
you
to
know,
give you.
doing
The other thing
something
you could
there.
also do is we could pace map at 10 at 1 and see if there is any narrow beats anywhere you map.
And I have a question here. You see, pacing at 10 without actually getting into the tissue, okay, is different than just pacing at 10.
Well, no, to be honest with you, if you're making good
That's
contact
slightly
with the
higher.
septum, then you all
Yeah, it looks
you
like
always
split hit.
the
That's what I was
threshold does
wondering. Is
not
there a
change
split?
dramatically. I'll tell you that.
Yeah, I mean,
Even after screwing it in, it might change a little bit, but it doesn't change dramatically. Maybe a half a volt here or there.
There's a hiss there. My only problem is even with 5 volts we couldn't correct it. So I think at this point I would have moved on to left bundle.
I know you're itching to.
But I can try more up here. That's slightly.
Can you get a little bit superior to the distal pole of the hiss catheter? Yeah, somewhere there. Can we pace here?
Yeah, it's still long. Yeah. It's still, I think.
Show me where you are fluoroscopically.
Flora, please. No. It's gone.
So advance the lead out there. Advance the lead out there.
There's a complete heart block.
That's okay. Pace here.
There's the infrasian block there. You can see AH. No. Still.
Okay, you can pull the lead back and you'll slowly up and down. Yeah, so another thing to do here would be go even more superior, and if you don't find any other spots, then move on to left bundle branch pacing. So again, like we suspected based on
Off
the
pacing?
ECG here, I think this is going to be distal his or proximal left bundle anatomical block in that anatomical region based on the ECG.
That's a even longer his. Look at that.
Yeah, that's a much longer HV, but that could be mechanical trauma as well.
Is there a Venkibach, infrahisian Venkibach? I see the HP prolonged and now it's shortened. See that?
I haven't seen a drop beat yet, Bob.
No, it looked longer before, and then it. Yeah. Okay. Left bundle. So.
Ready to move on?
So here the consensus is to move on to left bundle. Okay. So for the left bundle, usually we save his reference. From there, you go like a 1.5 to 2 centimeter distal at the basal septum. And then we're going to pace map and look for ideal morphology. No, not in the beginning. Okay. Off pacing? Oh, sorry. Flow? So.
Can we see a little more of the apex of the heart?
Yeah. So there, clearly I'm distal. Okay. Yeah. Sometimes you can get it off floor. You can get it on the anterior septum. Sometimes you can also get it on the inferior septum. Okay. So here I'm at least 2 centimeters. I want to look at the morphology. Why don't you pace here once, please? Can I?
So change your pulse width to 0.4.
0.4. It's capturing. So the notching in V1, we don't see it all the time, but what I go by is the inferior lead and the AVR avial discordance. I want to be negative, avial to be positive, which I see it here, and lead 2 is taller than lead 3. So that's like your parahisian PVC, right? Yeah, so you have inferior lead discordance, AVR avial discordance. So I would try at this spot. Now agree, Parik? So the discordance tells you are not in the outflow tract. Sometimes, just by pushing, if it gets slightly higher, you might be in the low RV outflow tract, and when you pace, you get outflow tract morphology, where you see 2, 3 positive, AVR, avial completely negative. If you think that's like 2 centimeter distal and just screw it in, you'll get a narrow QRS, but it's not true left bundle capture. It's going to be septal pacing. So the way we've been doing is we actually color code AVR, AVL just to clearly see when we are doing this live. Once it's discordant, either sometimes you see a notch in V1, sometimes you don't see it. Here I didn't see it, but can you pace again, please? So you can see the AVR, AVL discordance. Can you gain up the AVR, please? Gain up AVR and AVL once. There. So the AVR, AVL is discordant and lead than lead 3. So if we think about parahisian PVCs or PVCs coming close to the his, this is how the morphology is. You have inferior lead discordance, AVR, AVL discordance. So we've been going by this more than, okay. So I like the spot. I'll just give one.
What's the impedance?
I'm just going to give one turn, Parik, and then, wow, these gloves are very sticky. I can't even turn them.
So Santosh will go through step by step on how to do this in a little bit. I'm sure some of you have already done a lot of this and seen a few cases.
Can I get another pair of gloves?
So at this point he's going to change his gloves because you really want to feel the lead.
Is there an injury now there? Do you see any injury at all?
There is injury on the V there.
Okay, good. Because I just gave one turn just to get a spot. It should be on the analyzer.
What are your R waves here?
Pace again?
What are the R waves?
That's fine. What are the, can you pace again? 658. So when a pace, I just gave one turn just to get the spot, and then pace and confirm we still have the AVR, AVL discordance. Sometimes when you are doing this, you can jump into the outflow tract. So it's better to confirm it. And the baseline impedance is what? 650. Okay. So now I'm going to give 4 rapid turns. Thank you. Floor. Oh. So in RAL, No, that's good, that's good. So I'm going to give 4 rapid turns here, okay? Flow, keep flowing. 1, 2, 3. There is some buckling, you see that? So that sometimes when you have fibrosis of the septum, you can see the buckling. But let's see, pace here. What's the pace impedance? It didn't go up much, right? So off pacing, Flora. So I'm going to try to adjust the sheath so that it's perpendicular to the septum. There. I have a little bit of counter on the sheath, and then I'm going to give a few more turns here. See, the problem is when I'm giving turns, you see how the lead is behaving? It has gone forwards, but it's like there's a bend. It tells me that usually if it's a muscular septum, it should just go like a cheese, like it just goes in. But the fact that it's doing it, I know it's more like a fibrous. No, let's pace. Yeah, look for the potential, but we can confirm in LAO too. Pace. What's the impedance? So the impedance went up a little bit. Now you see a notch in V1.
What's the impedance? We can hear that.
So the impedance usually as you go deep into the septum, it goes up. You know, if it's 600, it can go up to 700, 800. And then as you come close to the left side of the septum, it actually starts dropping by up to 100 ohms.
What did the impedance go up to, Santosh?
It went up from 630s to 690s, okay. Not much. Okay. I'll try a couple more turns, okay? So the QRS is still wide. I'm looking for a QR pattern in V1 or a right bundle pattern.
So, Santosh, I think you are not pushing the sheath.
Yeah. Okay, show me Flora. I'll get the sheath close to the septum here.
Yes.
You can have someone hold on to the torque on it too.
Yeah.
That'll help.
Yeah, the sheath comes back. I think it's just the pace again. Any change in impedance? So the impedance is not changing. So I know I'm not just. Yeah, but it's not going in further. Flora again. You want to hold this sheet like this? Yeah, counter. So we have some counter on the sheet.
But the other thing that could help is looking in LAO.
Yeah. See, the problem is, see that how it's bent? We can check LAO once.
No, get your sheath up further and then check LAO and hold on to that torque.
See, it's not going deep. You can see it's just hanging, yeah. And it's not perpendicular to the septum. And this is a good, this counter. Hold the counter, please. I'm going to try Flora. See, it's not going. So that, and I have a lot of backspin, so that tells me it's fibrous, and it's. So at this point, I think it's pointless to
take. Make a suggestion, Santosh?
Yeah.
So one of the things that we've observed is that if you just mark the hiss and you just move forward a centimeter or two, you can get stuck in the tricuspid valve chordae, and that's why the lead won't go through. And you can also pin the tricuspid valve leaflet. So one of the things I've learned to do is go all the way into the ventricle and then pull back, so your sheath and lead are free of tricuspid valve.
Okay.
And this guy didn't have any scarring on his MRI, so maybe that's what the issue could be here. So
okay, so let's. I'm going to take off from this spot and then go a little bit more distal. Okay, go back to RAO, please. So when we are repositioning, it's always that's good. That's good. Repositioning, it's always better to take the lead off completely. Make sure there is no tissue. Usually you'll have some tissue. Just clean it up. Is that saline?
Yeah.
We can flush the sheet too. But yeah. We usually don't connect. Yeah, that's fine.
You are not going to be flushing the sheath?
Yeah, that's fine.
You can attach one tri-way there.
Yeah, it was there actually. I removed it. Sorry.
Yeah, so you know what? He tried at a position. He actually screwed it. Okay, some total of 12 turns, if I counted properly.
Yeah.
So, you know, there must be a tissue there at the screw. Yeah, so then, you know, you cannot just go with that tissue to another place. And the largest of the chunk that was removed, I think it was mine, which was shown on the Twitter.
Mm-hmm.
Or you had a larger chunk
I've
than
taken
that?
larger.
No, I was planning on showing that, but
I would still bet on the fact that that's tricuspid valve.
No, that is proved. But you know
there
what,
is
I designed
tricuspid
in
valve.
such a way that it looked like a
so
conducting.
I went a little bit more. So see, now I'll show you. So this one we think it's good, but I think it probably is in the outflow phase here. I'm just guessing. It could be low outflow. I'm just guessing. It's actually not. AVR-AVL is discordant. So that's good. That's looking good too. Pratik, I think the location-wise, it's definitely slightly higher than before. We have AVR-AVL discordance, and then probably mid-septal area. So I think we can try here. You agree?
Yeah, sure.
Okay. I'm going to just give one turn here again. The gloves get so sticky. Okay. Pace here, please. Yeah. So again, you have AVR-AVL discordance. What's the impedance, please? 625. So I just gave one turn now. Okay. Now I'm going to try to adjust the sheath, make sure it's perpendicular, and then give 4 to 5 turns. Okay. Off pacing. So he's pacer dependent now. He's backup pacing. Slower, please. Oh, it did jump or
Yeah,
it
looks
moved?
like you moved.
It moved. It moved. It didn't take a bite. I think Flora, please.
Parishad, you tell me what are the implications of observing higher degrees of the blocks
Okay. Pace here,
during the
please.
manipulation? For example, this was the LBBB. Then you went distal, you injured the right bundle. So is it prone for long-term disease?
Just wanna
You
make
know,
sure.
when even if you corrected the left bundle, does it say
No,
that
I'm used
maybe
to.
tomorrow
You know, we
you
can
will have
check
a
in the
right
beginning.
bundle
I would check
disease?
just to make sure you're not
Are there
in the-
any kind of
I just want to make sure. See this.
information you can get observing, you know,
There, I think I
intrahysian
got a bite.
prolongation,
The gloves are sticky.
some
so
kind of a
just-
newer QRS complex is coming,
Flora?
dependence on the pacing for a longer time.
Pace, please.
What do they suggest during the
Right.
procedure?
So there's some data on this. So
sorry.
intra-procedural AV block or right bundle branch block can be observed in about 7% of cases. Intra-procedural, that's
Discordant,
acute.
Yeah. So what's the impedance now?
The
Okay.
majority of these will resolve by the time
Yeah.
the end of the case or within 24 to 48 hours post.
Okay. So now I'm
They-
gonna just counter. it a
In less
little
than
bit.
1% of cases, you will still
Do you
have
mind
some
holding it
AV
there?
block after
Now-
the patient leaves
So the most important
lab.
thing I've learned is like the gloves.
And
have
majority
to
of
be
those
clean.
resolve in follow-up.
Yeah, and you can feel
There
it.
was a
Flora?
recent case report that I reviewed of two patients where they had persistent AV block 18 months post. But both of those cases also had a threshold of less than 0.5 on the His lead. So it's a marker of the fact that you're in a very good location of the conduction system, but we do not like to have that. I know that Dr. Wong, in his early experience, when he used to try and pace the distal His, he would screw the lead into the distal His. used to see complete AV block happen more frequently. And there is something, and we'll talk about that. I'm going to talk to you a little bit about left bundle branch pacing, and that will tie in nicely with Santosh's anatomy talk as to why we only go in certain areas with left bundle branch pacing and why we don't go superiorly. That's important. When you think about the anatomy, it really answers that question for you.
Getting narrow. So you can see now it's like more of delta in V5, V6. So I think it's getting, we need more depth. That's basically it. What's the impedance? Okay.
Santosh's mic need to be readjusted, please.
Yeah, Flora? Can you hear me now better? So I think we just need depth, it looks like. So we'll see if I can, if patient is coughing.
This intraprocedural trauma which occurs, how do you avoid that? And is it only 7%? I think it is high. Maybe for our side, yeah.
From my side, much more.
I think that went further. You guys appreciated that?
So it all depends on your level of experience. If you're early on in the course, then it might be a little bit higher.
It's getting narrower. So
and again, as
I think
said,
at this
Dr.
point,
Long used to see 20-30%.
you're getting narrow. I think we just need the depth. What's the impedance? So the impedance is going up. You can see the morphology is changing. It's getting narrower. So I think we just need the depth here. Okay. I'm just going to try a couple more turns. Flora?
Just make sure that you're nice and perpendicular. So intermittently, I would look LAO.
You want me to look LAO? I think there, see, RAO is good.
It's looking up now.
Yeah. I just can't feel the torque with this gloves. It's so sticky. Do you have, yeah. 1 second. Flora? Flora? That's good, that's good, that's good.
Yeah, it looks like it's moving
good.
forward.
How many you get? 2 or? Okay, that's good, let's see. There. So you're getting narrower.
Yep.
What's the impedance? Okay. We just need some more depth. Yeah, sure, let's do it. Let's check LAO.
So it's not just getting narrower. You pay attention to V3 to V6. They're all pretty much positive. So that's the other thing. Sometimes, depending on where you are, you may not where the level of block is
different
too.
gloves like a non-sticky, like the green one?
One completely flipped,
Huh?
but V3 to V6 are completely positive, and the QRS is narrower overall.
See, I think, look at the previous, his bundle lead, and now you feel so good. So you are touching the spine on the LAO.
II down.
Yeah, and then, I think he would be probably settling there. He has to probably push the sheath and then screw there probably.
Yeah, I think he's already through to a great extent. Just maybe a turn or two more.
And now, I just was wondering. Tell me, how about in a difficult situation, pacing the left ventricle, and then trying to get that left bundle potential? How often you resorted to?
Pace the left one. You mean LBBP?
Yeah.
How often do you see a left bundle branch potential?
Yes.
Okay, let's get the sheet.
Different series have reported it differently. I think the range is probably between 40 to 60%.
Correct.
You do not see it.
No,
it's not like a his bundle potential.
Yeah, you see, just tell me.
This is better, actually, way better.
Take that because when I had tried, even in normal patients, not for the pacemaker, I just was wondering, should we be getting that?
I can feel the difference. Like
in any patient
to
who is
use
the EP study, it's so very hard. Why is that? Is it because again the delay is so much that it gets into the QRS, local QRS, and that's why we don't see? What is this? Why 40-60?
Yeah.
Why it should not be the?
So it's getting narrower.
For, the point
what's the impedance?
One of the reasons why it is only 40 to 60% is because these studies report mixed patient cohorts.
So the impedance is starting to trend down. So right. So it went from 7. Yeah. So it's not yet.
Santosh, we can only hear you, so we don't know what the impedance trend looks like.
So the impedance was 730s, now it dropped to like 630s, 720s to 630s. So impedance is coming down. So that tells you I'm getting close to the LV side.
How about we look at
pacing?
How about we look at the LVAT at different pacing outputs?
Yeah, we can do that. And can you show me the injury current? So I'm just looking at the injury current. If you're through and through, the polarity will reverse. What is this potential I see on that? It's still in the QRS.
Well, we don't know. If you pace your His catheter, you might know. You see what I'm saying? You have an EP catheter, which is a His catheter. You pace that. If you can, at a high output, if you can narrow the QRS, that's the only way to know if it's a left-sided potential.
Yeah,
With
it's
left
still
bundle
within the
branch block,
QRS though. Pace the hip. Oh wow, look at the hip.
That HV has gotten very long. I don't think you're going to narrow it.
Maybe it has
Pace
come
the his at
proximal.
high output.
It has come proximal.
So the conduction just recovered. So I still think there is some mechanical. It was complete block a minute
No,
or
no.
two ago.
Maybe because that could be both. Because the A was bigger now. Earlier it was less.
So we are trying to, we're going to pace the his now. But I think whatever the
You're not
fraction.
unless you narrow the QRS, you won't be able to pull the potential
Yeah.
on the left side over, so you won't be able to appreciate.
It's wide. We cannot narrow it.
Yeah, so it's not going to help us.
So what we can do is we can check LVATs. Why don't we pace the left bundle lead at 5 volts and go back to the screen with 12
12
leads.
leads.
So that's 5 volts. Now, can you measure from the stem to the peak of R wave in V5? Looks long. V5 or V6, lateral leads. Stem to the peak of R.
That's really long.
Can I see it?
150.
Can you show me the monitor? Oh, it's here. Oh yeah, yeah. It is 150 per. It is very long.
Okay, let's pace at 10.
How much would you accept?
Below 80 is better. 75, yeah. Yeah. What
that
is that
10?
now? What is it now? Measure, please.
Yeah, looks a little lesser.
Okay, so I'll try to give a couple more. Why is there like a latency? You see in V5, V6, V4?
Definite latency. So again, you are proximal to the block.
Proximal?
Yeah, because such a latency, it tells you that you are still not overcoming
Yeah.
the level of the block.
Unless it's a combination with the
Floral?
myocardial disease and left bundle branch block as well.
It
So
could
that's
very
the
well be
That's
both.
probably the possible explanation.
See,
I'm going to give a couple more.
so what is
One second, let me get the sheath close to the
But now that's myocardial
Yeah, okay.
filament is there. So that also will come.
Dr. Parikshit, how much the upper limit we can accept that watt?
So
80?
typically we say anything more than 80 or 90 milliseconds might be too much. In patients that have left bundle branch block, it tends to be longer. In patients that have a narrow QRS, it tends to be 50, 60
Still
milliseconds.
long.
Thank you.
So anything more than 80, 90 milliseconds, that means it basically means
No.
LV lateral wall is taking that much
AVL
time
is
to be
positive.
activated. Like we say, right, QLV more than 190, 100 milliseconds is too long.
Yeah, you just need a gain
So
up.
same way, same concept applies to LV.
So I gave a couple more terms. What's the impedance now? 290? Show me the R wave polarity signal. You're able to capture it. What output were you pacing? So it's still positive. Yeah. So let's, we're going to try ring pacing to see if it captures.
No.
Yeah. What output are you pacing at? It's at 5 at 0.5. So the ring,
Yeah, I don't think it through, Santosh.
yeah. So it basically, if the ring is capturing, at least we know the ring is close to the septum or in the septum. Now it's not capturing, so I don't know if we don't have enough depth.
Can we get an injection and see when
Yes.
Yeah, we can do that.
Yeah, so we have
So the point that he's trying to make here is, are you too
Let's get
far
some
in?
contrast.
That's one concern that you might start having. But if the ring electrode is not even capturing, the ring unipolar is not even capturing, that means
Yeah,
the ring
come
is
back,
not
Alan.
receptive.
Get me like 2 cc's of contrast. So we're going to do a contrast shot.
So here in
Yeah,
LAO,
that's fine.
he's
2
about to
cc's.
do contrast.
I think, I feel like, is the impedance again, check the impedance again. Is it Roy?
Yeah,
Yeah, I'm not sure you're
it
through.
requires few more
I,
times.
I think it
Yeah.
might be,
Good. Now let's do it.
you
I
might
don't
be
know.
halfway
There is
in.
a sheet a little ahead.
I think I pushed it. I can push it more.
Floor,
Floor?
No.
Yeah, it's at the ring. Okay, keep flowing.
For
Fin it,
contrast
please.
shots, you want the
Fin
sheet
it.
to be back a little bit.
Oh yeah.
We are deep.
Now we're deep.
Can you play that? See that?
Yeah, it is.
Not in the.
Why is your ring not capturing?
I feel like the ring is close to the septum now.
Yes, but then your sheath is on top of the ring. The tip of that sheath has to be pulled out in case if you want to test, or push it further and then maybe 1 or 2 more turns.
Yeah, Flora,
What-
please.
What was the last impedance?
300.
See, the sheath is now back
Yeah, so
behind
now
the.
you can check for a while and then.
Can you give me 2 more cc's contrast? Pace the ring. Usually it should not drop that much.
Yeah, so you do not want to have the sheath up against the lead as much as possible when we
So
inject
there,
the
it's
contrast.
capturing now.
Yeah, see.
So the
it's-
ring is capturing.
Yeah, so because earlier it was insulated.
Yeah, I think it was
ring.
covering. The sheath was covering the ring. So what about now? Tip pacing.
Oh, nice.
Yeah, the LVAT.
So, Santosh, the LVAT is long here, the QRS hasn't, it's
Yeah.
narrower, but it's not ideal.
Yeah,
What are you thinking?
that's the bipolar capture. Again, I think it's wide.
Yeah, I don't expect bipolar to be any better.
Yeah.
If anything, it'll be worse.
So I think I can give one more turn and see. I don't think we are through and through because we are capturing the polarity is positive.
Do we know his interventricular septal thickness on echo?
Yes, so it was like normal in the sense maybe about 10 millimeters. That has been recorded. Of course, this is a non-ischemic cardiomyopathy.
And again, yeah.
So you know what? I think the shot showed that there is a room for another 2-3 more turns.
Yeah. Okay. Yeah, I agree.
What was the
Yeah,
impedance,
the
Santosh?
impedance, I don't know if it dropped by like 300 points. I've seen at least
Pace
4.
again and give us an impedance now because you're not covered. Let's see.
300.
What is the upper limit of septal thickness? We can go ahead safely.
There's no right answer.
Yeah, there's.
We've done septal thickness of 0.6 and I've done septal thickness unknowingly of 2.8 centimeters.
But the fact that we are not
It
getting.
was in Vietnam. They didn't tell me.
I think
I started doing it and I was like, what's the septal thickness? 2.8 centimeters.
the fact that we don't have like a QR or a short stream to LVAT, it tells me that we are still away from the.
What was the
left
impedance
side.
there, Santosh? Just
The
now?
impedance is like 300s. Yeah.
I'm debating just pull it out and start fresh.
I think we have a good. I feel like we have a spot, but we just need the depth.
I think you're deep enough. To be honest with you, you're perpendicular to the septum. Your tip is 1.8 millimeters. Tip to ring is 9 millimeters. This is a 1 centimeter septum.
Yeah.
You're about 1.2 centimeters in. The impedance is dropped. You still have injury, so that's a good thing. But I think I would try one more spot.
No, you may not even give one more turn. I think we should stop.
No, that's what I'm saying. Pull it out and try a different spot.
Yeah. One more
You want to do that while I finish my talk, and we can come back to you, or what are you thinking?
Sure.
Yeah.
Yeah, I think,
We'll wrap up my talk, 10 minutes or so. You give it another try, and then we'll see what it looks like.
Okay.
Okay?
Sure.
All right.
Thanks so much.
We can do it, but hey, Parik, are you there?
Yeah.
So we have a question. Why can't we try one more turn here?
There's no downside. You'll go into the LV, but what's the downside? You can take it out.
There is no downside.
There's no downside.
Yeah.
No, I don't disagree. But the impedance is 300. If that's real,
I don't know if
that's already telling you you're through.
But there is no, the threshold is still capturing, the R wave is still
Yeah, I'm not disagreeing. I'm just saying I would not leave this.
Yeah.
I'm not going to accept this as final because tomorrow this lead will dislodge.
Yeah.
So that's the reason not to accept
I'm not going to accept this, but I'm going to try one more turn, okay?
But if at a higher output also you are unable to capture the left bundle, then does it make sense to
Maybe we
give
can
one more
I think we are nice deep. I think we just need
The
more some more
LVAT here
depth.
doesn't look good.
No.
At a higher output, I would expect the LVAT to get shorter
And
if I was
still
not deep
capturing,
enough.
then probably we should try some other.
No, you're capturing, but you're not capturing conduction system.
Yeah,
You're right.
yeah.
So I mean that would happen if you would pace at 10 volts and you see what you want to see, then you screw in further.
Yeah.
I agree. So nothing changes here, which tells me it may not be the best spot to continue further at anyways.
One thing more I wanted to ask you and Dr. Chanmugh.
Parik, should I go ahead?
When we do the LAO check shot to see this, first of all, it doesn't look completely LAO because his bundle lead is looking obliquely. So it's not looking perpendicular. So it could be deceiving that because of the obliquity, you might think that the lead is inside. Actually, it is not that much inside. So what is the validity of doing check angio for all left bundle pacing? Because I don't do it in all patients.
So whenever you're giving a contrast of at least 2 to 3 ml, it is going to delineate the septal margin. So at least you will know how deep the lead is beyond that septal margin.
If you're oblique, you will be just having
that is what. So for that, you need to know the measurements of the lead.
I think sometimes
for
with the
that, you need to know the measurement of the lead. So lead 1.8 millimeter plus 9 millimeter will be around 10.8 millimeter. So proximal to that anode is around 10.8 millimeter. So here the contrast is just staining the septum where the anode is touching the septum. That means that at least 10.8 millimeter of lead is inside the septum. Of course, you need to have a perfect LAO to see the exact depth of the lead.
Pace, please.
But if you know the lead dimension exactly, and if your contrast staining is exactly staining the septal margin, then it is good. Here, though the sheath is a little bit away from the septum, but still it is delineating the septal aspect perfectly. So at least by that you will know how deep the septal lead is.
What are you pacing at?
The ring?
What are you pacing at? What are you pacing at output?
Are you pacing the tip or the ring?
Tip. I think, the impedance further went down.
You're through. You're not capturing.
Yeah.
So I'll pull it out.
I'm pulling it out.
Any impedance of less than 500 or more than 200 ohms drop in impedance probably we should not accept. So that unipolar impedance.
All right, why don't you take it out and try a new spot and we'll come back to you.
Go back RAO. Yeah.
Okay. Can we switch, please?
So, Dr. Sharma, you said the septum minimum which you have faced for left bundle is 0.6. Isn't 0.9 the cutoff? What I have read, it's 0.9. If it is less than 0.9, you should probably not try left bundle pacing.
Where did you read that?
I think one of the articles, I'm not sure, I'll get back to you.
No, so the thing with, and we'll talk more about LBB pacing when Santosh gives his talk, but to answer that question, it depends on the angle at which you go through the septum. There's no right or wrong answer. Yes, you want to be absolutely perpendicular because it gives you a better control over the lead, but sometimes you end up going in an oblique fashion through the septum. So if you're going this way instead of this way,
having more thickness,
then you can actually get 1 centimeter of the lead in a 0.6, 0.7 centimeter septum as well and still have left bundle branch pacing.
Right.
So I don't know if there's a right or wrong answer. Yes, I am not saying that you want to. I would err towards the side of avoiding that if it's a very thin septum, but I've done it. I've had to do it, but I had no other choice. So.
Thank you.
All right, so this was data on his bundle pacing for bundle branch block disease, right? So again, in that same Nature Reviews paper, we've listed some of these studies and what these studies studied, which patient cohorts were studied and what they showed us in the long-term outcomes. So this was the multi-center experience that we published on his bundle pacing for CRT, where we actually looked at two cohorts of, we divided these patients, this was multiple centers, those patients that underwent his CRT and were followed up in the long term. We called them either rescue his CRT or primary his CRT. Rescue was when you failed BiV pacing and you use his CRT for rescue therapy, which is what most people would do with the current gold standard being BiV. The other cohort was primary his CRT because we have had experiences and we know that these patients seem to do better. We would perform his bundle pacing as a primary modality in these patients. So you can see here that amongst all subsets, whether different subsets of patients for different reasons for CRT, overall the success rate for his CRT was about 90%. And you see pretty significant narrowing of the QRSs, a significant improvement in LVEF, irrespective of what their baseline EFs were, and a significant improvement in NYHA functional class. The overall response rate to his bundle pacing was 75%, with echocardiographic responses of 73% and super response rate of close to 40%. Now again, like I said, when it comes to patients with a low EF and right bundle branch block, we know that BiV pacing doesn't necessarily work very well. So we decided to study this cohort of patients. So here's an example of a patient with a delayed RV activation. This is the LAD in an RAO projection, the RV, and on the other side, the LV. You can see that after his bundle pacing, the LV activation doesn't change significantly, but the RV activation pretty much normalizes. The other thing you see here is that the earliest activation is on the septum, which tells you that in this patient that we normalize the right bundle branch block pattern. This is likely non-selective his bundle pacing because the septum's activated first. So that's a beautiful example of ECGI imaging. You can see here that this cohort of patients, their EFs improved significantly, and no matter what cohort of patients you looked at, even those patients that had a QRS duration with a right bundle branch block of between 120 and 150 or 180, all of those patients responded equally well with a 70+% response rate, a 76% overall clinical response rate, a 70+% echocardiographic response rate, and a 20% super responder rate. You don't see this sort of response in patients with BiV. And you definitely don't see this sort of response in patients with BiV for patients with right bundle branch block between 120 and 150. Okay, BiV patients that benefit there probably benefit because they also have concomitant left anterior fascicular block or long PRs to begin with. That's where the value gets added. Now there's a lot of talk of his sync. So people keep talking about it, saying, oh, it was a negative study, we don't know, what's the point in all this? So I want to clarify some of that. That's the reason I put this in here. So his sync was unfortunately not the best designed study, okay? Credit to Rod Tongue because he wanted to make sure that we can do something like this. We participated in the study, but we participated after the fact that the trial was already designed and it was already on clinicaltrials.gov. So they took all patients with BiV indication, including IVCDs, and randomized them to his bundle pacing versus BiV. We know it for a fact that IVCDs is not a conduction system disease, it's an intramyocardial process. And so what happened was they permitted crossover. They said if you fail if you're randomized to his CRT and you cannot narrow the QRS, you cross over to BiV. If you're randomized to BiV CRT and you cannot find a good branch, you have to be either posterior or posterolateral. No anterior branches are acceptable. If you cannot find a good branch, you can cross over to his CRT. So you can see here 45% of patients from the his CRT group crossed over to BiV. Unfortunately, 5 of those 21 patients had IVCDs, did not have true left bundle branch block or classic right bundle branch block. And so you're already eliminating 25% of the patients that are not even going to respond to a therapy. That was the fault of the design. And that's the idea of pilot studies, right? This was a pilot study to help us design a larger scale randomized trial without making these errors. But here's the interesting thing. If you look at what happened to the patients on their per protocol analysis, the reduction in QRS was much better with his CRT than with BIV-CRT. Echocardiographic response rates, more than a 5% improvement in EF. Now, this was a true randomized control trial. The echocardiograms were evaluated in a core lab at Duke, and the ECGs were evaluated at a core lab in UCLA, both of which were not participating centers in the trial. So these were blinded analysis. And you see that the echocardiographic response with his CRT was 76%, while it was only 53% with BIV-CRT. And the average improvement in EF was 9% with his CRT, while it was only 5% with BIV-CRT. Okay, so very preliminary data. Just use this as potential signal that his or conduction system CRT might have a better response rate than BIV-CRT, but don't hang your hat on it just yet. So based on all of these studies, current guidelines recommend his bundle pacing or BIV pacing for patients with an EF between 35 to 50% that are anticipated to pace in the ventricle, and also recommend a class 2B indication for dual chamber pacing for level of block at the level of the AV node at the present time. So what are the challenges? You know, there are issues. Why are we talking about left bundle branch pacing? There are challenges. I think his morphology is looking better now than it had. All right, so this was the large-scale study with Dr. Vijayaraman, and you see here that the capture thresholds in general in the his bundle region are higher. The R wave amplitudes are generally lower. The other issue is that these procedures do take slightly longer procedure time and fluoroscopy duration. So it is longer than a regular dual chamber RV pacemaker. The other issue is when you look at long-term follow-up of the cohort of patients, you see that between 5 to 7% of these patients require lead revisions because of an increase in threshold on the lead. This was very interesting. I like to highlight this for those of you who read these long-term studies. There was one patient in the his bundle pacing group that developed a pacing-induced cardiomyopathy, while 22% of patients developed that in the RV pacing group. The one patient that developed that in the his bundle pacing group was a patient that lost Hisian capture. And it was capturing the RV septum alone. So even RV septal capture around the his may not be sufficient to prevent a cardiomyopathy. As soon as we increased the output and they were capturing with the his, the cardiomyopathy improved. In the largest series of 332 patients, the lead revision rates were 4.2%. So again, between 4 to 6.7% on the previous study. So here are the challenges with his bundle pacing. Yes, it takes longer. Yes, there may be a failure to implant because of higher thresholds. Disease might be infrahisian, truly infrahisian. You know, depending on your experience level, you might have a 10 to 20% failure rate. That's looking even better. You see that W? That notch is become shorter. That's a good sign. He's headed in the right direction. There may be transient AV block, like we talked about. In 1% cases, there's transient AV block that majority of the time recovers, but then again. And then the evidence, we do not have randomized controlled trials. Everything that I showed you is non-randomized, although large scale, but it's not randomized control. So that then brings us to left bundle branch pacing, and that's a good segue to where we are. So Santosh talked about the anatomy, but I wanted to highlight a couple of things for you guys. So look at this. So this is what the left bundle branch really looks like. Okay, this is a thin cylindrical structure, the his bundle, and the left bundle is a big fan-like structure. Here's another example of how big this structure is before it fans out. You know those illustrations where you see a left anterior fascicle and a left posterior fascicle and it looks nice and pretty? That's not reality. Reality is this. Okay, this is what the left bundle looks like. It's a big stump. It looks like your hand, you know, a big stump, and then all of these fingers that come out that then branch out into Purkinje-like network. So the big stump becomes a better target. That's why you can try multiple spots and you might be able to get a good result for those cases. So again, like we said, the His bundle is a thin target while the left bundle branch, which is a big stalk, might have multiple places you can try to fix the lead in and gives you better targets. The first case of this was reported by Dr. Wong in Canadian Journal of Cardiology in 2017. This was his first case. He showed it to us at the first Physiology of Pacing Symposium in Chicago 3 years ago to me and Dr. Vijay, and we weren't sure that we agreed that what he's telling us is real, but then when he showed us the electrograms, we were convinced. So here's what I was trying to highlight earlier. When you think about the conduction system, the AV node becomes the His bundle that then becomes the right bundle branch. So the right bundle branch goes more superior and anterior on the right side of the septum in comparison to the left bundle branch stalk that comes off slightly more inferiorly compared to the right bundle branch. Okay, so when you target for getting through the septum while you're doing left bundle branch pacing, you're actually trying to go, you find the distal His, and then you draw a line to the apex, and you go a centimeter or two distal to that, and you're trying to target here. You're not going higher, because when you go higher, you're more likely to ding the right bundle branch and cause complete heart block. So that again is something that Dr. Wong learned early on, saying if you go higher, you're more likely to cause complete AV block, and so he started going lower. Okay, so this is all experience that has taught us these little things. It's not magic. It's not something that we said, okay, we already know how to do this. All these things happen. We learn all these things through experience with perforations, complications, what has happened, and what can we do differently. So the idea being, you go slightly more distal, you burrow through the muscular septum. So you want to look for good R waves. That's why I keep asking, what are the R waves like? You want to look for your starting impedance, because you want to know what the impedance looks like. As you burrow through the septum, the impedance will keep rising, and then it will settle down. So it goes to a peak, and then it starts settling down 100, 150 ohms below where the peak was. That means you're getting closer to the LV endocardium. If your impedance drops by more than 200 or 300 ohms suddenly, like it went in the previous spot he was at, from 650, 700 ohms down to 300 ohms, you're through. I just told him to continue screwing to prove the point that we knew he was through, okay, because they wanted to try. And again, half a turn more, and they lost capture. Very clear that they were, and that is exactly the kind of scenario I would strongly urge you. Everything else might look good. You might have great capture. Do not leave that lead in, because that lead will dislodge. People think that that lead will not come back, but once you burrowed through and through the muscular septum, you've made a hole. That with cardiac contractility, that lead's going to slowly start pulling back, and it's going to dislodge. Okay, so that's exactly the kind of situation you do not want to accept as a final result. Okay. So again, like this particular case, in a patient with left bundle branch block, you try to map the distal His and you pace, and you do not see narrowing, and then you try to go more distal, and you can get past an area of disease and result in a nice narrow QRS with the right bundleoid IVCT pattern. This is, let me see if these will play. I guess they're not playing. But the idea was, again, to show you what we're about to see in this case as well, what the RAO and LAO projections look like with septum being flush with contrast. And you're right, you want to be as LAO as possible. I think the issue there was they're also trying to continue to screw in, so you got to find that LAO that works so that you can actually continue to screw the lead in. So the final point is, where do we go from here, right? So this is what our current thought process is. How do we go about this? In the past, we used to accept His bundle pacing capture thresholds of up to 2.5 volts at 1 millisecond. Now we've changed our thinking because we have the option of left bundle branch pacing. I still caution people to jump to left bundle branch pacing. People think it's easy, but I will still caution you with being careful to being too premature to jumping to that for all your cases. We'll talk about this more at dinner because I have something interesting to share with you, but I'm not going to release that just yet. So this is what we do. We start with His bundle pacing. If the His capture threshold is greater than 1.5 or the bundle branch recruitment threshold is more than 2, then we switch to left bundle branch pacing. Or if it's a His lead revision, if a patient has a higher threshold with time, they come back for revision of the lead, then I try to prefer to go more distal on the His or a left bundle branch pacing. If left bundle branch pacing works, then that's great. You accept it. If it fails and the patient has a LVEF more than 50%, you do RV pacing. If left bundle branch pacing fails and the LVEF is less than 50%, you do bi-V pacing. So this is our current strategy when it comes to attempting conduction system pacing. So where do we go from here? We know that His Purkinje conduction system pacing is physiological in the true sense when it comes to ventricular activation. We also know that there's data that's emerging that this prevents heart failure hospitalization, atrial fibrillation, and may possibly affect mortality. We know that it can potentially reverse dyssynchrony and has higher response rates, at least in the preliminary studies that we've seen. With His bundle pacing, we have 2 decades worth of data. We know what the issues are. We know the issues are generally related to a higher capture threshold that may increase over time, and that can impact battery longevity. Oversensing can be a challenge, but we try to overcome that by going more distally. We do not have any large-scale randomized controlled trials, and that's what we need. Left bundle branch pacing is the new kid on the block. It's only 2 years old, and there's very limited experience with it. Like I highlighted at the first part, Santosh was trying to screw the lead in. If you're not careful, you don't go all the way into the V and then pull back, you can entrap the tricuspid valve septal leaflet, and that has been seen. And you may not be able to burrow through, and even if you burrow through, the tricuspid valve septal leaflet is entrapped and you cause TR. Lead dislodgements are more frequent than with His bundle pacing or any other form of pacing because the septum is like cottage cheese. It's like paneer. You get through, you can come out easily too. Okay? Lead perforation into the LV is another issue that we don't look for carefully enough, and it can happen. This is my last slide. And finally, with left bundle branch pacing, at least with His bundle pacing, you have data of over 1,000, 1,500 patients, though not randomized, but we have prospective data. With left bundle branch pacing, we have a few hundred patients coming mostly from China at the present time. So unless we have multiple centers across the world that have reported on this, and we know what the potential downsides are, don't jump to this as your primary modality just yet. We need better and dedicated tools for His bundle pacing. We need leads, we need better sheets, and we also need enhanced device algorithms that are specific and can make our life simpler going forward when it comes to conduction system pacing. All right, I'll stop there and let's go to Santosh. Yeah, can we switch to some? Hey, Santosh.
Correct. So I don't know if you can see the septal. We went to a different spot. You can see the septogram we did. It's pretty deep, and still, I don't think. Can you pace the left bundle lead at 5 volts through the programmer? So look at the QRS morphology. So this is at pacing at 5 volts at 0.5. Pace at pace at 10 volts. You see the QR pattern in V1. We see that at higher output.
So this is 10 volts.
That's 10 volts. You see that QR pattern.
Can we measure LVAT here, please?
LVAT. Yeah.
From the stem to the peak of V5?
Yeah, it is still long. Yeah, at 10 volts, it's still long.
It's 110, 120. Okay, go to 2 volts. 2 volts, please.
2 volts. So you lose that QR. 3 volts.
Okay, update and measure your LVAT here.
It is long, 130.
So I have a feeling that you're going through the septum at a little bit of an oblique angle. What's your impedance here?
Impedance has been in 300s. You see that septogram? You see that in the back, the fluoro? We injected dye again.
Yeah, you said impedance was what, 300s?
From the beginning, it's been like 300. It was 300, 350s, and then it came down.
From the beginning?
Yeah, it never went up actually.
So there's a leak of current in your system. That is
Somewhere.
not related to switch your cables out.
Which switched, it's still the same.
On the back end, where the alligator clips go in, there's a leak. I guarantee you that. It cannot be 300 ohms.
Yeah, it stayed 300.
I had that happen in the live case at APHRS, I'm telling you.
Yeah.
Why don't you just connect it directly to the PSA and measure your impedance?
$600.
Uh-huh.
So the impedance, if it's 600, you see what I'm saying is at high output we are getting the QR. Still the LVATs are still
No,
long.
but the fact that you're seeing a better morphology at a higher output tells me you're still not on the LV endocardial border.
I agree.
In the previous part, you didn't see that.
Yeah,
Here you're seeing that, so I would feel more confident screwing it in further, and especially now knowing that your impedance is 600.
Yeah, but also you see the septogram, how deep we are. The ring is almost half of the ring
But
is in.
I do feel that you're at an oblique angle, so it wouldn't matter. At an
Yeah.
oblique angle, you can get 15 millimeters in and you may still not be in the septum.
Yeah, agree. Yeah, you can buy more length.
I just was wondering if there's a drop in the impedance and then you think you're not yet gone in too deep and then into the endocardium, etc. So you would like to do this maneuver every time? If I figured out the
He
truth.
said the impedance started at 300 and it just went up a little bit and it stayed at 300. That means it's the cables.
Yeah, I think there was a
If
cable.
it started at 500, 600, went up to 800 and then it was 300, then you know it's not the cables, it's the lead.
Okay, so what was the sequence here?
He started at 300s and it stayed that.
Slightly higher. I think the problem was that we are measuring with that other cable, right, fluoro? So now that we can measure through the analyzer, we can see. So I can give one more turn, see if we can get more depth.
Yeah. I would give it better sheath support in LAO like you have. Have
Yeah.
someone hold on to the
Fluoro.
sheath for you and rotate the lead body at least a couple more turns.
Let me get the sheath closer. One second. I'll give you. There.
There, that looks a little bit better. Why don't you just test that?
What's the impedance? It's still, you're facing at 5 volts? It's still like QS, 7.5 volts? Yeah, 7 volts. So with 7 volts you get that QR pattern, but still the LVATs are long and unable to narrow it down.
I like what I'm seeing at 10 volts.
Yeah, I do. The QRS duration is about 134 or something we measured.
QRS is much better and I know the LVAT's not the best.
Yeah.
But it's better than what you would see otherwise.
I agree, like, the baseline QRS is 200 milliseconds. But the output is on the higher side. So the question is, should we try one more turn?
Yeah.
Only, I don't know if it's going through.
What was the impedance here?
570.
570. So it's getting close, but it's not.
I'm just gonna. Once you do the contrast shot, your hand gets sticky with the.
To Parikshit, could you please tell us some maneuvers, how to get more support in this situation?
It's actually
The sheath is
contrary to what people believe. You need to have the sheath pushing up against all the time. Sometimes the sheath back and just being at a straighter angle is what works.
Pace, please.
Now in his case, he's up into the septum. Then you can push the sheath as much as you want. It's not going to pull things back. But it's the initial getting through the septum that makes the big difference, right? So sometimes what happens is your lead will buckle back or forth, and so if after trying a couple of times in RAO I don't feel like I'm making any progress, I do switch to LAO quickly.
Look
now.
at
In the beginning I would keep struggling in RAO. Now I've just learned, let me look at LAO. In LAO you'll see
the polarity is
this way,
okay.
this way. You know you're not getting
You have
into the
positive
septum.
injury current,
You just
right?
have to try a different
Yeah.
spot and make sure you pull your sheath back so you make it straighter up against the septum in LAO and RAO. Oh, did you go through?
Sheath is back. Pace ring.
I think, was that unipolar earlier?
That's the ring.
But the tip didn't capture?
Pace the tip.
Yeah,
Tip
you
doesn't
went
capture.
through.
Yeah.
What's the impedance on the tip?
It went down to 380s.
Yeah, so you're through here.
Yeah.
Can you show us the RAO view? How distal are we on
How
the
about
septum?
how about you do a contrast injection just so we can see what it looks like?
Okay. Contrast, please. Floral. Okay. Cine, please. It's a deep.
You're
That
pretty
is
far
deep.
in as you
Yeah.
anticipated. So
Yeah.
show us in RAO where you started going through.
I had to go a little bit more. We'll show it in. Can you go back, Arya? We had to go a little bit more distal.
Oh, I
saline.
see. Okay.
Because we tried proximal, right, in the beginning. And I don't know if you can see the reference. The reference we have shows you where we were in the beginning. And then we had to go a little bit more distal.
Yeah, that's fairly distal. Yeah.
So if you
Okay,
if you
so
see
rip-
in RAO your lead going like
Pull the
this,
lead back.
would you continue?
Floral. Okay, let's go.
What are your thoughts now, Santosh? What do you think you're
So we tried two different places and, we couldn't narrow it at all.
Yeah, you know what, actually, before he could tell us, see,
Uh-huh.
at this stage, what I would suggest.
Uh-huh.
You see, there was a point where, before we enter into the LV cavity, there was one spot where, everybody was little feeling good. The QRS was about 110. It was okay. So, the lead could be brought there and it is stationed. And then we get into the CS. Because, twice we entered into the LV cavity. I'm not very sure. Are you going to be succeeding anymore?
I think our thought here, Santosh, was that this is probably a combination of left bundle and
Agree,
IVCD.
yeah.
So we're
that's what
partially
it's going to be
narrowing.
in this case.
So the idea was, do we switch to hot CRT here with left
Yes.
bundle and LV?
Yeah, I agree. So get it to the spot where we were before.
Yeah, come somewhere in between this position and the previous one.
And then try the CS, right?
Yeah,
Yeah,
yes.
and then put a CS in.
Yes.
So you'll get the best of everything.
Yeah.
Okay.
So I think we should be taking a tea break here now. And then by that time, I hope he would have fixed the thing, and then we start the other thing. CS lead, his bundle.
Okay.
Yeah.
And the DF1, okay.
So we can
You
actually
doing okay?
break
You need
for,
a hand
Gene.
there?
Huh?
You need a hand?
No, no.
Okay.
You,
All right.
if you want to come, that's fine. You join me. If you're done. Is a small forceps, like a tooth forceps? No, there's some tissue there, see that? What's that? Sure, I can try that. The RA cable, the from before.
Yeah.
Do you have P waves? There's
Santosh,
some
can you
injury,
hear
right?
us? Santosh, can you hear us?
Yes.
Oh, great. So, Parikshit, I think
So
you
what are
have,
the P waves?
expert tips to them?
What are the P waves?
Okay, great. So,
2 points, okay. I'm taking it, okay.
Santosh, you are going to update us?
I can't hear you guys well.
You can't hear us well?
That's I'm screwing that. Is it out? Can you guys see it? I think it looks out. Right? Yeah. What about 1 second? Let me hook you up. I want to see the injury if it's better. I usually check the injury and then do that tuck stuff. Did the injury, is it better? Good. Okay. Flora? Give me the straight side. Sure. Farik is not a. Flora? Hello? Can you hear me, guys?
Yeah, Santosh.
Hey, Parik. So,
can you hear me?
Yeah.
Okay, can you review everything you did for the left bundle branch pacing with the audience, or you already did?
Yeah. we can.
So,
yeah.
so you ended up going between the first and the second spot. Am I correct?
Yeah. So it was still, it was not easy to push the lead. It was fibrous. This was the second attempt, and then go back to the. Go back next.
This, yeah.
Go next. Go next. So this was the first one.
Yeah,
It
that
didn't
was the
even-
first attempt.
Go next.
More proximally.
So this was the second, which was went through and
distal.
through.
Correct.
We came a little bit more basal. Next. I don't know. Is it saved? No.
Look at the timestamp. What was the most recent?
I can just do
This was
RAO
when-
now.
This was when you had perforated.
Let's do RAO. Let's just. Yeah, this is the final. So look at the fluoro now, Parik. Can you just do RAO one frame?
Yeah, we saw the RAO shot. We wanted to see how far into the septum.
Oh, the septogram. Can you show the contrast in the end?
So why don't you do the contrast now then, just so we
Okay.
can... Yeah, it looks like it's in between the first and the
Yeah.
second spot.
So you want me to do the contrast shot?
Yeah, just so everyone can appreciate it.
Oh, sure. That's not. Okay.
Yes. And what was
No, this is contaminated. Yeah.
Do you know the impedance trends on this position?
Yeah, the impedance starting was 1000. It went up to 1100, 1400, and then came down to like 1300s, and then finally at 1130 or something.
That's a little bit higher than what we're used to, but
Yeah.
the trend was...
It started off
stable,
high.
yeah.
Even with one bite, it was like 1000.
Yeah.
Okay, so LAO. Fluoromans. Show me a little bit more. Okay, Cine. So we are deep, looks like.
Yep.
Okay. So if you look at the, let's hook it up to the left bundle lead, please. I'm going to hook you up to the left bundle lead.
Santosh, do you plan to do another fluoro shot, contrast shot, or?
Miss.
So what people in the audience are bringing up is that doesn't seem like it's true LAO, and maybe it's just giving us a false sense of maybe we could go a little bit more LAO and get a
give me
better
more
sense of
contrast.
how deep into the septum. Also pull your sheath back a little bit so you can, you know, stain the entire septum rather than just the
Fluoro.
back end of the lead.
You agree that's close to the ring?
Yeah, so now your His catheter is foreshortened, which is what you want it to be. Pull your sheath back a little bit so you can stain the septum better.
I thought you were, okay, pulling back.
No, pull it back, yeah. Yeah, that's better.
Okay, Cine.
So it seems like the ring is in.
Ring is in, yes.
Okay. So that should be, so 1.8 millimeters for the helix, 9 millimeters from ring to tip, and then a few more millimeters from there. So it's about 12 or 13 millimeters.
It's more than that. Correct. The ring is like 3.8 millimeters. So at least 15 millimeters, I believe. And the radiographic marker on the thing is actually more than 3.8. So the ring is 3.8.
Yeah.
The radiographic marker extends up to
So
6 to
this is
7 millimeters.
probably about 14 or 15 millimeters.
Yeah.
But I still think it's a little bit of an angle.
Yeah, so the
but that's fine.
obliquity buys you more length, right?
And then can we also show people the review screen with the
So
bipolar and unipolar
Yeah, let's do it now. So we hooked it up unipolar tip, face. Huh? Oh yeah. So can you see on the screen? So this time, you know, the first site before screwing in, this was the morphology.
Yeah, so that's the W pattern in V1
Yeah.
before we started screwing in. Okay.
Yeah. So we start screwing in. Show us. So you can see its QRS is narrowing and the W is moving up.
Yep.
The notch is moving up. And then we got this QR pattern. You see that?
Yep.
Okay.
So it's more prominent in the last beat on the
And then, as you see on the right side of the screen, keep going to the right. Keep going to the right. Yeah. So as we came down on the output, you can see the QR becomes RSR prime pattern.
This is bipolar.
This is still unipolar.
Okay.
Probably the left side is septal plus left bundle, and the right side, the pure right bundle is just right bundle or left bundle capture, selective.
And what was the LVAT here?
LVATs are still long, but you see the stim to QRS latency?
Yeah. Can Can you show us what the lead looked like here? Shanmuga wanted to see what that looked like.
What do you want?
What the local EGM on the lead looked like with pacing.
Yeah. So can we hook it up to the Pruka, please? We had unipolar tip. Yeah, unit tip, but they want to see the electrograms on the Pruka.
Muthu, you must be there around, right?
No, the septum
Muthu?
is-
Muthu should be informed that, the cables should be changed for the next case. Yes. Okay, and then better check, those impedance issues.
Yeah. So let's pace now. Again, let's pace the unit tip at 5 volts, please. Yeah, I think they're connected. We have the. So that's at 5 volts. Come down to 3 volts.
Why do I feel the LVAT is lesser now?
Yeah. See the QR pattern now come down from 3 slowly. So you have a QR pattern. Keep coming down slowly. There. There becomes. Keep coming down. Check the threshold, please. So Parikh,
Yeah.
so I think we have a left bundle capture. Now, once we have the A lead is in, we'll adjust the AV delays and see if we can narrow the QRS, normalize the QRS.
Yeah, and can you also tell me where was the transition in morphology from non-selective to selective? When we saw the right bundle appear, the big right bundle appear.
So the QR to
Correct.
RSR was like
Yeah.
2.5.
Okay, let's pace around that again and be ready to update so we can show that to the audience.
Pace at 2.5. No. Yeah. Are you pacing at 3?
Start at 3 and come
3 and a
down.
half. Go to 3 and a half. There.
There,
You see
okay.
the QR, Parikh?
Yeah, so look at the local EGM. That's what I want you to focus on. So come down on the output and be ready to update. Come down on the output.
Look at the local EGM, how it splits once you have that. Keep coming down slowly.
There. So update
There.
that.
You see that local split?
So go back a couple of beats. There, stop there. So look at the third and the fourth beat.
Yeah.
Focus on the local EGM.
Gain down the his a little bit. You can see the.
So if you gain down the
Gain
his
down the
channel
his
by
channel.
1.
Yeah, gain down it a little bit.
No, gain it down by
Gain
1.
it down. There.
Good. So you can
You see
see
the-
that the local V
Is moving.
is pulled in and it pushes out when you see the transition in morphology. So that is non-selective left bundle capture to selective left bundle capture.
So you see
Okay?
this local
So the
split?
same concepts that
So it's
apply
a
with his bundle
HV
pacing
interval, right?
also come into
Stim
play with
to
left bundle
left
branch
bundle.
pacing. It's just difficult to see those sometimes, but this
So
is a good
when
example to
this,
see.
When you're pacing the tip, what's happening is here you're capturing, you're capturing the left
Though the
bundle
selective capture of
and the
left bundle
surrounding
phase
septal
QRS
myocardium.
is little bit
And as you
wider.
come down at
We have three
2.5,
important
you see the
things to
you
take
lose the
into
septal
account
myocardial
to narrow
capture,
down the
you get a
QRS
pure
more.
left bundle capture, and
So
the
one is to
local
get the help of
electrogram changes.
anode. So you can
So
just
this
see the anodal
local
capture
V is
threshold and adjust
pushed
it so
out.
that the anode also
Here
captures
it's
the other
pulled,
side of
pulled
the
in
septum.
because you're
The
capturing.
second thing is
So
native
that's the
conduction.
concept.
Probably you can adjust the AV delay to activate the RV via AV node
So
and LV via
in
this
this
left
case,
bundle
the
lead.
patient has left bundle
And
branch
third
block,
is we have an
so
RV
you
septal
won't see the
lead.
potential.
So you have an
Sometimes you can
RVVV
see
pattern on
retrograde
the
left
left
bundle
bundle pace
potential.
lead
I'll
and
show you some
LVVV pattern
examples
on the
later
RV
today.
septal pace lead. We just time it accordingly so that you can
You know,
bring down
Chinese
the
have
QRS.
said
So
98%.
probably I think we can
but
get a QRS of less
ours
than
we've
110
seen like
milliseconds
65%
even
of
with
the
this
time.
wide QRS
You know,
with left bundle capture.
You don't, again, the risk of...
Santosh, can we check bipolar to see what anodal morphology looks like quickly?
Okay, so this is bipolar pacing. Pace at 3 volts. We had a nice QS with bipolar.
How about we pace
Go
at
at
5 here?
volts.
There, look at that.
So that's bipolar with anodal capture. Come down to 4 volts. Yeah, again you can see the local electrogram changes. Run it down from 4. So this is beautiful. Parik, did you see that?
Yeah.
Go back to 3.5 and go down slow. So there are 3 transitions here, looks like, right? So this is
Non-selective with anodal.
yeah, come down.
There.
So
that
you
transition.
see, yeah, that's interesting. So you see from QS to QR to RSR. So 3 transitions. Keep coming down. Intermittent. Keep coming down. What are you at? What? Come down to 2.9. There, it's 2.8. There. Changes. So it's like 3 morphologies there. Again,
Yeah,
it
you
depends
should-
on
you
how much
should
of myocardium is
Save all
captured.
of these, but they're interesting. So play around with your AV delays and
Yeah.
bi pacing and see what you get as the best morphology.
Yeah.
But great job, good result.
Okay.
So,
So
we'll
we'll
keep
split-
going here. Congratulations.
Thank you.
I
Okay,
just
so-
want to share one of the experience that in such patients,
So we'll
sometimes
split
when we
the
get very
sheets and then
long
tie it
LVAT,
down.
Despite
Do you have
QR
the old
pattern in
splitter?
V1, but V5 is
The
showing
old,
long
the-
LVAT, then
Yeah, the one which you can
to create
pull
a
it down.
fusion with
Adjustable.
native right bundle conduction, you need to
Yeah, the
program to
adjustable.
very short AV delay, maybe at around 50.
So you see this,
60. Majority of
Yeah,
times
so,
when I look at
you know,
the echo,
I don't know what this
usually
potential
there
is,
no much,
right?
not
Could it be a
much
retrograde
problem.
left bundle potential? In
AV
patients with left
fillings are
bundle, it's coming
optimum.
down the right bundle.
But one of the case where
Comes down and
when
goes
I
down.
programmed such a
Yeah.
short AV delay, there was problem with AV filling.
So, yeah, so
should
I don't
we
know if it is
accept,
right bundle. I'm just,
LVAT,
I'll show some examples where
which
we had
is
clear
much
retrograde
prolonged,
bundle potential.
specifically when your right bundle is conducting very fast, because AV synchronization is a problem because some of the device does not allow less than 60. So that is the question. Yeah, so this patient I'm talking about, he had 7 millimeter of septum. So I just had my tip inside the septum and I was capturing the left bundle. But LVAT was, again, it was around 104 and right bundle was very good. So when I was trying to achieve a optimum fusion, I had to program to 50 millisecond of.
Yeah, so anytime you program your AV delay, in our experience, less than 80 or 80 milliseconds, again, it's variable from patient to patient. Inter-atro conduction time also impacts all of that. You are likely to have issues with pseudo pacemaker syndrome.
Yeah.
So we're careful with programming AV delay shorter than that. So if that is going to be the case, I would much rather try to get anodal capture and see what the QRS looks like, do bipolar pacing with variable VV intervals, and see what the QRS looks like before I make an AV delay as my final strategy. So AV delays is a good idea, but not when it becomes that physiologically, non-physiologically short. So, in fact, I have a couple of examples tomorrow in the troubleshooting talk, which are on that topic.
Okay.
So I request Neeraj. He is one of those enthusiasts of his bundle pacing. So it is a pleasure to have you, Neeraj. You have a great experience, and thank you for making your time out. We're here to listen to you and learn something.
Thank you very much, sir, for giving me opportunity to speak about my experience of physiological pacing in front of the expert of this field. And since the time of Hippocrates, it's known to clinicians that symptomatic bradyarrhythmia, particularly when it is caused by His-Purkinje system disease, is associated with increased risk of sudden death. And pacemaker is the only proven therapy to improve clinical outcomes in these patients. Since the first pacemaker was implanted more than 60 years back, VVI pacing has saved millions of lives. However, it is hemodynamically inferior because of problem of VA conduction as well as VA dissociation. And AV synchrony is important when resting heart rate, at the resting heart rate and low level work, but heart rate is the major determinant of cardiac output with moderate and heavy work. So in 1990s and 2000, actually dual chamber pacemaker was considered as a physiological pacemaker because of its ability to maintain AV synchrony and to provide a chronotropic incompetence. However, the target of physiological pacing has kept on moving because of the problems that we observe during current pacing therapy. Dual chamber pacing, despite superior hemodynamically to single chamber pacing, did not prove any significant benefit as compared to VVI in randomized controlled studies. The only subgroup of patients which were benefited were probably sinus node dysfunction where ventricular pacing could be avoided. This is the retrospective analysis of most trial which showed that it is cumulative percentage of ventricular pacing which
I need to check the
determines
slides
the
too.
adverse
So
outcomes.
yeah, you can raise it a little bit.
Yeah.
Yeah.
And first episode of heart failure hospitalization or AF was significantly more in those patients who had more than 40% of RV pacing burden, and it was irrespective of the mode that was chosen. So DDDR as well as VVIR. And David trial, though it was an ICD trial, it showed that when it is programmed to DDD, it leads to worse outcomes as compared to backup VVI pacing at 40 because of the committed RV pacing that happens in this subgroup. David too actually proved that supposition that RV pacing induced altered mechanical activation is the reason of worst outcomes. They looked into AAI 70 beat per minute mode versus VVI backup at 40, and they did not show any significant difference between these two modes. Danish registry, in the Danish registry, it was more than 10% of incidence of heart failure hospitalization by end of 2 years of follow-up in patient undergoing RV pacing. And our definition of pacing-induced cardiomyopathy of LV ejection fraction less than 50% due to chronic RV pacing is just a tip of the iceberg. We may have many patients who are having heart failure symptoms without any significant change in LVEF. If you see the predictors of pacing-induced cardiomyopathy, all these predictors are actually measure of dyssynchrony. So RV pacing burden and paced QRS duration longer suggest more dyssynchrony imposed on LV myocardium. Baseline LV function, if it is reduced, it increases the extent of LV dyssynchrony imposed by the RV pacing, and that is why they are more vulnerable to pacing-induced LV deterioration as compared to normal LV function. So it was intuitive to think that if we correct the dyssynchrony by any means, it will improve the outcomes. And Protect Pace actually studied the alternate site of pacing. And BioPace study, the results of which are actually not published, but it compared BIV pacing versus RV pacing in all comers of RV pacing indication, and it did not show any improved outcomes. The limitations of BIV pacing is that it is clearly an established therapy for heart failure patient with EF less than 35%, LBBB, QRS more than 150 millisecond. But there is not much evidence of benefit in patient outside this indication. even if you see the block HF trial, it just delays the event of first event of heart failure and mortality as compared to RV pacing, rather than reducing these events. So the concept of physiological pacing came in, and the work of Dr. Vijay Raman, Dr. Parikshit, and this has really led to excitement in this field. And the reason is that any single site myocardial pacing cannot restore the synchrony to physiological level. The attempt of His-Purkinje system capture was done. And now probably our definition of physiological pacing is to maintain AV synchrony and VV synchrony through His-Purkinje system capture. You can capture the His bundle, or you can capture the left bundle to achieve this outcome. Before his sheath and leads were available to our center, actually I tried to implant a stillet-driven lead to His-Purkinje system region by way of manually shaped stillet. And though it actually I got successful in three cases actually, but I must tell that this was at times very frustrating because of very prolonged procedure, prolonged radiation dose, and the main thing was that the results were not reproducible every time. Sometimes you may get it, and majority of time you end up by putting lead into the RV septum. So this was another case where stillet-driven lead was implanted, 54-year-old female, 2:1 AV block. Pace mapping was the main tool to guide the site of lead in this technique. So non-selective His capture was achieved through manually shaped stillet, but there are many cases where I failed, which I am not showing here. So His bundle sheath as well as lead was made available to our hospital in end of 2017, and through online tutorials by experts like Dr. Gopi, Dr. Vijay Raman, I had some confidence that okay, we can try it and we can do it. So I was fortunate enough to have successful His bundle capture in my very first case, and this was a elderly male post CABG normal LV function presented with 2:1 AV block. We did His bundle pacing in this case, and this was first case and it was successful. It is very important to have success in initial implants, because I've seen many people giving up trying His bundle pacing because of initial failures. So I would suggest to have someone at least experienced in doing pacing in initial cases or initial implants. Also, it is very important to select patients carefully in initial learning curve. I chose all those patients who had normal heart, who had AV nodal block, who did not present because of syncope, but their main problem was chronotropic effort intolerance. And all these patients were local residents of my town. Once I got comfortable with implanting his lead then I had an opportunity. I never thought about doing it as in a case of CRT, but I had an opportunity in this case because I failed to implant LV lead because of very difficult tortuous vein, small caliber vein, and I ended up doing CS dissection. This patient had a non-ischemic cardiomyopathy. If you see cardiac MRI, had shown LV dimension of 7.7 centimeter. My echo dimensions were 65 by 51. EF was 25%. There was no late gadolinium enhancement. And his bundle pacing was done as a bailout because of failed LV lead placement. And I got QRS duration of 90 millisecond from 168 millisecond. This was her echo after 2 months of LV lead implant, after his bundle lead implant, and it shows some reduction in LV size, but LV was still dysfunctional. And at 5 months, her LV reduced to 46 millimeter from 70 millimeter, and ejection fraction improved to 50%. So because of this experience, I also tried to do his bundle pacing in a patient where I didn't even look at coronary sinus vein, but this time I failed in implanting his bundle lead. And fortunately, I heard Dr. Parikshit about left bundle pacing, and I knew how to go ahead with it. So I did a left bundle pacing in this case. This case was a left bundle branch block syncope. She underwent CRTD implantation, and QRS, final QRS was 100 millisecond from 160 millisecond by left bundle pacing. And this lady also has good LV ejection fraction improvement, though it is around 35 to 40 from 20%, but she is doing much better. For potential CRT indication, we know there are some subset of patients where you want to do beyond ICD lead placement, but you know that bi-V pacing is not an answer. This was a lady post-CABG, LV dysfunction, presented with stable monomorphic VT. Right bundle branch block QRS was almost 190 millisecond. Because bi-V pacing has not shown much of the improvement, we implanted his bundle lead, and we corrected QRS duration from 190 millisecond to 116 millisecond. And this lady is doing fine. Interestingly, in this patient, the episodes of ventricular arrhythmia has also reduced significantly despite of absence of any antiarrhythmics. So that was something that was striking in this case. Again, there are patients where you know that these patients, we have some data of bi-V pacing, but it is not practical many times in our practice. This lady, 86-year-old female, coronary artery disease, systolic dysfunction of 40%. She presented with worsening of heart failure symptoms, and she had progressive conduction disease, right bundle, left anterior hemiblock, then right bundle, left posterior hemiblock, trifascicular block, and she landed up with 2-to-1 AV block in emergency with worsening of heart failure symptoms. So again, his bundle pacing was done with final QRS of 108 millisecond. Non-selective capture was achieved. There are patients where RV pacing can also do equally good, but we don't know, because there are many patients who has normal LV function and still they go on developing pacing-induced cardiomyopathy. So just for prevention of dysynchrony, there are some cases. This was a young man, diabetic, symptomatic AV block, normal LV function, and his bundle lead was implanted with very good parameters. Threshold was almost 0.5 at 1 millisecond pulse width. Another cases which I never tried earlier was AV junction ablation and putting a pacemaker. But after having some confidence in physiological pacing strategy, this was a lady, 68-year-old female, rheumatic heart disease, status post BMV. She had AF, atypical atrial flutter, which was ablated 2 years back because of incessant nature and worsening heart failure symptoms. She developed recurrent rhythm problem after 2 years, and rate and rhythm control strategy completely failed despite 4 different class of drugs. LA volume was 160 ml, and after discussion with patient, we went ahead with AV junction ablation and pacemaker implantation. In this case, I did a left bundle pacing, and final QRS in bottom panel was almost 100 millisecond, 96 to 100 milliseconds. So it's not a huge experience, it's just a small experience, but total number of implants, 32 I've done. Majority of them are his bundle implants. Probably the success of his bundle pacing in my cases are because I have chosen mainly AV nodal blocks patient, normal heart till now, except few cases where I had to do for CRTs. So left bundle pacing, 5 cases, stellate driven where I could achieve his capture, non-selective his capture was only 3, and longest follow-up available is of 27 months, and there is no issue of threshold or sensing in this patient after end of 2 years of follow-up. Majority of them were AV blocks for CRT indication 6, AF with bradycardia 1 patient, and AV junction ablation for AF 2 cases I've done. There are no lead dislodgement till now. Our right bundle branch block, which I had noticed during on table in 1 patient, and it recovered completely on the very next day. Under sensing and over sensing is not seen till now. Majority of these leads were implanted in distal part of the region, and I tried to achieve non-selective his capture in few of these cases where thresholds of selective his capture was very high. Exit block is not seen. Subacute rise in thresholds were in 2 cases. Both of them were left bundle branch block patient, and they had increased, which again recovered in follow-up. So from 1.5 it went up to 3, and in follow-up again it recovered to 1.6, 1.5, 1.75. Lead revisions are not done. Failure 2 cases of his bundle pacing. But at that time left bundle pacing was never thought by me. Now probably I would, once I fail in his bundle, I would go to left bundle and pace the left bundle. QRS durations were impressive in all of these cases. Capture threshold 1.31, maximum threshold 1.75. So if I have achieved higher threshold, I don't accept that site. That may be so the reason. R-wave amplitude was around 1.5 to 9 millivolt. Impedance was around 415 to 750. For CRT indication, 4 patients, out of which only 3 patients data is there. 4th patient I have not followed up yet. So ejection fraction from 23.6% has to improve 40%. So it is definitely a viable pacing strategy in day-to-day clinical practice. It has got broader applicability across the pacing indications as compared to right ventricle or biventricular pacing. Initial learning curve requires thoughtful selection of patient during initial cases. Most complications I think can be avoided if at the time of implant we don't accept any abnormal parameters. Thank you.
Great.
I think you should be congratulated. That's a lot of effort on your part to get to that. Particularly, we usually recommend that most people start off with simpler cases like sinus node dysfunction and narrow QRSs, and in your 32 case experience, you've actually done a lot of wide QRSs, CRTs, AV blocks, AV nodal ablation. So congratulations, that's a lot of effort. And also looking at your results, it seems like you're sincerely putting in the time and the effort to learn this and to get good at it. So we need more people that that actually take this
It's all
on in a sincere
because of
fashion.
the learning that we have received from you, Dr. Vijay Raman, and all these experts. So, but yes, the only thing that initial all 24, if I talk about AV blocks, there are two only infrahisian blocks. Majority of them are AV nodal blocks. Initially, I chose only those patients who never had syncope because of AV block. So I never implanted a backup lead also, except those cases of CRTD. I was convinced from the initial 3 or 4 cases that lead is pretty much stable. It does not get dislodged that easily.
Right.
One dislodgement that happened was in stillet driven lead and not in the
yeah,
this,
like I said earlier,
trapezoidal.
I said that earlier today in the talk, is that please be wary of using extendable retractable helixes. We don't have a lot of experience with them. Definitely don't use them in patients that are going to be dependent on pacing. And I think picking patients with AV nodal disease for your initial case experiences is also the right thing to do, because infranodal disease requires much more attention. Just like in this case that Santosh did, we looked for sites with a long HV and avoid those, go to distal sites with short HV. In patients with infranodal disease, especially if block is intermittent, you may not know all of those things happen, and you have to do your due diligence, and a lot of additional steps are required before you accept those sites. So start off with the easier things, gain enough experience with them before you take on the more challenging ones.
So Neeraj, great, the data, the way you presented. Coming back to that 1 or 2 cases of yours where the defibrillator lead was placed, and then I think it was an RBBB cardiomyopathy.
Yeah.
Yeah, and then
RBBB and
cardiomyopathy, and then it appeared like it is a CRTD for you.
Yeah.
Is that right?
Yes.
So now I have also got about 10 of DXICD now. DXICD and putting it there. And of course, we got to check the defibrillation ability. We'll have to induce and all that. I want to know from you, in a person where you thought this kind of a typically atypical RBBB cardiomyopathy, this is a good option, or I am actually thinking quite loudly about this. It is helping.
So
it's helping. You see, this is not as great as your his bundle pacing narrow QRS or a CRT narrow QRS. But the atypical RBBB really becomes narrower. And it is that fear of not detecting the VF, the fear of higher defibrillation thresholds, I'm finding not based on really the experience what I have. So I think we are changing the way we are doing the CRTD for the atypical RBBB patients.
So last time I asked Dr. Parikshit same question, that should we choose only those RBBB patients who are anyway a candidate of CRT therapy as per guidelines, very long QRS or atypical right bundle, or if at least a demonstration. So one of the case that we did, I actually first we have lot of aux bipolar leads. So what I did was I went into the CS, I put that bipolar lead inside the CS and just checked the QLV. So QLV was, in that right bundle branch block, QLV was quite prolonged.
Really?
Yeah.
That's unusual.
So it was 100 millisecond in right bundle, 110 or 100 millisecond.
And there it works. CRT.
So probably those are the patients where they have underlying left bundle disease also, or LV delay for either intramyocardial disease or left bundle disease. So probably those patients are much more benefited as compared to
CRT.
pure right bundle, right?
Yeah, that's exactly what some of the other studies have shown us, is that, when you combine right bundle branch block with one of the left anterior posterior fascicular blocks, or they have concomitant intramyocardial delay that results in delayed activation of the LV lateral wall, or a very prolonged PR interval, where we know a PR interval more than 230 milliseconds, they probably benefit from BIV anyways, then those are all, that data is a little dirty. So that's why when we say RBBB more than 150 benefits from BIV, there is a subset of that patient population that is not just clean RBBB only. There is concomitant left-sided disease as well.
So I ask you the same question. Like, what are you thinking in those terms now? A defibrillator lead at that position?
That's a very tricky one to answer. So we've done a couple of those, not intentionally. One of my colleagues did defib lead where he had what seemed like non-selective capture of the His bundle, not for CRT reasons, but we've not moved to that because that becomes a challenge. Again, we can, sensing of VF is definitely a concern. Again, if you're non-selective, you're likely to be more ventricular, in which case you're more likely to have better R waves. So sensing may not be as much of an issue, but then again, until we have more data, and if you're telling us you've done 8 or 10 cases, you ought to publish that because that data is important.
So defib at the His bundle pacing,
But
I'm totally.
Is the science or is the technology is going towards this now? Because we need to be now pacing some defibrillator leads also.
Yeah, there is more coming down the road.
That's correct. Okay. So Neeraj, again, a great applause for him. Thank you so much. So I think Santosh is going to tell us, what ultimately he achieved. Santosh, can you hear us?
Hey, Parikh?
Yeah.
Are you guys there?
Yeah.
So we played around with some AV delays. We'll show you. Why don't you show the AV delay? What was the longest? So look at this. What happened was it hooked up. So if you look at the morphology here, V1 to V6 was all negative.
Yeah.
So I knew there was RV contribution. So this was LV and RV simultaneous.
Okay.
So then we go to 100 speed. Then we moved RV 60 milliseconds out.
Hold on, that's interesting also because if you think about the stim to the peak of the LVAT, which was so long, activation of the left side was taking so long that your RV activation would beat it out anyway. So BIV, which was simultaneous, would not look any good anyways, as expected.
Yeah. So when we moved out LV RV delay, we set it at 60 milliseconds. So I didn't want any contribution from RV. So this is now the AV delay of 100 milliseconds. We got a QRS of 124 milliseconds. Do you guys see it on the screen there?
Yeah. This looked really good. We saw this as you guys
So
were
then
working.
we further shortened the AV delay to 100. Shows the QRS, please. It became 104. So as we shortened the AV delay, the QRS duration got better. Again, the goal here is to fuse the antegrade connection down the right bundle with the left bundle pacing.
Yeah, no, that's great. We had touched upon this point while you were still doing your stuff.
I'll show in the
about AV delays and how sometimes setting AV delays below a certain limit can potentially cause some pseudo pacemaker type syndrome.
Yeah.
And we,
I agree, but there's a lot of stim to QRS delay.
Yeah, so here in these particular cases, I think I agree with you because the ventricular activation is still happening a little bit later. But with His bundle pacing, particularly if you go to below 80 milliseconds, you'll probably cause more pacemaker syndrome.
Yeah, so we have like 80 and probably there's some stim to QRS latency too. So 80, we're leaving at 80 now.
Yeah, this looks really, really good. It's a fantastic result.
Thank you.
Yeah, congratulations.
Thank you, guys.
I see that you're even closing the pocket for the patient.
What's that? Yeah, I'm doing the pocket now.
We are really getting work done from you.
I know.
Maybe my Ram Kumar must also been, tired watching so much. Santosh, you heard the applaud here. You achieved such a great result.
Thank you.
Thank you so very much.
Yeah, thank you.
Ram Kumar, are you there? Thank you very much for supporting Ram Kumar and the other team members there.
Can you
All right,
raise the table up a
so
little
you can
bit?
come down. We have another talk before go for lunch, or what do we do? Go for lunch or talk?
Yeah, thank you.
Yeah. So the next talk would be Avinash. Yeah. So pleasure to invite Avinash as well. Avinash also has some great original thinking, and he has got great experience about his bundle pacing. So. Avinash is from Delhi. He is now in which hospital you are with the Clay?
Pushpavati Singhania.
Right.
Yes. Good afternoon, everyone. Thanks, Dr. Ullas, for calling me and having me here in front of all the people from whom I have actually learned his bundle pacing and left bundle pacing. So I'll be taking you all, it's a pre-lunch session, but mine will be less academic and more story-like talk. So I'm not an expert, it's a disclaimer. So
We don't agree by that.
I'm certainly not an expert because I still think that there's so much to learn. I mean, every day I find something in the lab which is, dazzles me. So still I don't think that we should go in that line. Okay, so physiological pacing has just begun. It has came out of the beta phase, and the hardware is still the first version, and software, what software? We don't have any softwares. So we only have first generation hardware to work with. So how did I started my journey? So it was a shaky start. The first his bundle case which I was there was at my center in 2015, and incidentally it was first his bundle case in India. There were two cases done on that day. First case, the next morning the lead dislodged. The second case, the threshold rise to 2.5. So it was such a start of a his bundle program that for next 2 years nobody thought of doing his bundle casing. So my next attempt was in 2017, and this was again for a girl of, I think she was a 18 years old girl. And we thought, okay, we are putting a LV lead, but why give a RV lead to this girl? Let's put a his bundle lead for that girl. So we tried to have a his bundle, and incidentally it became a hot CRT. So this was my first case at that time. It was not a selective his bundle capture which you can achieve. We were only possible to get a non-selective his bundle capture. But she had very good response, and her EF now is 25%, 50%, but the credit went to BIV. We put a LV lead, and that is why she responded. So it was not in a very true essence convert of his bundle pacing after this case. So this is where the real start happened. This was after 4 years of my initial exposure to his bundle and 2 years after doing the first his bundle. And it was the case number 4, October 2019, so it's just 4 months. 65-year-old man, DCMP, 30% EF, post-CRTP in 2015, non-responder, LV lead, non-functioning, came for replacement. So what was the plan? So the first thing, CRTP replacement has to be done. His bundle, left bundle CRT. Now this is very important. Inspired by Dr. Shunmuga, his doc, and don't diss the his. So I was introduced to Twitter by Deepak and Dr. Neeraj. And on Twitter, I saw all those things. And then, suddenly this thought came, why not do his bundle? So that is the importance of inspiration and a conference like this. It inspires people to do something. So another thing was, again, going his LV lead intravascular, LV lead epicardial. The plan was, okay, let's try his bundle in this case. And it was like miracle, like Dr. Neeraj said, you need certain cases like this. In 5 minutes, it was at the his bundle, very good potential. As soon as we started pacing, this was the QRS. So it's first time in my life I was seeing something like this, that in 5 minutes, a patient who was on CRT for 7 years couldn't get anything, having a QRS of 70 milliseconds. So when such thing happens to you, your beliefs are shaken, really shaken. And such cases are important as they create a paradigm shift in your thinking as well as your confidence. So this was the kind of copy picture book case that was the first case. From 82 millisecond HV from that site, it immediately shortened to 44 milliseconds. The QRS also shortened. Very good recruitment, and this was the ECG. Now, after this ECG, I was very excited. Okay, now I'm going to do more and more his bundle case because, as I said, it was only in 5-10 minutes that entire thing was done. So my next case in the same week. So in the same week, I took another case, was his bundle CRTD. And in this case also, as you can see, the LBBB from 210 milliseconds, it came down to 104 milliseconds. And I was so sure that it will work that I didn't even put a LV lead. So it was LV lead, it was CRTD, primary CRTD, after doing a rescue CRT, primary CRTD without putting a LV lead. That would maybe somewhat more bold than I should have been, but the result is pretty good, and the patient is in follow-up, 3 months follow-up till now, everything is going fine. So I converted to physiological pacing. Now you can say that it's a very short experience to convert to physiological pacing. More than the number of cases you have done, it's that you have to believe in the therapy. It's more like radialist versus femoralist. You have to first decide to be a radialist, only then you become a radialist. So for physiological pacing, for my purpose, I have decided for physiological pacing, so I go for it. If I don't achieve good parameters, it's not that I have not done anything in between. I do normal cases also, but my primary thing is that I will go for physiological pacing as the primary source of pacing. So my 3 months or 3 years experience, whatever you want to call, total attempted cases is 38, successful implants 35. Incidentally, lot of CRT and his bundle cases. That is why I have done a lot of LBBB pacing because of this subset. And displacements, no his bundle displacements apart from the first case. The displacement which I have had was again the left bundle pacing, and the lead went through next morning. So this was my first left bundle CRTD. Again, the very next week, 70-year-old man, ischemic heart disease, LBBB QRS duration of 170 millisecond. This was not a primary left bundle pacing case. Again, I tried for his bundle because I was not doing left bundle pacing. So this was my first left bundle case. Again, it is a CRT case. So LBBB, pacing from the his bundle side, selective his capture, not doing anything. I'm getting a small his. Even at distal his, I was unable to correct. And this was the left bundle EGM that I got. I tried from upper septal pacing, but didn't get anything from that side. The EGMs were not good. I screwed it more further down the septum, and this was the final position. And this was the unipolar left bundle capture, and it was pretty good, and I was pretty amazed by my left bundle results. And this was the bipolar. So from unipolar to bipolar, just like in the previous case, the QRS narrowed down considerably. So it was left bundle pacing CRTD. This was my first dual chamber pacemaker CRT for primary left bundle pacing in a 35% EF patient. Now, as you can see, it was an infrahisian disease, and EF was 35%, patient was not affording. So this was the case where instead of trying for left bundle, instead of trying for his bundle, I straight away went for a left bundle. So went for a left bundle pacing, couldn't get a very classical left bundle ECG, but still got a very good left bundle RBBB kind of pattern and total QRS duration of around 120 milliseconds. So fairly decent result for a dual chamber pacemaker. Now this was my first his bundle pacing for CHB with LBBB and EF of 25%. Patient presented with this rhythm, complete heart block in emergency. This was the rhythm. When his rhythm came back, it was LBBB and his EF was 25%. And before doing left bundle pacing, I just put the lead at the his bundle site, and this was the result which I got. So I screwed the lead, and I thought, okay, let's see what are the voltages. Now, incidentally, this is the case. This is my only case where I got the best result of his bundle. So the correction thresholds was 0.7 at 0.5. So it's amazing what things can happen. You never know. So it's always my first, protocol is always try his bundle first. If it works, you never know where it might work. And if it doesn't work, then go for left bundle pacing. After that, I've done many cases of left bundle for CRT. This is again left bundle for CRT, left bundle for CRT, and left bundle for CRT. So all these cases, left bundle for CRT was done after trying his bundle. So like in the previous case, what I have found is that if you take more of these diseased infrahisian conduction system patients, my chances of successful his bundle implants were around 50%. Maybe it's different in some other centers, but that's what I have found. So my threshold for going to left bundle pacing is somewhat lower for these type of cases. If it's a narrow QRS, then definitely I would try more for his bundle. And because of my subset of these patients, so many CRTs and poor LV patients, his optimized CRT was something which I stumbled upon quite early. So we know about this study. So these are my cases of his bundle. So this is the first case. Now this was a classical left bundle. Actually, Dr. Ullas pointed out in the previous talk about this. What's the use of doing hot CRT in this case when your his only pacing is getting, his only capture is giving a QRS of 106 milliseconds. I agree, not much. But I mean, this was one of my cases of putting a LV lead along with that. But this was the case, second case where hot CRT actually helped. Over here, the LV pacing, LV first was not good. Simultaneous pacing was, his alone pacing was also not good, whereas the simultaneous pacing was good. And again, this was a left bundle pacing, not a his bundle pacing. This is again left bundle pacing for hot CRTD for RBBB patient. This was a few weeks back. This patient was native RBBB QRS, native QRS duration of around 170 milliseconds. From his bundle, nothing got corrected, moved to left bundle pacing. LV first didn't give much. When doing a left bundle pacing, isolated left bundle pacing, I couldn't get a classical left bundle pacing electrogram for this patient, in spite of taking a support of a CS sheath. So around 5 to 6 times I have to take a CS sheet support to screw the LV lead in. But in spite of that, I was unable to reach that site. But after doing hot CRT in this case, as you can see over here, we are getting by doing LV 21st, we are getting a very narrow QRS of around 116 milliseconds in this case. This is again left bundle pacing for hot CRTD for atypical LPBB. So this was again one case for atypical LBBB. Now let's talk about failures. It's not that I have not failed or there was not stumbling blocks. The first case which I failed, again, I was choosing probably the wrong type of cases. So this case was explanted ICD. Now this previous ICD lead was there for last 10 years. So I don't know what it would have done to the septum on that side. I tried his bundle pacing, I tried left bundle pacing, and this was right side. So explanted lead and a right-sided his bundle. So I was unable to get, no matter what I tried, I was unable to get that. So did a conventional CRT over there. The second case was atypical LBBB. This was yesterday's case. Atypical LBBB, superior axis, V1 to V6, everything was negative. It was very weird ECG. I couldn't take it because it was just yesterday. DCMP and EF of 20%. I tried with whatever things possible, but couldn't get it done. I would love to do a hot CRT for this patient, but only pacemaker was the available option. He was not affordable, so couldn't fix that. But yeah, this is one of the failures. Now, Dr. Shunmukh pointed out that in DCMP, sometimes if you have a LV, a mid-myocardial scar in the septum, no matter what you try, you wouldn't be able to go through the septum. So I took the CS sheath support in this case, but in spite of that, I was unable to go through the septum. So these are the failed cases. Now, what are the problems which I faced and how I overcome that? CHB while manipulating is pretty common. I mean, Dr. Parikshit said 7%, but for me it is roughly to the tune of 25 to 30% that I get CHB or RBBB. So I always keep TPI, but initial cases which, when I was manipulating with TPI, his sheath has a curve, so it just pulls back the TPI sheath. So from that time onwards, I started putting the RA lead as a TPI, and it works pretty well. So that was my learning. RV side septal fibrosis and mid septal fibrosis, you have to change multiple sites. That's the only way to get rid of it. Lack of support for screwing the lead in the septum. Now, I have had few cases in which the heart was really like a football. His sheath couldn't even reach there. So I had to take the CS sheath for support to finally eventually get there. So reshaped CS sheath for sheath in sheath support and kinks in 315 sheath. Now this I have faced twice. If suppose we want to get more support and we give more counterclockwise turn, now this 315 sheath is not that stiff as the CS sheath. So instead of giving too much counterclockwise turn to the 315 sheath, which can cause kinking, and if that sheath kinks, you will never be able to give the torque to the lead and you will have a spin back. So so now my threshold for taking a backup CS sheath for support is lower after seeing these two kinks. So these were the problems and these are the solutions. So my conclusion is that don't get disheartened by some of the failures that you will get in initial cases. Like in my cases, I have been exposed to his bundle for 4 years before actually taking it on seriously. And you have to decide for yourself. Once you taste the success, like I did so a few months back, it's those cases when you see the QRS has narrowed so much, then you decide and convince yourself to go for this physiological pacing. And after that, you just have to strive. It's not easy, believe me. I mean, it looks easy, but sometimes what I have seen, I have myself have spent 2 hours, 3 hours in certain cases. So it might take more time, but let's not get discouraged by that. I mean, initial CRT also used to take 3, 4 hours. And remember, it's the first generation hardware which you are using. It's not the second. Things are not made for his bundle. So it might take more time right now. But we should not give up on this physiological pacing thing as of now. So thanks a lot.
Thank you so very much. Yeah, so you know what, let me just bring out some of your points. You see, I think your practice is great. The way you explore the his bundle area. Even though now you have seen much more positive results with the intraseptal pacing. You hinted to us that you would like to explore the his bundle area first.
Yes.
Is that what you said?
Yes,
right.
Always.
So great. You know what, that I support a lot. I go one step further. One step further. When we explore, especially with the left bundle branch block, before crossing the tricuspid wall, 70% of the time, see the volume is not large, okay? Maybe we're touching about 100 now. Before crossing, exploring, and then getting, it is possible, according to me, 70, maybe 60%. Then I switch on to the CS lead if I wish that it has to be a CRT kind of a thing. Now this is one approach because I'm scared about this intraseptal issue. Yeah, intraseptal alone, achieving a narrow QRS, I believe, is also about 70%. But if I put in his bundle area and then the CS, it's like 90% of the time I end up in having a good result. Now please tell me, what should be my approach? Should I try after exploring the his bundle area and go and then poke there and then hope for that 70 to 90% of the time getting a narrow QRS, or you just put an LV lead? In our patient population, people afford. This hospital caters to a little more. Yeah. So affordability has not been such a major concern, and I don't want that affordability to come into picture.
Are we talking about this hospital's patients or your patients, Ullas?
See, hospital patients, not only. The interventional guys are quite more famous than me.
I see.
Okay. They get heart failure patients and then give it to me. Okay.
Yeah, so it's an interesting question. The honest truth is you have to first define what's the substrate you're dealing with. So like I said, if it is a very classical left bundle branch block, and the wider the left bundle branch block, the more likely it is to narrow. Okay, why is that? Because if the left bundle branch block is more proximal, if it's truly proximal disease, the QRS will be much wider, right? So typical left bundle branch block looking, not an IVCD looking wide QRS. So if it is a typical left bundle branch block, I think conduction system pacing by itself should be sufficient. If you see partial narrowing, but I'm not seeing complete narrowing, you need to map a little bit more. And I'll show you some examples of that. If it is an IVCD type pattern, where maybe you partially corrected with, maybe it's a mixed disease, there's some left bundle disease, there's some intramyocardial disease, then I think hot CRT will be the ideal strategy, because you can partially correct the QRS with his bundle pacing and combine it with CS lead pacing, and you'll get the best possible result for that patient. So I think you have to take it back to the substrate you're dealing with, and then choose your strategy accordingly.
I think you got to tell us a little more here. Without the CS lead, if you have not got the good narrowing of the QRS, this intraseptal, if you do, what is the percentage you think we should expect in general, and typically with the typical left bundle branch block?
So with a typical left bundle branch block, based on currently reported literature, the success rate for his bundle pacing is between 80 to 90%. Correction, typical left bundle branch block. If you add left bundle branch area pacing to that as a strategy of conduction system pacing, 95% plus chance of narrowing the QRS. If it is a typical left bundle branch block. So maybe that's why I said you got to take it back to, is it typical or not? If that's the case, conduction system pacing should work 95% plus.
Can I ask you, what is the percentage of getting a good narrow QRS with his bundle area and then the CS lead?
Together?
Yes.
I don't know. I have not, except for hot CRT, which is again a very limited subset with IVCD pattern patients. We've not done that for left bundle branch block patients. So I don't know.
So I was thinking that actually would result more often optimal QRS than the intraseptal in gen. See, again, it is just an experience, not necessary.
No, I mean, so we've seen QRSs of 80, 90 milliseconds with correction. And so then we wonder how much more narrower can you make that QRS with adding a CS lead. So that's where it's.
Yeah, I think the experience is accumulating. Maybe we should wait for such data.
How you connect CRT, hot CRT, D?
So we take bipolar, we take these DF1 leads. So the device has to be DF1. So in DF1 device, in hot CRTD, what we have done is, instead of keeping it at his position, you do left bundle. So all my hot CRTDs are left bundle. So I don't miss out on sensing the R waves of the right side.
That's why
so
that is the problem.
Yeah, so we call it his optimized, but actually it's left bundle. The hot CRTDs which I have done.
So you can also plug in the CS lead into the RV pace sense port and do his bundle. That's also the.
Yeah, that's for sensing, for RV sensing. Yeah, that also you can do. But what I do is go for a DF1 lead.
Yeah, that's what I mean. Is DF1 lead.
Yeah, okay. Instead of, so epicardial sensing. Yeah, that's fine. Yeah.
But how accurate is the epicardial for VTVF sensing?
It's been reported.
Okay.
People have done this they put the LV lead in the RV pace sense port for DF sensing. You get nice R waves of more than 10 with LV.
Okay, then.
Avinash, excellent presentation.
Thank you, ma'am.
I have one question and one comment.
Yeah.
My question is the cases that you showed, the two failed cases.
Yeah.
Out of them, one of them you showed was the old RV defib lead which was there.
Yeah.
I did not understand why were you saying that lead would have, not made you possible to have a his bundle pacing? What were you trying to say? I did not understand.
Okay, so my thing was that if the RV loop is there, so you're implanting a ICD lead and it goes with a loop. And if the loop is touching at the same place where traditionally you will put a left bundle pacing lead, that area with repeated touching, because for 10 years it was touching and going, that area could have been fibrosed. It's a hypothesis, I don't know. I mean, maybe it was not fibrosed and we are not getting support from the right side, or maybe some other reason. But it's one of my hypotheses that why I was unable to screw inside the septum at that site.
Did you try his bundle? Because you
Oh,
don't
yes.
have to go into the RV.
I tried his bundle.
You don't have to go into the RV, you are just above the tricuspid.
So this thing, this is the his bundle location. So, so this was at the his bundle location. I was unable to correct from there. So that's why I went low and tried for left bundle also. I was unable to correct from there also.
Okay.
Yeah.
So my comment is you said 2 cases done in 2015, which both of the leads failed. Was that with
Not exactly failed. One is still working, but the threshold was high.
Threshold is high. Yeah. Both of the cases, 2 cases you did. The first 2 cases, they were with Professor Zenon.
It's the same
Okay.
time.
The same day we did 2 cases.
Okay.
So now next time you say this, you can say it was a 50% dislodgement because both of our cases are doing well. No dislodgement, no rise in significant rise in threshold. Yeah. Just a comment.
Yeah.
Thanks.
Predominantly septal, then the his bundle pacing might be enough, and if they're more parietal, then these would require that additional CS lead. Any news on that?
No, that's a very good question. So I think you start thinking about the disease process and of the QRS you're seeing, right? So, like if you see a QRS that doesn't fit your typical right or your typical left bundle branch block pattern, and you're seeing septal scarring on MRI, you're pretty much convinced conduction system pacing might not be the answer for that patient. So that's additional evidence to help support that theory. But I think we've been surprised from time to time as well. Like, even in this previous case that Santosh just did, we predicted that there's a little R wave in V1, disease is not as proximal, his punctal pacing may not completely narrow, which is exactly what we saw. Despite finding a distal site, a proximal site with a long HV, we didn't anticipate that's going to correct. Distal site with a short HV still didn't correct. And left bundle branch pacing we thought should correct, which it finally did correct. So I think that's putting 2 and 2 together. Combining it with MRI information is only going to aid your thought process ahead of time and know what strategy you're going to pick and choose. But I do think that we can refine the ECG a little bit more to help guide us, and it's not always, so far I would say I've been able to get to 90-95% accuracy in terms of saying, okay, I think I know what we're going to be successful with here, but adding MRI to that might actually give us much more.
So in your practice, what is the percentage of patients his lead threshold has gone up and you need to revisit?
Yes, the correction threshold has not gone up significantly. I don't have a very long-term follow-ups, just 4 months follow-up. But all those patients, the correction threshold has not moved much.
You'll have to make.
So if the usual correction threshold we accept is anything less than 2. So it has not gone beyond that.
Because that is the main concern in, I think, in his bundle pacing. Is there any strong or predictor to suggest that the his bundle threshold we have achieved today will remain, is going to remain? Because
so if you get an injury current, Dr. Parikshit has published that. So if you get a good injury current, your the thresholds are much likely to be stable long term.
But in some of the cases we have seen it is not a very foolproof or very authentic, because in one of my patients at table everything was fine, threshold was around 1, but during discharge it went up to 4. So we used to check even pulling the sheath away from the lead and checking it. That is one way of also they are saying. So in our institute we predominantly go left bundle as a first strategy because of we always seem, or we are something says that his bundle is going to be less, the threshold issue is going to be the problem.
So you have to, yes, that is something to be concerned about. That is something that we are always worried about. So based on current literature, there is an increase in capture threshold of the His bundle, in the His bundle leads, in about 10 to 14% of cases, by more than 1 volt from the time of implantation. The concern isn't that the threshold increases, the concern is that the threshold increases in an unpredictable fashion over time. What you're describing is lack of implant experience. Again, I don't know how many cases you've done, but if the threshold increases before the patient goes home, that's not a result of the increase in threshold we're talking about. That's a result of fixation being inadequate at the time of implant, or the patient moving where the lead pulled, micro dislodged. When we talk about increased threshold with His bundle pacing, we've seen a very small percentage of cases where the threshold rise can happen 2 years from the implant. Majority of them tend to happen between 3 months to 9 months,
6 months, yes.
but rarely they can continue to rise with time. The good thing is, firstly, these leads don't dislodge. If they dislodged, again, that's a function of inadequate fixation. So they don't dislodge, and if the threshold goes up, it gradually increases and starts creeping up. So once you see an increase in threshold by more than 1 volt from the time of implantation, you bring the patient in more frequently for frequent checks. And you'll know if it's stabilized or if it continues to go up, and you can intervene. The difference with left bundle branch pacing is when that lead dislodges, your patient's either going to be dead or you're not going to have enough time to act on it. And I've had 2 of those cases now. Luckily, no one's died, but.
So,
yeah, I may disagree with Parikh on that. So the only paper so far published on the long-term outcomes of His bundle pacing is the Vijay Raman and Frank Zannon's paper, published in JC in 2019, I believe. They have 844 patients who got His bundle leads. And then if you look at that paper carefully, the thresholds, they looked at the thresholds. Threshold more than 2.5 volts at 1 millisecond at a median follow-up of 3 years was seen in 28% of the patients. It's not 10 or 15%. It's 28% of the patients had thresholds more than 2.5 volts at 1 millisecond. 9% of the patients during the follow-up had septal pacing morphology. So what does it mean? They had His pacing or non-selective or selective at implant, but at follow-up, when you check the ECGs, their pacing morphology changed to septal. So they lost His capture. So that was 9%. So 28 plus 9, 37%. The lead revision rate was about 8% in that case series. So we do have some, I think, problems with His bundle leads in long term. Sure.
No, so Santosh is not wrong in stating that, but I think you have to take some of that data. That is very dirty data. That is data, the way the 800 and something patients were from back in 2005 when Dr. Zannon first started doing his bundle pacing. He used to use a different delivery sheet at that time. We used to accept thresholds of 2.5 to 3 volts at that time, and all of those practices have changed significantly. We're now not accepting anything more than 1.5 volts. We've learned so much more. I tell people when we do these implants, you want to make sure your unipolar and bipolar capture thresholds are as close to each other as possible. So there's all those things that we've learned over time, and the experience with these implants has only really picked up after 2011, 12, 13. So if you actually go back and collect patients from 2005 to 2013 in the early experience where we didn't even know what was the right implant techniques and start following those patients, you will be getting skewed results. So I think there is a little bit of that. Those numbers are right, but I think that data is very dirty, and that's why I don't quote it. Because if you look at the largest series, which was Dr. Vijay Raman's series from 2013 to 16 after a few years of experience, the rate of increase in threshold was about 13 or 14%. Just increase in threshold. The revisions were only 4.2%. So my bigger concern is when the thresholds increase in an unpredictable timing. We don't know when that threshold will increase. If it increases 2 years in follow-up, then that is a challenge in which Is that related to the region? Is that related to the lead? We only have used one lead in this area so far. And that lead is not even steroid eluting. And we know that we need steroid eluting leads to prevent some of the fibrosis that happens in association with them. So it is steroid coated. You basically take the helix of that lead, a factory worker dips it in steroid, and steroid coated. And you know how many times you have to clean the tip of that lead. So guess how much steroid is left on that by the time it actually goes in the patient. So we don't know if that's a factor that plays into the behavior that we're seeing in some of these cases, whether it's where is the location of disease, whether it is movement of the lead with the tricuspid annulus, or whether it is steroid. And hopefully we'll have some of the answers as we use other leads, and we'll find out either some of them are much worse or they're much better. So
are there any more questions? Yeah. So.
No, generally not. There's a couple of case reports of persistent heart block after the lead has been screwed in, but there have been multiple cases where we've actually screwed in and they've taken it out and screwed it back in. We've not seen, although the other extreme has been reported.
Dr. Parikshit, what is your experience on the right-sided implant? And also you showed on Boston Scientific sheath has come up with the right-sided for the right-sided.
So far, I have not had a failed right-sided. And I think we've done close to 50, 60 of them.
Use the same sheath, the
C315. You can reshape it a little bit and that can help. I'll show you that in my implant.
Thank you.
All right, so thanks Avinash, it's a great data what you presented. Well, I think we can go for the lunch. So we will disperse for the lunch. Lunch is served on the right side.
Most important.
Most important.
नहीं वो तो इवनिंग में
इवनिंग में दारू नहीं रहे
I decided to make it a little bit more than basic step by step. So I know a lot of you guys have at least been exposed to the basics. So this is going to be a deeper dive, so to say. And hopefully this will also, as I'm seeing this ECG on this next case, hopefully give us some more insights into the next one. So it'll tie in nicely. So we're going to talk really quickly about the standard tools and the setup. How to perform historical pacing, which I'm not going to go through how to get access and all of that stuff. We're going to jump right into the more challenging implant cases, which is the more fun part. And then we talk a little bit about more advanced techniques so that you can sort of have more tools in your armamentarium. So the standard tools, as we already saw earlier today, so there's the 3830 His lead, which is a 4.1 French ISO diameter lumenless lead. It has an exposed helix, so that needs to be kept in mind. You need to make sure that the helix is never exposed outside the sheath so that it does not get caught onto the myocardial tissue. The sheath is the C315. This is your go-to sheath. This is the only one that's available here in India. And there's a curve that points the sheath towards the RV, and then a septal curve that points it towards the septum. Now it's very important to remember that the motions or the clock and counterclock on this sheath need to be very gentle and very purposeful. They're not big crude motions. If you make big movements, this sheath will go all the way from the septum to the lateral wall. You really have to do a few degrees at a time. Sometimes you may get stuck behind the tricuspid annulus. You just have to pull back and then you clock. With a little clock, the sheath should really move quite a bit. If it's not moving, that means you're stuck somewhere. So pull it back, free it up, and then start again. We said the other sheath that's available in the US is the C304. This is deflectable, so using this knob, you can actually put a rotation on the lead and you can get up higher on the AV annulus. The challenge is that the 304 did not have a septal curve, so we helped design this 304 His sheath, which now has a septal curve. And in addition to being able to help us get up higher on the AV annulus, it also has a septal curve, so it helps you deliver the lead as well. The differences between the The C315 and 304 His are that the 315 is only pre-shaped while the 304 has the deflectability with the septal pre-shape. They're both equal in length, 43 centimeters. This is 7 French outer diameter, while this is 8.4 French, because the ability to add deflection to it requires cables, and that makes the sheath much larger in size. We also talked about how Boston Scientific now has their new set of sheaths for dedicated right-sided designs, multi-purpose extended hook for their own lead deliveries, and you might have access to this. But again, like I said, be careful with using extendable retractable leads until we have more information, or at least don't use it on patients that are going to be dependent. Again, similarly, the Biotronic system, the Solia lead with the Selectra 3D family of catheters with different lengths and different, the small, medium, and large sizes. That's going to be available. It's already available in Europe, should be available in the US by the end of February, beginning of March. So again, you always want to hook it up to the recording, to the PSA. Currently, because we predominantly do cases with Medtronic as the Medtronic PSA. On the Medtronic PSA, we hook it up in a unipolar fashion to the atrial channel. Why? Because the atrial channel allows a gain setting of 0.05 millivolts per millimeter, while the ventricular channel will allow only 1 millivolt per millimeter. You set it up for a sweep speed of 50. Why? Because if you leave it at 25, which is what most of your reps will do, you might miss a His signal because it might be too close to the A or to the V, and you may not appreciate it. Like I said, we learned a lot by hooking these up to the EP recording system. So the more you have access to it, try to do this, because you will pick up on things that your supporting rep will not. And then you will realize that you were doing things based on what they told you and not what you tell them. And for something like this, you're more knowledgeable than they are, and you can only educate them. So the recording system, we usually set it up as 2 channels of filtered and unfiltered electrograms. That's the settings. So filtering from 30 to 500, and unfiltered basically means you open up the high pass and low pass band filters. That allows you to appreciate injury current. So here's an example of a patient where you have an A, His, and a V recording, and you see very nicely before the lead is even screwed in, you appreciate a large amount of injury corresponding with the His electrogram, suggesting you're making good contact up against the septum, and that this might be a site where you might only have Hisian capture, because there's not a lot of injury on the ventricular signal, not a lot of injury on the atrial signal. So predominant injury is Hisian. And then again, the most important tool is the 12 lead ECG. Having all 12 leads is key, particularly for the first few follow-ups, and then anytime you're trying to troubleshoot any issues, 12 leads are important. How to perform His bundle pacing, I think I'm only going to show one slide on this because we want to talk about the more fun stuff. So this is a summary of how we perform His bundle pacing. That's again in that Nature Reviews paper. That's a good go-to in case you have questions or you want to learn more. So obtain venous access. We recommend obtaining a separate access. Don't double wire. If you double wire, you're likely to increase lead-lead interactions as you're adjusting the slack on another lead, and that might pull your His lead back, and then you can't re-advance the slack back in with the His because it's lumenless. So a separate access. A 7 French peel away is what we recommend for the 315. Advance that into the right atrium or the right ventricle. I want to pause here and talk about this a little bit. There are 2 different approaches to doing this. One is you can advance the wire and the sheath into the right atrium, and then you advance forward towards the tricuspid annulus. The second is you advance it all the way into the RV, and then you pull it back towards the tricuspid annulus. Both of those have their own pros and cons. If you start on the right atrial side, you're more likely to find the proximal His first, which might be a great site because once the His is more proximal, you don't have a lot of ventricular tissue. When you pace there, you get selective capture, and you're very tempted to take that, while that might not necessarily be the best site for that patient. So proximal sites, you're more likely to see atrial oversensing. proximal sites might also be proximal to leveler block, and you may not see that during the case. So you really have to pay attention to if you're going to take this approach. The other issue with this might also be if you're actually going to advance from the A to the V, you might actually pin or go through a cord of the tricuspid valve and get that stuck in your lead. My preferred approach is to advance the sheath all the way into the ventricle, advance the lead into it just to the tip of the sheath, and then start pulling back until you get to the tricuspid annulus. You're more likely to find the distal hiss almost right away. You're also less likely to get the tricuspid valve stuck in the apparatus. The only downside could be you could actually, ding the right bundle. So you just have to be mindful of that. There's pros and cons to either one of those approaches. So you advance the lead to the tip of the sheath, not beyond the tip, just to the tip, and start recording unipolar electrograms, map for the His bundle. If you can find the His bundle, you pace at that site, you like the response you see, you go ahead and fix the lead. If you cannot find the His bundle, start pace mapping. The idea behind pace mapping is as you get closer to the conduction system, your QRS will start getting narrower. And that will just give you a cue as to where you should focus more time and effort and what do you need to do to get there. If those don't work, and you suspect that the hiss is more superior or more distal, the first step I usually do is I reshape the 315. The way to do that, you pull the entire system out of the body, leave the peel away sheath in, pull the sheath out all the way to 315, flush it, pull the dilator back in through it, and manually reshape it. So here's the proximal curve, here's the distal curve. You manually put a curve on the proximal end so it'll get you higher. You manually put a curve on the distal end if you need to get more septal. So you can manually reshape the sheath, but remember to do it with the dilator in through it, because if you do it without the dilator, the sheath is going to kink. So you can reshape it and then go back in, and hopefully that can get you to a different spot and find the hiss or deliver your lead. And if that fails, then we either go to a sheath-in-sheath approach or to the deflectable sheath, depending on what we need to achieve. So the challenging implant is what is important for all of you guys as you gain more experience. What are the challenges? So the challenges are location of disease. Anytime disease is infranodal, then it can be a more difficult case and you have to have more patience, you have to have more experience. So intrahissian disease, bundle branch blocks are more challenging implants. Anatomical variations. Right-sided implants are oftentimes challenging for inexperienced operators. And a very enlarged heart with a massive right atrium or right ventricle causes the His bundle to get displaced, which may make it challenging as well to get to that site. So here are some modified tools that you could use in such cases. So we already talked about reshaping the C315. It can help you get higher on the AV annulus, and it can also help with right-sided implants because you can reshape it up here by the SVC innominate junction. Reshaping the 304, again, I don't think this is very valuable for you guys here, but the 304 His, which has now got a septal curve, also helps. The sheath-in-sheath particularly can be very helpful for the audience here. It can provide you more distal reach. So if you realize that the right atrium, the tricuspid annulus is more anteriorly displaced, then use a sheath-in-sheath approach. How does that help? Because the CS sheath is a stiffer sheath, and that provides you the support so that the 315 can get more distal into the ventricle or at the annulus. So use a sheath-in-sheath. The one, if you only have the choice of taking one sheath, just remember this, one sheath for the CS sheath, the only option you have, take the multi-purpose right. The right-sided multi-purpose from Medtronic is, in my opinion, I have tried at least 10 different CS sheets, works more than 90% of the time, okay? And you have to cut the CS sheet so you can accommodate the length of the 315, so it can be a little bit of a challenge slitting the CS sheet after, but we can talk more about that if you guys are interested. So here's an example of reshaping the 315. So as I said, you see this is the level of the septal curve, this is the proximal curve. I put a manual curve here so it gets a little bit higher. As soon as I take the dilator out, see how much higher I can get on the AV annulus. So you can get higher on the AV annulus using this proximal curve approach. So mapping in the setting of infranodal AV block. We touched a little bit upon this, but this is very, very important. If you do not follow these steps, you will start seeing an increase in threshold, or you will start seeing loss of capture from the lead. So this happens, and a lot of the early experience cases where we've seen increase in thresholds could be related to the lack of doing some of these things that we've learned over time. So things to remember. Always want to ensure that the lead is distal to the site of disease. And how do you ensure that is the case? Always map for a distal His potential. So if you have a patient with intermittent AV block or intermittent AV conduction, then on the conducted beats, make sure you're looking for that distal His. Make sure that your distal HV is short. Less than 60-65 milliseconds is probably the upper limit of what I would expect, or I would accept, not expect. Ensure that the capture threshold is low. If it is a narrow QRS, make sure your His bundle capture threshold is less than 1.5. If it's bundle branch recruitment, make sure that the bundle branch recruitment threshold is less than 2. Ensure that there is no significant His Purkinje axis disease distal to the site of implant by pacing at a faster rate. So let's say, for example, it is a 50-year-old that needs a pacemaker. Hopefully that isn't the case, but we see that from time to time. But it's an active patient. So you probably are going to program the upper track rate to 150, 160, depending on how active the patient is. You have to pace that lead just a half a volt above his capture threshold up to 170, 180 beats per minute. You have to go at least 10 or 20 beats per minute faster than their upper track rate. Why? Because if there's any disease distal to the tip of that lead at the time of implant, you recognize it then and there rather than find out that it happened down the road. And finally, majority of these cases, your lead ends up more distal to disease. This disease is infranodal, and in those cases, you will have non-selective capture, and that RV capture will act as your backup anyway. So these are all good things to have in cases where disease is more distal or infranodal. Now here's a good example. So this was a lady, 55 years old. She developed exertional AV Wenckebach and right bundle branch block. It was very interesting. 2 months ago, she had a PR interval that was 160 milliseconds. Then suddenly she starts complaining of dyspnea on exertion. She's very active. She had mantle radiation to the chest 20 years ago, and now her PR has suddenly jumped out to 360 milliseconds, and that has correlated with her symptoms. So we put her on the treadmill. She has a PR interval of 550 milliseconds and Wenckebach, and she's clearly symptomatic at those times. So we bring her in for an implant. So this is the first part. You find an AHV. This is a published case. The AH is 300 milliseconds. The HV is 150 milliseconds. Right? So just because you find a His doesn't mean it's a good spot. The HV is important. So the HV here is 150 milliseconds, and your right bundle branch block is 155 milliseconds. We did pace here. I'll show you what it looked like in a moment. This is the fluoroscopic location with the sheath and the lead in place. So now, as you can imagine, you want to get more distal because you want to find a distal His. So distal means you're not going to go here, you're going to go here. The conduction system runs like this in an RAO projection. So, but I'm not able to get any higher. So this is where I reshape the 315 like I showed you, so it can get higher and more distal. And as we get distal, this is what we find. A distal HV of 45 milliseconds, and an AH here is 400 milliseconds. So this was H1, H2 delay of about 100 milliseconds. And this is the fluoroscopic location of the second site. And look at how close they are to each other. Okay, so it's very subtle movements of the tip of the sheath or moving the lead around a little bit to get to that superior location. Now, this was the first spot with an HV that was really long. When you pace it high outputs at 3 volts, up to about 2.5, 2.4 volts, you had a narrow QRS, complete narrowing of the right bundle branch block with narrowing of the QRS. So just to prove the point, this case was, I think, on a day where we were doing a proctorship. So just to make the point to the audience, I said, let's pace at faster rate. So 2.4, 2.5 was Hessian loss of capture. So I paced the patient at 3 volts at 100 beats per minute, 110 beats per minute, 120 beats per minute, 130 beats per minute. Okay, so what you're seeing here is 2:1 exit block from the lead in a patient that's 50 years old. If this would happen when she exerts herself, she'd be back with the same symptoms she originally presented with. So remember to always pace at faster rates. So when we went to the distal site, we paced up to 180 beats per minute and there was no loss of capture from the His at a half a volt above threshold. This was her final pace QRS with complete recruitment of the right bundle branch block physiology. So mapping for the site of disease and putting the lead distal to site of disease. What about patients with a large right atrium or a cardiomyopathy? So here's an example of what can happen. You can have enlargement of the right atrium without displacement of the His bundle, in which case the C315 will probably work just fine. But you might have enlargement where the right atrium and the tricuspid annulus is displaced more anteriorly and the 315 does not provide you with enough reach. So here's an example where we reshaped the 315. That didn't give us enough reach. You see how far my lead is extended out. I found a His here, but it just still would not really work with us in terms of being able to implant there. And then we reshaped the 304 here and that worked. In some cases, you can do the sheath and sheath and that might be a better solution. This is just an example of how we had a good result. So finally, some advanced techniques. Left bundle branch pacing, you guys already heard about it. You'll hear more about it in the subsequent talks, so I'm not really going to dive too much into it. But you got to consider that in patients with very high grade AV block where there's alternating right and left bundle branch block or His lead capture thresholds of more than 2 volts, His lead revisions, and inability to correct bundle branch block with His bundle pacing, just like we saw in the previous case. So currently, those are the 3 indications for which we reserve left bundle branch pacing. You can also, we'll talk a little bit about His/left bundle branch pacing CRT techniques, and then finally fluoroless 3D guided mapping. So here's an example of this patient that came into the lab. Initially we said, I was told patient has complete heart block and right bundle branch escape rhythm. So I was like, fine, it's a right bundle branch block escape rhythm. As soon as he comes into the lab, he shows me alternating right and left bundle branch block. And clearly when you see that, you know that this disease is going to be more distal. So as we see here, when we start mapping, there's an A His with infra His block. We could not find any distal sites. We did find a distal site, but with complete narrowing of the QRS, but the threshold was 2.4. So the stim to QRS was short. We didn't see a His there because complete block, you're not going to find a distal His. But the threshold was high, and that's sufficient for me to say I'm not going to be comfortable accepting this. So we decided to move on to left bundle. So here's an example of the capture morphology. Look at this complete narrowing of the right bundle branch block, but the threshold high. So we decided to leave that lead in at the His, use that as a marker, and place a second lead distal into the left bundle branch. And you can see here, I don't know why some of my videos aren't playing there. So you can see her lining up of the septum right there, and the lead with its proximal pole just making it into the septum. So this was the paced morphology here with a threshold of 0.5 at 0.4. This was the echo image of the lead, demonstrating where the lead tip is. Okay, I apologize, this is stuck. So anyways, that becomes your next strategy, as we said. So that's more advanced techniques. It's still not working. The next thing I wanted to talk about is like many people had this question earlier today about, how do you figure out whether we should do conduction system pacing, should we do bi-V pacing, things like that. So, we have been doing this with what we call the biotronic vision wire. It's a wire that you can put out into the CS in cases where we're unsure. So I'll show you an example of that in the next case, and that can really help you figure out what is the best strategy for a given patient. Okay. So, so here's an example of a patient, right? So if you see this patient, she has what seems like a QRS of 150 milliseconds. There's not a lot of R waves or Q waves, but there's a lot of fractionation, AVR, AVL. There's multiple, there's leads with a lot of fractionation, multiple components. That always concerns me, because when you see that, then you have to think about multiple levels of block or multiple areas of intramyocardial disease or delay. So in this particular case, she has a non-ischemic myopathy, EF of 15 to 20%, and what we think is a left bundloid QRS. So I'm not sure what's going to work really well for her. So I'm going to go ahead and get access into the CS. So I already know I can put a lead there. So this is what we did. We got into the CS, nice juicy lateral branch. So we decided to put this wire that's coated, electrically active at the tip. So sub-select into that branch and put this wire into the lateral wall. The QLV here is 120 milliseconds. So we know it's a very delayed lateral wall activation. So now we say, let's start mapping the conduction system. So we get to this site. It's a proximal location. Why? Because the A is really big. This is the fluoroscopic projection in RAO with the lead there. We pace here. The QRS does not narrow. We go to a slightly different location. This is fluoroscopically slightly more anterior and superior to this spot. And the A is a little more far field. The HV looks nice and short. And we pace here, and the QRS looks better. We're like, okay, you know what? This is not bad. And the QLV is 90 milliseconds. So this is where a lot of people will stop and say, hey, you know what? I got a good result. I should accept this. Or we might actually put a CS lead and do hot CRT. I would urge you to map for a few more minutes. So we want a little bit more distal. So fluoroscopically, we went from here to here to here. Okay? We found this spot. Base QRS of 86 milliseconds and a QLV of 70 milliseconds. Now what's interesting, here is the RV septal electrogram. Here is the LV lateral wall electrogram. Look at how simultaneous that activation is. Okay, this lady was a super responder and her EF is now 55%. We've done 9 cases like this now where we use this sort of a methodology to figure out what is the best strategy. Should it be HIS? Should it be left bundle? Or should it be a BIV? And finally, low fluoroscopy. I think we've shown this before here and at other conferences, but we published this paper in Circulation where you can actually use a mapping system to tag your HIS points and place a lead fluorolessly. Doesn't have to be done fluorolessly, but if you tag your HIS points, you can actually have a precise target to go place your lead, and you're not spending that much time and wasting time about it. Here's an example with EnSight where you can actually tag the points where a QRS narrows, make them green, and the points where the QRS doesn't narrow, make them yellow or any other color, and then you could place the lead at the spots where the QRS narrows. We just started a randomized control trial that's called the fluoroless HPP trial, looking at exactly this in patients with a left bundle branch block to see if we can get more precise localization and decrease procedure times. Here's an example of actually a left bundle branch pacing using an EnSight system. This was a case courtesy of Dr. Vijay that he published in JCE. So clearly you can decrease fluoroscopic exposure using 3D and electroanatomical mapping. It takes a little bit of getting used to. The maps don't really take that long. It takes an additional few minutes to do a full map, but for cases like CRT or where you anticipate that anatomy can be challenging, going and tagging your His point on a map and being able to track your lead and take it right there, nothing better than that. So tips for a successful implant: you gotta know and understand the anatomy of the conduction system, understand the disease pathology and where is the level of block, so you're able to identify it, know the tools available for the implant and what options you have in different scenarios, and an individualized approach to implantation based on the anatomy of that patient and the level of conduction system disease. So again, like we showed earlier, you start with His bundle pacing. If the threshold's high, or if it's a His lead revision or failure to correct a bundle branch block, go to left bundle branch pacing. If that fails and the EF is normal, do RV pacing, and if EF is low, then do bi-V pacing. We'll stop there. Thank you. Questions or concerns? I guess everyone's post-prandial.
The vision wire, you talked about the 1.4 centimeter, the distal tip is uncoated. So it's a huge unipolar antenna, right?
Mm-hmm.
So what you can also do is put a 5-inch vert all the way down to decrease the size of that. So that you probably will get a precise measurements.
I mean, that depends on what we're doing in terms of, so we usually will collect data on, of course, the timing. For the timing, I don't think it's as important because we just want to see how long it takes to get to that area. Oftentimes we'll curl the vision wire in that branch so it becomes generally a smaller region. Pacing is where it matters, so we usually will do bi-V pacing where I'll pace the RV lead and the vision wire almost simultaneously. I think the shortest you can make the VV interval, you basically pace it like a dual chamber, so it becomes 20 millisecond offset. And we'll look at the bi-V paced QRS morphology and the bi-V paced QRS duration. And then we'll start performing conduction system pacing. And if conduction system pacing gives you a worse QRS and does not pull the LV lateral wall in, you're done. You put the lead in the CS and move on. So at least intra-procedurally you can assess and you know what's the best strategy for this patient. And so far, we have follow-up echoes on 6 out of the 9 patients, and I think 5 out of those 6 patients have responded. So it might actually pan out to be a reasonable approach. Time will tell. Yes, sir. Basic.
How do you remove the tissue stuck in the screw part of the lead?
Yeah, I mean, it's there's actually a simpler way. You can make it more complicated if you choose to. But so the one step is, if you ever try to fix a lead at the His bundle, in the left bundle branch region, wherever the case might be, remember that the lead has an exposed helix. And if you've tried to fix it, there's probably tissue stuck at the tip. So anytime you're trying to reposition it or go to a different site, start from scratch. Leave the sheath there, pull the lead out all the way, flush the sheath so that there's nothing stuck inside the sheath. And then you got to make sure there's nothing at the tip of the helix. So what I generally do is I'll take a little gauze, I'll place the lead in my left hand because I'm right dominant. I'll place the lead in that gauze, gently wrap it around. If you hold it too tight, then the helix will get stuck in it. Gently wrap it around, counterclock the lead out. Counterclock the body of the lead, and anything that's stuck in the helix will stay in the gauze and it comes out. Sometimes there'll be tissue that goes into the well, the little well where the helix comes out. You might have to take a little needle to scrape that thing out that if it's stuck so badly, but otherwise it comes out easily.
So I was wondering, it is advisable not to use the sharp needle to remove this? Is it something to do with that?
I don't think that it matters, whatever works for you. The only thing I worry about is if we have to do this too many times, what does it do to the steroid on the helix?
Exactly.
That's definitely a big concern. And you don't want to have a lot of tissue stuck in there, because then otherwise it's going to impact your fixation for the next step. So the best you can do to clean it up.
When you discard that lead, in case there are more than say 2 attempts of taking it out and
I have never discarded a his lead, unless I'm worried about, the one time there was an impedance that was 3,000 and we checked everything else and something wasn't right. So my Medtronic rep was like, no, I'll give you a new lead free of cost, but don't use this, that's the only time we did that. I've never actually, not used a lead.
Yes. Okay. So there's not much fear about its functionality if you've done it 2-3 times.
No, unless you clearly see you've destroyed the helix. As you're pulling. Now, one other thing that I really want you guys to remember, taking that lead out, if it is stuck already, it seems simple, but if you do it the wrong way, you're asking for a lot of trouble. So, if you find a spot, you don't like it, especially at the his bundle region, there's fibrous tissue there, tricuspid valve annulus there. So you want to advance your sheath all the way back to the tip. We always test these leads. Someone earlier made a comment about we test these leads after pulling the sheath back. Even then our thresholds are high. You always test it by pulling the sheath back. You don't test your atrial lead with a J stylet in it. So why would you test a his lead with a sheath support on it? You always test the lead with pulling the sheath back. So if you don't like what you're seeing and you need to reposition, advance the sheath back all the way to the tip. So if here's your septum, advance it all the way, push it up against the septum. Rotate the lead body only 2 or 3 times, only. Even if it took you 12 turns, 15 turns to fix the lead, only 2 or 3 counterclock turns. If you overdo that, your lead will get stuck and it will not come out. I promise you that. So only 2 or 3 turns, and push the sheath forward, pull the lead back, one single motion. Generally, it will come out in one single motion. If it doesn't work, then gentle nudges 3 or 4 times, it will finally free up and come out. If you do too many counterclockwise turns, what we've seen in the perfused cadaver model is that the lead can actually get more tricuspid valve and annulus tissue stuck at its helix, and then it's really caught in that. Then it's not coming out. So I've had people that have called and said, oh, our lead's stuck, we don't know what to do. And I generally ask them, what did they do to begin with? And that's really what they did, is they thought they gave 10 turns to get the lead fixed, so they gave 10 turns to try and take it out. And that's what we've observed is why that happens. So just remember that that's key. And just gentle pulls with the sheath all the way to the tip, it will come out, but you just have to be patient if it takes longer.
So every time you are repositioning, actually you take out the lead and
Yes,
push it and see?
correct.
It's not like you just pull it out and place it
No, if you've actually fixed the lead, if you've tried to fix it, you always have to take it out and start from scratch. Because imagine you get to that next sweet spot and you're like, wow, this is the best spot I've ever seen. And now you have tissue at the tip. Who are you going to blame? Yourself. And you'll be like, shit, I just tried to save that 15 seconds to do that one step. And now I'm going to struggle for the next 2 hours. So.
How often you use a deflectable CS sheath for his bundle pacing?
So early in the early experience, I probably used it only about 5 or 7% of the time. I used to let myself struggle with the 315. Now I would say I'm a little bit more lenient with jumping to the next sheath, because it's just like with CS, right? If you try something for enough time, you know this is not working, it's not going to work, I need to try something different. So if I try something different, I usually try reshaping the 315 first. If that isn't getting me what I want, then either I will go to the deflectable or I'll do the sheath and sheath, depending on what is my concern. If I have an issue getting superiorly, I'll switch to the deflectable. If I have an issue getting more anteriorly or distally, I'll switch to sheath and sheath.
And how often the implant is above the valve and how often it is below the valve, tricuspid valve?
So I think that's depends on the level of disease. Where is the level of conduction system disease? If the disease is AV nodal, I think you're more likely to end up supravalvular, because you have the entire his bundle available for mapping and implantation. If the disease is infranodal, intrahischian or bundle branch block, I think you're more likely to be ventricular or infravalvular than being supravalvular. And to a certain extent, that is also dictated by the approach you take. So if you start on the atrial side and you move forward, you're more likely to end up on the atrial side. If you start on the ventricular side and pull back, you're more likely to end up on the ventricular side. So those are the two things that dictate it. I do believe most of them end up more ventricular than we think. Okay. Should we see the case for the afternoon? Yeah.
Thank you so very much. It was a great tutorial. Actually, we had lined up 3 cases for the day, but because of the evening symposium, I think let's do today. 2. Tomorrow, definitely 3. Seba, you may actually present us the second case.
Okay, check. So we are heading with the case 2, which is 68.
Sir.
Check. How will I see the slides then? Yeah. Okay, we are heading with the case 2. 68-year-old male diabetic who is a case of non-ischemic cardiomyopathy, severe LV dysfunction of EF 25%, NYHA class 3, and normal coronaries. His ECG shows sinus rhythm, LBBB, QRS duration of 160 millisecond, leftward axis. The QRS morphology here suggests more of conduction disease. So the plan, LBBB correction with dual chamber pacemaker, or CRT with quadrupolar or bipolar LV lead, or hot CRT with quadrupolar or bipolar LV lead, addition to AICD, if DF1 type required.
So you are the operator. So patient is yours.
Yeah, so let's go back to the ECG again. So again, like I said, I always like to look at these ECGs carefully. This is not that dissimilar from that first case we just saw. But the one thing I noticed here was that, again, if you look at what we have up there as well, there is a very tiny, if any, small r prime in V1. There's no Q waves in the lateral leads. I don't know if V5 there is lead positioning, but if you look at 1 and AVL, they're both pretty much R's. There's no Q's in them. So this to me tells me that, again, this is, distal his bundle might work here. His bundle pacing might work in narrowing this QRS. And again, if that doesn't work, then we'll have to go left bundle branch pacing here. But we'll do our due diligence with trying to map enough on the septum and find the His and see if we can narrow this QRS before we take the next steps. Definitely, I shouldn't say definitely, I never say never, but I think the likelihood of needing CS here is really small. And I don't know, unless we don't see significant narrowing with either one of those two strategies, I don't potentially see the need for hot CRT in this one either. Question about pacemaker ICD. Whatever the patient wants, I think I usually offer the patients what they want. In this particular case, is there any history of syncope or VT or anything of that nature? Yeah, so, I mean, I heard that the patient wanted to get a CRTD is what I heard. So that's fine. In the US, like I said, that's probably what we would do. Yeah, it never is for any of us patients. Was there a cardiac MR on this patient? No. No. Yeah, so. That answers that question. So yeah, so but I think that if this was a patient that we had followed from the past and there was a steady decline in EF with the left bundle branch block pattern present for years, then that would argue more that this is dyssynchrony induced. And but here we don't have all that information available. So I think we'll go with the strategy of a CRT system, and we'll figure out what's the best way to resynchronize the ventricles, whether it is conduction system pacing and resynchronization or bi-vein resynchronization. Okay, all right, let me go get started. I'll see you guys soon.
So thanks very much. So having heard the step-by-step his bundle, I think we are in a mode to learn, to go one step further for the left bundle pacing step-by-step tutorial. I think it, yeah, surely. So your presence will make everybody's life comfortable.
I know. My absence is.
I thought that's what you were going to say. And so again, Santosh, it's honor for us to have you again to talk to us about how do you do the subtle pacing. Yes.
Whole discussion of we've been having repeatedly about the need for a defibrillator. So for patients with non-ischemic cardiomyopathy, I mean, how my practice is changing, I want to learn whether we are doing the right thing or not, that in non-ischemic cardiomyopathy, a patient coming with left bundle branch block, start doing an MRI. And if the MRI is not showing that there is great evidence of scar, shift towards, no, but I want to understand from from people like Dr. Highgrave, Dr. Ashish. No. I don't want supporters at all, sir. I want to discuss this point.
You said crowd and then you focused on Highgrave.
Okay, I'll ask you. Okay, I'll ask you, what is your practice? You are my biggest supporter. What is your practice?
I'll ask him.
Yeah.
Are you ready to pay for CRTD?
Okay. No.
Okay, you see, best is CRTD. Okay, that is what has been the guidelines.
But that's what I want to discuss about this point, that I'm not doing that now.
It comes down to whether the patient is aware of a defibrillator entity, whether his relative is staying in the US,
okay,
whether he is a likely candidate to give you a trouble later on, not recommending a defibrillator to him.
So can I take the discussion to the next level? I recommend, but I tell them that let's do an MRI, and then a doctor can often take the patient where he wants.
Correct.
So I take them
so you
to
are
the
also
path
taking
of
the patient to wherever you want by
CRT3.
sending him to the MRI.
Yeah, so we need an MRI to see the scar.
That is just the beginning of a kind of an observation. It's not a recommendation. It is not.
That's what I want to understand. That where are we today? What are all of you practicing? I mean, should we still, if the patient can afford, go ahead with a CRT-D for non-ischemic DCLP?
Yeah. See, there are experts here.
Or
experts here. At least Santosh. Let us talk to Santosh.
Yeah.
Okay. There is a small discussion which took place intensely. Of non-ischemic cardiomyopathy. Let's not talk about the LBBB, by the way, or should we talk LBBB, non-ischemic? Yeah. So a Danish point of view also. See, non-ischemic cardiomyopathy, LBBB, candidate for a CRT. Well, there is now kind of a building up evidence that defibrillator may not be as beneficial.
True.
So section is saying that we do something more with respect to the risk stratification in the form of a scar quantification by MRI specifically, and then you decide. That is one. Another one is simply you suggest a CRTD because that is what is the guideline as for the date.
Yes.
And if the patient is not willing for that kind of an expense, well, you simply send for CRT. But again, making it more complicated. No, okay, let's see whether a scar is there, and then if the scar is there, and then making him to go for a CRTD. This is the discussion.
Yeah, I think again at this stage we're gonna offer him a CRTD, but there is no studies to show that patients with non-ischemic cardiomyopathy, low EF, benefit from ICD for primary prevention. Yeah, and that was shown in the Danish studies too. Yeah, still, but it made into the guidelines, so we just follow the guidelines. I agree with you. Okay, pardon my voice, guys. It's getting worse and worse. So I'm gonna.
You want to have a coffee?
I already had one coffee, so it's not helping. So we're gonna go step-by-step approach for left bundle branch area pacing. I have no disclosures. So we're gonna talk about step-by-step approach to left bundle branch area pacing, and then I'll try to give some tips and tricks for successful implant, and if time allows, I'll show some cases. So this slide, Parikh already showed it to us. So basically the tools available at this stage, you have a C315 his sheath and a 3830 pacing lead. The new sheath which is available, I think for the last, since last May I believe, in US, is a deflectable his sheath, and it definitely has improved the success rates for left bundle branch area pacing implants, especially in patients with enlarged hearts. I showed this slide in my first talk. So for the his bundle pacing, you're targeting this narrow, precise area, whereas for left bundle branch area pacing, you have a wider landing zone. You can either try slightly distal to the his, or you can come all the way up to mid-septum. Hence, I feel like it's technically easier, and you have higher success rates with the left bundle branch area pacing. So how do we do it? Again, we started doing left bundle branch area pacing since Feb 2019. So over the past 1 year, we have implanted about 150 left bundle branch area pacing leads. We've completely switched over from his to left bundle branch area pacing. And I think our success rates are about 88 to 90% overall success rates. And so far, we've not had any major complications, like late perforations. We did have 4 or 5 transeptal perforations during the procedure, but we recognized that we moved the lead to a different spot. Again, when doing the case earlier, there was a concern not to give more turns. There was a concern about LV septal perforation. So the question is, what are the consequences of LV septal perforation? Again, so far we had only about 5 cases where we had transeptal perforation. We've not had any issues. Again, if you think about it, for atrial fibrillation ablation, we put 2 transeptal sheets, like Agilis 12 French sheets across, and then pull it out, leaving behind like 3 to 5 millimeter gap without any issues, right? We put a cryo sheet 16 French across. We don't think about it. This is a small 4 French lead with a very small diameter at the tip. So that too in the muscular septum, if you go through and come back, I feel like it should just close out. And the pressures on the left side are higher than the right side, so it's unlikely to cause any right to left shunts. Yeah. So the first step in left bundle branch area pacing, first thing is to do is to locate the distal his. Cine shot and save it for reference, as we did in the case this morning. Sometimes you might not be able to map the his. In those cases, I usually go by the tricuspid annular signal, or if they have prosthetic valves, that serves as a good reference. Once you have that spot, advance the sheath. Just gently clock it. Advance the sheath about 1 to 2 centimeters distal to the distal his. At this spot, pace map. The ideal site should have 2 of these things. Actually, it can be either of them. So you can see a W pattern in V1 with a hump on the later half preferably. This is the pattern which was described by the Chinese folks. And in our experience, we see that maybe 50 to 60% of the time. So you don't see it all the time. What we go by is the inferior lead and the AVR-AVL discordance. So what it means is we typically like doing with 12 leads on the Pruka, and we color code AVR-AVL so that in a live situation, you can easily identify AVR-AVL discordance. AVR is typically negative, AVL is positive, and lead 2 is typically taller than lead 3. If you think about it, if a PVC comes in from a parahesian focus, that's the morphology you get it. So that's what we are trying to look at, which kind of gives us an idea that we are on the septum. Once you identify that morphology, typically I rotate it once or twice just to get a bite into the tissue. And then, I don't know why it's cutting off, but once you have that, note the pacing impedance and the QRS morphology. So you get a baseline pacing impedance, and also you make sure that the QRS morphology is consistent with your parahesian or septal morphology, meaning sometimes if you're rotating it once, it can jump up into the outflow tract, and you might end up with the outflow tract morphology, and you don't want to miss it. So this is the ideal site for fixation. So as I mentioned, this is a 12 leads. We use AVR, AVL color-coded. We like putting the V1 all the way at the bottom, just for the sake of ease, because you're close to the left bundle electrograms. So you can see the V1 has just QS without any notch, but you have AVR, AVL discordance, and lead 2 is taller than lead 3. There is a discordance, inferior lead and AVR, AVL discordance. The next, once you have the ideal site, the second most important point is the ideal sheath position. So what's the difference between his bundle pacing and left bundle branch area pacing? So the his bundle pacing, once you get the sheath at the his area, the septal curve makes it look, in the RAO, it looks like it's going towards like a 12 o'clock position, 12 to 1 o'clock position. Okay? Whereas the left bundle lead should face like 2 o'clock. If you think this is like a clock face, it should face about 2 o'clock. And that tells you, if you think about the septum in this direction, you have to be perpendicular to the septum. Okay? Again, in the beginning, when you're trying to do the left bundle branch area pacing cases, I would urge you to go to the LAO, make sure you're on the septum, confirm it before screwing it in. Okay. Once you're at this position, what typically happens is you need to counter the sheath. Sometimes it's 45 degrees, sometimes it's more than that, to try to orient the sheath perpendicular to the septum. In some cases, you might not even need to counter, just the position itself keeps you very perpendicular to the septum. So once you have the torque, gently advance the sheath so that it's abutting the septum. If you have somebody to hold the sheath in place, that's great. You can also do it single-handedly, but it's better if you have somebody holding the sheath, maintaining that counter torque. Once you have that, the next step is to rotate 4 to 5 times rapidly under fluoro to assess the depth of the lead into the septum. And with the his bundle leads, we used to do single hand technique, but with the left bundle, I typically prefer 2-hand rolling technique. And you can feel the difference. As you keep rolling, you can feel that the lead is going into the septum. Once you have that 4 to 5 turns, then hook it up unipolar tip and then check the lead parameters. Pay particular attention to the impedances. The impedance gradually trends up as the screw starts going into the septum. So today we started off at 1,000. It gradually went up to 1,100, 1,300, 1,400s, and then it started to come down. It came down to like 1,300s. Once it starts to come down, we know that we are coming close to the left side of the septum. Usually it can fall by up to 100 ohms. If it suddenly drops by more than 300 ohms, typically, that tells you that you're through and through. Next thing, you also pay attention to the QRS duration and the morphology in V1. Try to look for the left bundle potential. I think for some reason this is cutting off the screen. Do we know why?
Go off the presentation mode, I think.
I can't see the lower end.
चाय और कॉफी ऑन द हाउस होनी चाहिए. ब्लैक कॉफी दे दो यार, ब्लैक टी दे दो यार. लेकिन इम्पोर्टेंट है. गरम पानी रख दो, हम उसमें से कॉफी डाल लेंगे.
Hot water. Yeah, this is hot water. This is hot water. Yeah. Some more? No, I'm good. Yeah, that's sure. See, it's not showing up below the left bundle potential. There are a couple more. So yeah.
show you if you minimize. See, everything is correct. I think they changed the resolution or settings. Even the previous slides were getting cut off.
I think the spacing needs to change. The line spacing. Line spacing.
No, not that.
I'll just.
Experts are coming here. You know. Okay, give a chance to
पैराग्राफ में वो स्पेसिंग मैंने सिंगल कर दी थी
Any singles in line spacing options?
पॉइंट उससे भी कम करना पड़ेगा
0 before 0 now okay
resolution slide show no it's not resolution resolution only line spacing has to be maybe less than that multiple
0.9 कर दो
0.5 कर देते हैं सारे में करना
So claps to both of you.
enter
सारे में करना पड़ेगा सारे में करना पड़ेगा
oh is it that's fine
Yeah, I mean this is okay, I think.
yeah I think that's good thank you. So first once you give the 4 turns, you basically look at the impedance, the morphology, look for any left bundle potential, and then look for the LVAT. And then the R waves and threshold are usually checked once you have a good morphology. So once after that, if you don't have a QR or a RSR prime pattern, you can rotate further. After the 4 to 5 turns, and the next should be like 1 or 2 turns at a time. So keep rotating 1 or 2 times at a time until you get that QR pattern. Once you get a QR or a RSR prime pattern, I usually stop rotating it, unless, irrespective of whether you get a left bundle branch potential or not. Sometimes you can see backspin or buckling in the septum, like we saw this morning, which can indicate fibrous septum. So once you get the QR pattern, you can do a septogram. We call it septogram. Basically, you inject the sheath. You inject the contrast 1 to 2 cc's through the sheath in the LAO to look at how deep the lead is in the septum. So typically, the helix measures 1.8 millimeters. Tip electrode to the beginning of the ring electrode is 9 millimeters, and the ring electrode measures about 3.8 millimeters. Once left bundle pacing is confirmed, split the sheath and split the P elevation. I don't know why it's not playing, sorry. I think it's the resolution, I think it's just moving away. I think somebody in the morning they changed something. Yeah, lower it down. Yeah, just go up one slide. Yeah, this one. What I'll do is I'll probably show it like this. So, oh wow, it doesn't play. Anyways, that was to show how deep the lead was in the septum. So you can see clearly the septum delineating the I'm sorry, the contrast delineating the septal wall, and you can see how deep the lead is in the septum. So there's some of the tips and tricks which will help in successful left bundle branch area pacing. I think it's very important to have clean gloves. Bloody or sticky gloves, especially after injecting contrast, you might not get that same feeling. So whenever you're trying to screw in the lead, it's better to either clean your gloves or switch to a new pair of gloves. This is a video of two-hand technique. You can see somebody is holding the sheath counterclockwise, maintaining that counterclockwise stance, torque, and I'm rotating the lead rapidly, giving 4 to 5 turns under fluoroscopy. This is in the beginning. Okay. So what will you do if the lead buckles or backspins? So if the lead buckles at a higher spot, you can try to go down on the septum. So this is one example of how it looks like when the lead buckles. And actually we saw this during the morning case too. So this lead won't go in because, probably because of the fibrous septum. So when this happens, you can reposition the lead. So before repositioning the lead, as Parikh mentioned during the previous talk, it's always important to take the lead out completely and clear off all the tissue. And this is the largest chunk I've come across so far. Nothing like this. So where Dr. Panrangi got, I'm not sure what exactly this was, but if it was a conduction system tissue or tricuspid. Well, yeah. Yeah. The third tip is recognize when to give more turns. So the LVAT can actually guide you sometimes. So this is a case at 5 volts. You can see we had a nice, if you look at V1, we had a nice already RSR prime pattern. And at 5 volts, the LVAT was 65. The LVAT is measured at from the stim to the peak of R in V5 or V6. Anything below 80 is okay. So in this case, we had 65 at 5 volts. And then when we paced at 1 volt, you can see clearly the change in morphology. The stim to QRS was longer, and the LVAT was 93. So that tells us that you're close. At higher output, you're able to get into the left bundle branch area, but at lower output, you're not getting into that area. So what we did in this case, this guy's septum was a little thick, so I gave 1 complete turn. But if I see this in a septum where you're easily able to advance the lead, I would have given only a half a turn. So after 1 turn, we rechecked. Again, at 5 volts, the LVAT was 65, and at 1 volt, now the LVAT became 65. So you need to show short and constant LVAT at higher and lower output. That's one of the criteria for to say that we are capturing the left bundle branch area. And then you also need to recognize when to stop rotating the lead. So this was a case, you can see a small left bundle branch potential. I was craving for a larger left bundle branch potential. I gave 1 more turn. And then you can see there was a clear polarity reversal. So that tells you that you're through and through. For us, all comers get left bundle. Everybody's getting left bundle. You know, even for his bundle pacing cases, we were doing his bundle cases for patients with six sinus syndrome. You know, everybody used to get a conduction system pacing lead. It's not just patients with AV block or infrahisian block.
Essentially, you consider this is safer and more assuring than the his bundle?
Yes, I do. Again, people might not agree, but I do. Because we were putting his bundle leads from 2014 through 2019. We have about 300 his bundle pacing lead implants. We're going to be presenting the data at HRS in May. Our own experience with the his bundle, we've had issues with high thresholds, lead revisions, and since switching over from his bundle to left bundle in the last 1 year, we've done 150 left bundle branch area pacing leads. Not even a single patient has threshold more than 1.25 at this stage. No major complications, no lead revisions. So why would I not prefer a left bundle? So that's again, that's what we've been doing it. But again, if you ask Parikh or Vijayaraman, they say that you have to map for his, look for the capture threshold. If it's high, then go to the left bundle. But again, we have cases where patients with his bundle, probably I'll show it later today, capture threshold was 0.5 at 1. At implant, we took it for his bundle. 6 months later, the capture threshold was 6 or 5. So how do you explain that? So there is this unpredictable delayed rise in thresholds with the his bundle leads. If somebody can tell me, okay, which patient will have higher threshold 6 months down the road, that would be awesome, but we don't know the predictors yet. So again, in this case, you can clearly see the impedance went from about 700 to 320 ohms, and you can see the polarity reversal, suggesting that the lead went through and through. So one suggestion at this point, so once it goes through and through, if you pull back slightly, you might get your QR or RSR prime pattern back. Thresholds might be good, but I think it's best to take out the lead and go to a different spot. Again, this didn't happen to me. I learned left bundle branch area pacing from Dr. Vijayaraman. He had a case where he left it after pulling back, but the next day the pacing lead dislodged. Basically, you're creating a hole, and then it can easily come off. So it's always better if you're through and through, pull it out completely, go to a different spot. So this is what you're looking at. So this is the initial pacing site. You had a W pattern in V1. You had AVR-AVL discordance. We gave few turns, and you can see already how the QRS starts changing. You start to see this delta wave. And when I see that, you know that you're getting closer. You just need the depth. And you can see the notch moving from the descending limb all the way to the nadir. And after a few more turns, you get a QR pattern with a QRS duration of 115 milliseconds. So what are the criteria for left bundle branch area pacing capture? So these are the criteria set forth by Wong, Dr. Wong, and Dr. Vijayaraman in the heart rhythm paper. Again, none of these criteria have been validated. So far, this is what we have, so we are going by this criteria. So you look for paced morphology of right bundle branch block pattern. You look for left bundle branch potentials. You look at stim to LVAT times. You look at selective and non-selective left bundle branch pacing configurations. And you look for evidence for direct left bundle branch capture. So let's take a look at these. Yeah, so at least in our series, we had left bundle branch potential in about 60% of the patients. Not everybody has left bundle branch potential. Dr. Wong recently mentioned they had 98% of the time they had left bundle branch potentials. You know, once we have the QR with a QRS duration of 110 milliseconds, it's a risk benefit. You know, you give one more turn, you might go through and you might lose that position. So I don't think there is any data to support that you need to have a left bundle potential to say that you have left bundle branch area capture. So even without getting the left bundle branch potential, you still might capture the left bundle branch area. I'll show some of the things. Yeah. Yeah. Yeah.
Probably if there is a complete left bundle branch block or if there is an improvised incomplete heart block, where there will not be activation of left bundle. Very difficult to demonstrate unless you are antegrade activating or retrograde activating.
Yeah. Yeah, I'll show some examples where we have retrograde left bundle potentials. But the point is, if you have a baseline left bundle branch block, and if you have a pacing lead at the left bundle branch area, you won't be seeing left bundle potentials because you're blocking in the left bundle. But sometimes the impulse can go down the right bundle, transeptal, and come up retrograde, and you can have retrograde left bundle potentials. I'll show some of the examples like that. Yeah. So this is the first criteria, looking for paced morphology of right bundle branch pattern. You either go by QR or RSR prime pattern. So here you can see nice RSR prime pattern with a stim to QRS latency of about 28 milliseconds. And also you can notice the local electrograms. There is a split discrete electrogram from the stem, again suggestive of selective capture. The second one is to demonstrate presence of left bundle branch potentials. Here are the two examples. You can see left bundle branch potentials. Here it's kind of more inverted, but here you can see a high frequency left bundle branch potential. This was a different case. You can actually see a left bundle branch injury current, which we don't often see it, but sometimes you can see it. And what's interesting is this patient had a right-sided PVC, and note what we found. So you can see, you can demonstrate the antegrade left bundle potential and also retrograde left bundle potential in a patient if they have a right-sided PVC. Third criteria is looking at the LVATs. I've already shown a slide on this. So always demonstrate that the LVAT is short and constant at high and low output. The fourth criteria is demonstrating non-selective to selective left bundle pacing. I think this is very difficult to demonstrate in most of the cases. Unlike his bundle pacing, where you can clearly demonstrate non-selective to selective, it is very difficult in left bundle branch area pacing because if you think about where the lead is, it's surrounded by dense myocardial tissue. So majority of the time, you're going to have some septal myocardial activation when you're pacing the left bundle branch area. So this is one example where you can see non-selective to selective during bipolar pacing. So during bipolar pacing, you can see a QS pattern, which changes to QR, and you can see the local split in the electrogram, and there's a stim to QRS latency. So here we demonstrated non-selective to selective during bipolar pacing. This is an example. This is what is typically noted if you see a non-selective to selective left bundle branch morphology during unipolar pacing. So now I'm pacing unipolar tip. So I'm just capturing the left bundle branch area and the surrounding myocardium. So at 2 volts, you can see the morphology is more like a QR pattern. And if you see V4, V5, V6, there is no stim to QRS latency, and you see the local electrogram, there is no discrete local electrogram. As we came down on the output from 2 to 1.5 to 1, all the way down to 0.3, you can see there is a discrete electrogram. There is a stim to QRS latency. And this demonstrates transition from non-selective left bundle to selective left bundle. So most of the time, so this is seen in about 15 to 20% of the time. And whenever we saw this phenomena, it's usually at very low capture thresholds, close to the capture threshold of the left bundle branch pacing lead. So how can we, to get a selective left bundle branch pacing and program it on the device, it might be impossible, right? So because usually the non-selective to selective is usually at a very low capture threshold. So most of the patients end up having non-selective left bundle branch pacing. So this is one way we can show evidence for direct left bundle branch capture. You can measure VA times. So this is a patient who got a left bundle branch area pacing lead. We first paced from the unipolar ring. So the ring captures the RV septum, and you can see the wide QRS morphology. And you can see the retrograde 8 times. And then you do unipolar tip pacing. You can see RSR prime So you're capturing the left bundle branch area, and the V8 times were shorter. This is similar to your parahesian pacing. So you can do ring pacing and tip pacing. Sometimes helps in differentiating whether you're capturing the left bundle branch area or not. You can demonstrate the same thing on the analyzer. So this is on the top, you can see the V8 times measured from the surface QRS to the atrial electrogram. When we were pacing the ring was 220 milliseconds. And when we were pacing the tip, it was 160 milliseconds. Again, it makes sense. When you're pacing the ring, you're not capturing the conduction system. It has to come all the way down and then go up through the conduction system up to the A. So that's why your VA times are longer. Whereas when your lead tip is at the left bundle branch area, you're capturing the left bundle branch, and then you can readily go up to A. So the VA times will be shorter. Again, similar to your parahesian pacing. So again, to summarize what we talked about, the step-by-step approach, first and foremost, try to identify the distal His marked by an asterisk. So you get distal His bundle potential. There's no A, again tells you you're distal. Once you have that, go about 1.5 to 2 centimeters distal. In some cases where you cannot identify the His bundle potential, or if you have a prosthetic valve, you can just go use that as a reference and go 2 centimeters distal to it. Once you have that pace map, you're looking for this pattern. You're looking for inferior lead discordance and AVR avial discordance. So this is the ideal site. Screw it in. As you screw in, after initial few turns, you can start to see delta wave in V5, V6 here. We give few more turns at this point, and now you can see the pace morphology is right bundle branch block. The V1 is at the bottom. This is your V1. So unipolar tip, once you see this RSR prime pattern, we stop at this point. We don't go for left bundle branch potential. So out of those 5 criteria, we always try to get right bundle branch morphology, and we always check LVAT times, TIM to LVAT times. Those are the 2 main big things. If they have retrograde conduction, we look for VA times. So those are the 3 things. And if we get a left bundle branch potential, that's a bonus. Once you get the tip, you can also pace ring. This is the ring pacing. You can see the widening of the QRS. These are the QRS durations. I don't know if you guys can see. Initially it was 144, narrowed it to 125. With left bundle branch area pacing, it was 114, and the ring was 136. Once you have ring capture, again, it tells you that the ring is close to the septum or in the septum. That automatically should tell you that at least 1.1 centimeter of the lead is in the septum. And then, once you have that, look for left bundle branch potentials. Look for STIM2 peak of V5, V6 LVAT times at 5 volts, 1 volt. And then try to demonstrate non-selective to selective. Here you can see a QR pattern. Look at the local electrogram, how it splits, non-selective to selective with latency when you have selective. So this is the basic approach to left bundle branch area pacing. So again, as I mentioned, all these criteria which we have been using are not validated. This is a very elegant paper from the Polish folks, recently published. I think it's out in JCE now, where they used programmed extra stem to differentiate whether you have a left bundle branch area capture or not. So this is a concept taking into account that you have differential effective refractory periods of the septal myocardium and the left bundle branch area. So if you think about it, when you pace the left bundle branch area, since you have a lot of myocardial tissue around, predominantly you're going to be getting non-selective left bundle branch area pacing. But there is also a paper from Netherlands group where they showed that LV septal pacing is good enough. So when we are trying to do conduction system pacing, we really like to differentiate whether it's LV septal pacing versus left bundle branch area pacing. So this maneuver actually can be very helpful, and we started doing this maneuver to differentiate whether we have left bundle branch area pacing or not. So how do we do it? So just pay attention on the left side. So you have, so you can do extra stim by two ways. You can do a basic drivetrain at 600 milliseconds, and then give an extra stim at a coupling interval of 400, and then decrement by 10 milliseconds, 400, 390, 380. Or you can do an extra stim during sinus rhythm. So on the left side, you can see an example of programmed extra stim. So just pay attention to V1. So V1, during the drivetrain, you can see a QR pattern, right? So at this point, you don't know, am I capturing just the LV septum? Am I capturing the LV septum plus septal myocardium? Or is it pure left bundle branch area pacing? So when you do the program stim here with the basic drivetrain, and when they gave the extra stim, note what happened with the extra stim. The QRS morphology completely changed. It became wide. You lost the right bundle branch morphology in V1, and it's wider than your paced morphology. So what happened here is the effective period, refractory period of the left bundle branch was reached, and patient just had myocardial capture. So now this, they call it as myocardial response. When you see this, you know that your drivetrain was both a mixture of septal myocardial capture plus left bundle branch area, because now you've shown by this example that the ERP of the left bundle is longer and the ERP of the septal myocardium is shorter. Okay, this is one way, actually a very elegant way to prove that we are capturing the left bundle branch area. On the right side, you have another example. Here they're giving extra stim during sinus rhythm. Okay, so again, pay attention to V1. So this is an extra stim, two sinus beats, and then you gave an extra stim, say at 350 milliseconds. With the extra stim, you can see the morphology is QR in V1. Right? You have a nice right bundle branch pattern, nice QR. When they decremented by 10 milliseconds from 350 to 340, now see what happened. It became RSR, and you have stim to QRS latency. So now you're showing you changed from non-selective left bundle to selective left bundle. Okay? So they call this selective left bundle response. So what they found that in their series, 80% of the patients, they demonstrated either myocardial or left bundle response, which confirmed left bundle branch area capture. What was interesting in their paper was some of the patients, they didn't find any left bundle branch potential, but they were able to still demonstrate left bundle branch area capture based on the program stim. So again, that tells you that you don't necessarily need to have left bundle branch potential to demonstrate left bundle branch capture. Do you have time for just a couple cases?
No, I think you should go on.
Okay.
You should finish with that.
Yeah, I just have a few more slides. So this was a case where we tried the fixed curve sheet. Patient had AFib, and you can see we marked the his position. The asterisk points towards the his. And then every time we advance the sheet never would come down. It would actually try to go up. And when we pace here, look at the morphology now. So if you just pay attention to V1, sometimes you can see a W pattern even in the outflow tract. So you might think, oh, W pattern, it's great, you can screw it in. I have seen cases with outflow tract morphology with a W pattern in V1. So the W pattern in V1 is not very specific for that location. So here you can see 2 and 3 are positive, AVR, AVL is negative. So I know I'm in the outflow tract, so we didn't take this position. But every time I tried advancing the sheet, it won't go down. So you can see here the asterisk is the his, and this dotted line is the position of the sheath. I wanted to get the sheath lower, but I couldn't get it. So in this case, we switched to Medtronic 304 deflectable, the new sheath, and you can see how low we were able to get. This was a his, and we were able to get lower, and pacing revealed AVR, AVL discordance, and lead 2 taller than lead 3, and screwing in the lead at this point resulted in a good right bundle branch morphology with a QRS duration less than 120 milliseconds. This was another interesting case. Patient with complete heart block complete heart block post aortic valve replacement. So he presented for a pacemaker. So as we talked about the anatomy this morning, typically the his is close to the right cusp, non-coronary cusp. So I would have expected, we did try here in this location, but it was very fibrosed. So we kept going down and finally ended up at this spot, which you can see it's actually pretty low down on the septum. It's actually mid-septal spot. And when we did the septogram, we were nice deep into the septum, okay? So if I overlay this anatomy pictures, again, what am I capturing here? I think I'm not capturing the left bundle branch trunk. I'm very low on the septum, on the posterior aspect. Most likely capturing the left posterior fascicle. And when we tested this lead, this is VVI bipolar pacing, threshold testing at 3 volts. At 3 volts, you can see in V1, you have a nice narrow QS morphology. At 1.75 volts, you can see it transitions here from QS to RSR prime pattern. So this is bipolar pacing. So what's happening here is as you come down on the threshold, at some point, typically between 2 and 2.5 volts, you lose the anodal capture, you lose the ring capture, and you get pure left bundle branch pacing. So here you can see RSR prime pattern. And then the threshold was all the way down to 0.5 at 0.5 milliseconds. And note the axis. You have a left axis deviation. Again, in this case, we were so low in the mid-septum, posterior septum, we were capturing the left posterior fascicle. Despite being so low on the septum, we were able to narrow the QRS down to below 120 milliseconds. And I think that's the big advantage because you have a wider landing zone. I'm done.
Great. So you do this as you go now. And then you can come back. Get one more glass of hot water, please. Coffee or hot water? Coffee. Parikshit, you can hear us? Parikshit? Selective left. No, they can't.
Can go off pacing.
Hi, Parikshit. I think you almost finished the case, I think.
Yeah.
All right, so let us know what's going on.
Can you hear me, Ullas?
Oh, yes, we're all.
Ullas?
Yes.
You can hear me?
Yeah, I can hear you. How about me?
So let's pull up some of the images. We started at a proximal His location. If you look at the review screen, that was the His there. That HV was 75, 76 milliseconds. So nice AHV with an HV that was long. So when we paste here, show them the paste morphology. So pacing at this site, you still have the same left bundle branch block type morphology with what seems like non-selective capture. So then we went to a slightly different location. So the second site had an HV that was 60 milliseconds. You can see it in the first beat, there's a nice HV there. But pacing at this site, we had a morphology that was slightly narrower, but still about 140 milliseconds. I think you measured the wrong beat, but that's fine, that was fused. So it's the next beat. Yeah. But still non-selective, so still pretty wide. So that's all we've done so far. So we'll be able to show you the rest. Yeah. So that's where we saw the wire going. Okay, pace here. Update and measure the HV and then pace. Okay, pace. Update and measure the QRS. Still looks wide. Okay. How about we stay on pacing, please? You're at 5 at 1. Okay. So now I'm going to do a little bit of pace mapping, hoping to see if I can find a site. The challenge is this sheath is not letting me get any higher, so I might have to quickly reshape it. But before I do that, I'm just going to do a little bit of pace mapping to see if I see any narrow beats with 5 at 1 millisecond. Flora? That's atrial capture. What's that pace QRS? So narrower.
Koti sir, I just was wondering, would you bring in that monitor on the leftward side, because I think he's straining his neck too much. The way what we do, how about pulling those monitors? Koti sir, can you just get the setup done that way? I think he's turning, straining him.
Well, they're on two different sides. So.
Is that okay? Better, I believe.
I'm not sure. They're just going to move this monitor. Something first. Okay, can someone else fluoro on the meanwhile for me? Yeah. Okay, go off pacing. Yeah, because of the curve on the sheet. Sorry. Give me the dilator. And give me some saline, please. Dilator's flushed. Give me a wet lap. Okay, so if you guys can see or focus on my hand. So here I'm actually going to reshape this sheath. So as you can see, what I couldn't do fluoroscopically is get up more superior and anterior. So what I'm going to do now is I'm going to reshape this. So if you see here, this is as low as it can get. I'm going to try and get up higher here. So in order that I'm going to put a curve here, maybe put a little bit more septal curve up top as well. So I'm going to do this. So it's a little bit higher. And do a little bit more, get it even higher. So that's going to be even higher. So we'll try to take this back and into wire. Okay, fluoro for me, please. You can go off fluoro for a moment. Okay, fluoro again. Yeah, we'll take the red. That's okay. It's where no, it's just fluctuating. It's flickering. I guess so. That's fine. Let's pace it 5 at 1, please. I don't even know. Can we turn that towards me at least in the meanwhile so I can see what we're... No, turn the screen. Okay. Fluoro again. Fluoro. Fluoro.
No, the other one. The other one. The real time. Just turn it a little.
There's a haze. It's capturing either, or not capturing anything. It's narrower, but so can we update and measure this QRS? How much? I can't see. No, this one doesn't, even the review screen is gone. Fluoro again. Yeah, that's because the sheath is pointing more subtly, so it'll just pull it back. So I'm not able to find a narrow spot. This is selective capture with left bundle branch block. So you guys see this, Vilas?
Yeah, would you please tell us something?
So this is a spot where we have selective capture with left bundle branch block.
That's
you see
correct.
the local V, septal V is not pulled in.
Yes.
And the left bundle branch block still exists.
Yes.
Can we go off pacing, please?
And what was that duration there?
Yeah, I'm looking at the underlying AHV. So there's a nice hiss there, but good A as well. What's the HV here? (80 millisecond HV, so long HV. So I gotta go even more distal fluoro.
I still would like to know what was the QRS morphology at that stage.
It was selective capture without narrowing. That's what I was showing you guys earlier.
Okay, there was no narrowing at all?
No narrowing at all, no. Pace here. Yeah, let's pace here, please. Update and measure this QRS, please. It's narrower. $150. Go off pacing. Pace here. What's this HV here? No. 58. Measure the space QRS. Go off pacing. 140. There's an A actually. I think there was some junctionals, that's why. So A actually. There's actually, so you see the His injury on the His? You guys appreciate that? Look at the unfiltered EGM.
Yes.
There's an injury current that corresponds with the His electrogram.
Yes, we could see.
Those are junctional beats. There's a His preceding the V. HV is nice and short. And you said the pace QRS was 140 here? Okay. Fluoro? No, not yet. Fluoro, I just wanted to see that. Okay, pace here. What's this pace QRS? It's narrower, but that AVR looks terrible. This doesn't look like this good. Yeah. So intrinsic QRS was 170, 180. This is not going to get too much narrower with this one pacing. Fluoro again. Pace here. Update, there's a right bundle potential on it. Yeah, so it's not getting much narrower at any of those spots. Just keep pacing for a moment. I'm going to pull the lead back gently. So we basically mapped right bundle, pulling back towards his bundle. Update and measure this QRS here. One what? 120? Do you guys agree? I can't see the review screen. Is it really 120? Ullas?
Yeah.
Oh, look at AVR.
What is that? Yeah, you can actually measure, that's better.
Go off pacing for a moment. There's a little hair.
How much is it?
Just hold this for me. Let me see if I can get a little light and see.
हाँ HB देखो HB कम होना चाहिए from the normal native HB उससे कम लाओ that means you're distal to it हाँ हाँ spike to V
Yeah, we're still trying to figure these out. In the meanwhile, can we keep going so that people can... Let's pace here. Yeah, there's a small. Pace faster, please. 110. Okay. Let's measure this QRS again, please.
If you measure in the AVR, it will be too heavy.
Dr. Ullas, can you hear us?
Yes.
Okay. 140.
Yeah, so I think we should get better.
Okay, fluoro for me. Okay, go off pacing. Go off fluoro. Off fluoro.
बैकअप क्या रखते हैं उसके बाद जो आपकी एक्स्ट्रा वायर होती है ना they can paste from there उसको यूज करते हैं
Show me fluoro again.
कुछ भी नहीं किया था उन्होंने मैं बोल रही हूँ absolutely बिल्कुल बैकअप जरूर 200%. एक बार नहीं हुआ लेकिन एक भी होता है अब वो गया मैं नहीं आ रहा.
So did you guys see what I was doing? Did he show you? With my hands? No, it's already done.
No. Please repeat as we saw, but we couldn't actually make out what exactly.
No,
you did.
so that's exactly what I was doing. I felt like I was stuck into something, so I just kept pulling back every few beats on the lead, and then finally it just let loose.
Oh.
So I don't have a lot of tissue at the tip either, so it's not like I caused any damage.
So I was wondering if you do that with the gauge piece, maybe some threads get stuck.
No, so here's what I was talking about. You hold the gauze in your left hand, put the lead into it, gently cover the helix, and then counterclock the lead and pull it out, and everything comes out. Can I get a flush just? For one more spot, if not, then we go to the left.
14 अंदर 3 बाहर करने की है ये बहुत ऐसे दो ही करने हैं.
Yeah, we'll have to see. I made it too superiorly directed. I don't know if it'll work for left on the branch pacing.
चलने जाके एक को सीखा पर ये शीट किस पकड़नी है मैंने शीट पकड़नी भी सीखी है वो कैसे करना है
Mm-hmm. Pace here. Mm-hmm.
So same is selective his bundle.
No, I think it might be non-selective, Ulas. There's a little pseudo delta in V3, V4, and the local V is pulled in. It's not a separate EGM. So I'm not finding any spots that are proximal enough on this part, and we don't have enough support on the distal part. So I'm going to try and see if we can go more left bundle-eyed. Yes, please. So like I said, for left bundle, I always start more ventricular and pull back so I don't get the valve entrapped in my lead and sheath system. What are your R waves here? .9. Yeah, just pace here. Not yet, just pace.
It's not really appreciated.
Yeah, go to 0.4 on pulse width now. Yeah, there's a notch in V1. 2 and 3 are discordant. AVR, AVL are discordant. So. Okay, what's your, let me see. Go off pacing. Show me a little bit of the apex of the heart. So you see this is a little more vertical heart. So this is along the line of the distal his to the apex. That's why I'm starting a little proximal here, but let's see. You can go off pacing for a moment. And then can I get a size 7 gloves, please? Opened up.
Are you coming? You get one coffee for me too.
Okay. How much? 1100 already? So I usually will switch to once a half a size smaller gloves for LBB.
Now, is it some scientific reason?
The scientific reason is because I can feel the lead better.
Okay.
Although by the time I'm done with the case, my fingers will be purple sometimes. But okay, so pace again. Let's see morphology. Let's make sure we're still where we were. 5 at 0.4. Yeah, so V1 has a nice notch on it. Then 2 and 3 are discordant, and AVR, AVL are discordant. So fluoro again. Okay, go off pacing. Stay on fluoro. I never get too excited about this because you can never predict. Okay, let's pace. Okay, what's your impedance? 1139. So a little bit higher than where we started, but the QRS is looking a little bit narrower. What's the go off pacing and give me R waves? R waves?
So still there was an issue with the cables, that's why you're not using the cables anymore?
Yeah, we are using the cables. Can we not see them on the...
No.
You're not going through the... You're connecting directly? We didn't...
Yeah, we can connect. I mean, in case if there's a
Let's
problem.
connect through Pruka and see what it looks like. Can we come LAO, please?
Great. What do you think about the sheath position in RAO? You think it's facing more like 3 o'clock?
Yeah, you're right. But I was... come a little more LAO. So that's why I'm going LAO to look. I've just given it 3 or 4 turns. I don't know if it's far in or not. I know it should be more towards 2 o'clock, but this heart is also more vertical, Santosh. So you see, you quickly get a sense here in LAO that you're not really getting into the septum. You're not directed into the septum. That would be probably a little bit more directed into the septum, but it's interesting. I'm actually clocking the sheath here and it's pointing in that direction. If I counterclock, this is how it points. Yeah, okay, let's go back RAO. I'm going to reposition. Fluoro. Okay, let's pace here. What's your impedance?
Not much, but inflow.
300. Put it back through your PSA. Why are we pacing though? Cause TV block. One 130. So if it's the PSA, it has to be over 1100. If it is through the Pruka system, it has to be 300. That's what we decided.
Yeah.
Okay, pace again and give me impedance.
Yeah, it's so common. So common.
Okay. All right, go off pacing. So I just gave a couple of turns. I usually give 1 or 2 turns to get a bite on the septum. Then I'll hold my sheath on fluoro. On fluoroscopy, I'll pull it back a little bit and counter it a little bit so it points a little bit more towards the septum. And then I'll give a few rotations before I go LAO and start checking again. Fluoro. That jump forward. Go off. Oh, flow. Pace. So no big change in morphology. And 2 and 3 look pretty much in the same direction. I think we slid forward. Yeah, let's check LAO. LAO. Okay, fluoro. Not sure why everything's working the opposite of what it's supposed to. Clock is taking me septally with the sheath. And counterclock looks like it's pointing posteriorly. Go off, fluoro. Go on, fluoro again. Go back to RAO. Let's pace here. Show me fluoro. Yeah, that's too low. Or too proximal. Pulled back, I guess. Okay, pace here. Morphology is not bad. 2, 3 are opposite. Looks okay. Yeah, let's try this. What's the impedance here? I think it's over 1,000.
Break. Do you think you can advance the sheet a little bit so that it makes like a J rather than like a L pattern? You see how it's pointing down towards the 3 o'clock?
Yeah, I think it moved as I was pacing. It was a little bit higher. The problem is I don't think this sheath is giving me the support I need, especially with this vertical heart. Everything's, see that? It's buckling downwards. I'm trying to advance into the ventricle there and impossible. See, now it's looking better. So it's interesting, if I clock it, it points that way. If I counterclock it, it just points downward. So I gotta keep clock on it instead of counterclock, which is not commonly what we expect to see.
I like the shape of the sheet better.
Yeah, but this is with a lot of clock on it.
Yeah.
I haven't, it's contrary to what we do normally. So that's why it's...
Yeah, you know what, actually would love to see the electrograms. Connect to the cables, please.
There.
Parishit, I think this time, it's nice looking sheet position.
Yeah, I'm not seeing electrograms. We're connected. Okay. Can you Pace now. Impedance. Okay, put it back through your PS. Just put it back through your PSA. Olas, underlying rhythm is just V pace, so we're not going to be able to appreciate.
Yeah, but
any
so we
change.
can always have that, the basal ECG for comparison.
Impedance. Okay, fluoro. So this is about 4 turns in. Impedance. Okay, let's go LAO, please. Okay, fluoro. No. I don't. The angulation looks totally off. I said the angulation looks completely off in LAO. Let me see if I can try to get this through. See, it's just flopping, bouncing around all over the place. Yeah. Okay, go back audio, go off fluoro. You can go off fluoro, please. Saline, please. So again, can you zoom onto my lead? So here you see that there is tissue in the tip. And I didn't want to keep going. So again, I'm just going to take this, I'm going to put it in the gauze, lightly wrap it up, counterclockwise, and majority of it already is out. Still some more left, which I might actually need the needle here. So give me a, like here. The stuff stuck inside. Maybe that's why I didn't take a bite the last time.
Sir, is the his bundle still in place from the groin?
Sorry?
Is the his bundle catheter still in place?
Yeah.
From the
it's on
groin,
floor.
his signals are still there. But in LAO, the previous left bundle lead position and the his bundle lead position, his lead position are both are like little awkward.
Little what?
There is a, but the age is achieved.
Needle. Watch. I think it did get into something earlier. Okay, fluoro. Okay, pace here. You can go off fluoro, please, and pace. What's the impedance here? Everything is 1100. Okay, let's try this. Fluoro? No, looks okay. Pace again. Give me impedance again. Okay. Go off pacing. On fluoro. I don't know what's going on there. Why is it just doing that? It looks like it's through the septum. Or it has that secondary bend. I don't know what that means. Go off fluoro for a second.
Seems like again it's going down, right, Varek?
Let's pace. Yeah, I don't know why it's pointing down. I was.
Make it like a J, the sheath. See if you can advance the sheath.
What's the impedance here? Okay. Go off pacing. For my liking, it's a little low for my liking, where it's already through a little bit into the septum. Let me see if it goes. I don't know why it's doing that. What is it stuck in? Go off pacing. Yeah, I'm going LAO next. Pace. How will that help? Okay. Okay, go off pacing. You have an escape rhythm, right? No, go off for a second, please. So what did you want me to do? You wanted me to switch the cables? I'm supposed to put this and just leave it in for now, I guess. Because you can, how do I hook it up to this? Okay, now paste the his lead. One, 3, 5, 6. Let's go LAO. Finally it's increased. Watch out on me. Okay, fluoro. Yeah, that's a really funky. Okay, I'm gonna have to reshape this sheath. So let's go back audio.
Can you take a new sheath?
Yeah, I'll try to reshape this. These guys have to pay for every sheath and every lead, Santosh. It's not like us.
No, Parikshit.
Yes.
No. There is no inhibition. You
No,
can
but I want to be able to do it that way too, right? I mean, it shouldn't be like I'm a spoiled.
Spoiled for choice, what? No, but if you really are uncomfortable with that sheet.
No, I'm not uncomfortable. I'm gonna reshape it one time and see if I can make that work. If not, then I'll take a new one.
I think we'll try one more time.
So give me the needle again. a smaller size needle. Meanwhile, let's just reshape this. So, septal column. Come this way. Yeah, no. I need a septal curve for septal support, and I need it to go. It's a vertical heart, so I need it to go. This should probably be reasonable. I just needed more septal. You got stuck in the well, like I said, there's a well there, so if we get stuck in that, then it's not going to come out.
To see a couple of patients.
Right, we'll take the wire back. Is the wire flushed? This is flushed. No, just the septal curve to see if that really helps. That's good. You can go down and go back RAO, please. Go off.
Parikshit?
Yes.
I think you may take time.
Yeah,
you
if
can
there
go
are,
slow-
if
you
there
can
are
go
any
slow.
other talks, then you're welcome to continue.
So you know what, Daljit, she's from Hyderabad with Narsimhan. She also has got some great experience with his bundle.
Yeah, of course.
Pacing. We would like to hear from her what is her experience, and it's a pleasure and honor to have you, Daljit, sir. Okay, so may I ask you to present? Yeah.
I think LAO just fools us completely. No, I'm not getting a good sense of LAO in this case. Basically, I'm trying to. Okay, let's pace here. Okay, morphology is not there. 975. Okay, go off, please. Okay, Flora.
I would like to thank Dr. Ullas for having me here, for giving me this opportunity. So I would be presenting few cases
Patient,
from
give me
our
impedance
center.
again.
I put it our experience because it's not the cases done by me alone, it's the team's work. So I must say that in our center, we started, unlike other people who has presented, Avinash has presented and also, we started in the patients who are having atrial fibrillation, persistent atrial fibrillation, sick patients, arrhythmia-induced cardiomyopathy. So our initial cases are those cases in whom we have done AV junction ablation. So I would like to start this case with this case, 53-year-old lady, NYHA class 2-3, since last 6 to 8 months. She was having ECG of persistent atrial fibrillation since 2014. I've never seen sinus ECG in her because I was following her consistently. She's diabetic, hypertensive, normal coronaries, hypothyroidism, autoimmune disease, and with chronic glomerulosclerosis, initially on medical management, AF with FVR. So she was on dialysis in between with a dialysis sheet with the multiple admissions for CKD, and that was her biopsy for glomerulosclerosis. And she was on warfarin for atrial fibrillation. On warfarin, she was having some admissions. You can see her INR in between, it became 6 or something. She was receiving FFP and discharge. So what we did was, and she was having, we thought once we should admit her, do T, if there is no clot, we'll try to do cardioversion, because she was having heart failure hospitalizations as well. But because there was an L appendage clot, she was in CKD 2-3. With all these things, her GFR was less than 30. So she was put on Eliquis 2.5 BID. So on this dose, this was her echo with the EF of around 43% with some pericardial effusion, some restrictive filling pattern, and with the IVC congested. So she came on Eliquis of 3.5 with the peripheral arterial thrombosis, for which Fogati was done. And by this time, because creatinine was little better, and with that dose of Eliquis, she was having thrombosis, we increased the dosage of Eliquis to 5 milligram BID. And then because we were not able to manage her medically, we thought we'll do his bundle pacing with AV junction ablation for her. This case was done in February 2019. So it's just a mapping. Everyone has seen this since morning. This is a his bundle mapping, and you get a good current of injury. And then there's some data saying that if your first potential, your first EGM is more than 40 milliseconds from the onset of the pacing, it's kind of a selective his pacing. We got a good, nice selective his pacing in this patient. You can see the threshold was also good. We were checking the threshold. AV junction ablation was done for her. And this is a very nice thing. This is on her follow-up. She came 10th day on the follow-up. This lady never had a sinus rhythm. And now you can see the ECG. In lead V1, you can see some P waves. So in all our cases, I would say that whenever we say persistent atrial fibrillation, we think that atrial lead we should not put. We just put ventricular lead because we accept that as a permanent atrial fibrillation, we do AV junction ablation. For our group of patients, we put atrial lead, and we could see that there is a sinus rhythm which is very slow. And then her rate was 30, and then you can see this is on follow-up. She is having A pace and V pace. This lady has completed now more than almost 1 year of follow-up. On the device, there is not even a single episode of atrial fibrillation. She's not having any heart failure hospitalizations. And you can see her echo has improved. There is no pericardial effusion. And now her creatinine is 1.9 and GFR 1.1, and GFR has improved to 53. This is a second case. This is a 66-year-old male, severe LV dysfunction, COPD, biatrial enlargement, chronic persistent atrial fibrillation, repeated heart failure hospitalization, and he was on optimal medical therapy with multiple attempts at cardioversion failed. This was his ECG. You can see it's a RBBB with much more fractionation in up to V3 and V4. It's not only RBBB. We can say that it's much more diseased heart. So this patient was taken up for the physiological pacing. So with the selective his pacing, we got a good selective his pacing, but you can see that the right bundle branch block was not corrected. So this was, we did little distal pacing. It's a not selective his pacing. And with the fusion achieved from the RV lead also. So RV septal pacing, and you can see there are two stim there. So 40 millisecond distance. So only his bundle, we were not able to achieve very narrow QRS. It was narrower. But with the fusion with the RV lead as well, we got a good narrow QRS. And this is the lead position. This patient also improved, and we did cardioversion for him on table itself. And you can see this is post-AVJ cardioversion, it's a sinus rhythm. So this patient has completed, this was one of the initial case, was done in June 2017. But this case, after 1.5 years, his threshold increased. Its baseline threshold was 1 at 1 millisecond. Now his threshold is around 2.5 at 1 millisecond. So this patient, now his battery is draining. Now this is the only patient which is showing battery life of only 1 year. It's a 2.5 years follow-up, and the battery life is just 1 year. So this patient, we are thinking, because his EF has become completely normal now. He was EF of 30%, so we are thinking once he comes back, we can downgrade the device. This is a third case, 76-year-old male, persistent AFib, severe LV dysfunction, CKD this case, and the EF of, there was much more sicker patient, EF of just 20%. This is one of the emergency visit of the patient. This patient was thought to be it's a VT going on, and they gave shock, and after the shock, they realized that it's an AFib with very fast ventricular rate. So this just, I'm trying to show this is a pacing, you achieve non-selective, you can see there is a pseudo-delta, narrowing of the QRS. This is the position of the lead. This is non-affording patient, so we have not given defib lead. This patient was given just a pace sense lead. It's a CRT P connected. And this patient, you can see, this was done in January 2018, and it's October 2018 ECG. So it's cardioverted in sinus rhythm, but atria pacing, ventricle pacing, you can see. And this patient's his threshold is 0.7 at 0.8, and his 2RV was kept at 50 millisecond. So we, at our center, started his bundle pacing. We are thankful to Dr. Vijayaraman because he started the program at our center in January 2017, and we have published our first 19 cases. So I must admit that all of our initial cases, like out of this 19, 15 were CRT cases. Out of that, 11 are AFib with fast ventricular rate, with sicker patient with the tachycardiomyopathy. And slowly now after this we are changing. Like initially we used to put backup RV lead, but now with the confidence we are not, many cases we are not putting. So there's only one case where the single chamber pacemaker was implanted. This is an 11-year guy with corrected TGA with congenital complete heart block with severe LV dysfunction. So this is the only where till 2019, June, we were doing mostly CRT cases, few only dual chamber, and these dual chamber cases are those in whom we have not put atrial lead, we have put his and the RV lead with the AV junction ablations, but maximum we have put the RV lead. So till now we have done little more than 60 cases. I have the data of 51 cases, and the mean age of the patient is 61 years. And I would like to say that my interest is here. You can see there's a valve replacement cases. There are 3 cases. These are rheumatic heart cases with the persistent chronic atrial fibrillation, with the aneurysmal big LA, with the heart failure. So what I'm doing is, this is the protocol which I follow for the patients with the persistent chronic symptomatic atrial fibrillation. All of us in India, we have these kind of patients. We know that. And they are younger patients. So this is the protocol we follow. Like first you try medical therapy. If it fails, you try cardioversion. If it fails, if the LA is not huge, like not more than 5 or 5.5 you feel, and you feel that it's more of a LA flutter than the fibrillation, you can take them to the lab for ablation. But if you feel that LA is huge, it's more than 5.5, it's a fib and heart failure, you can go and think of doing his bundle and AV junction ablation and follow-up, but with the atrial lead, because we have done 3 cases with rheumatic in whom I've cardioverted. I never cardiovert them on the table, especially rheumatic ones. Once they remodel, we know that it takes some time for the heart to remodel, mainly the rheumatic ones. So once they come after 6-8 weeks, they feel much better. You have done AV junction ablation, you do T and then do cardioversion and then follow them. Although we don't know very long-term data, like 2.5 years data, we have most of them maintain sinus rhythm. So this is the protocol which I have prepared. So I have prepared one registry for this group of patients of rheumatic atrial fibrillation who's having chronic persistent atrial fibrillation. We are not able to manage them with the drug. We can think of doing his bundle with AV junction ablation and see the follow-up. So in our group of patients, initially if you can see, like mostly was CRT, 37 patients, but now we are going towards the dual chamber pacemakers. Mostly are for the CRT or the arrhythmia-induced indications. 2 were pacing-induced cardiomyopathy. 7 patients were complete heart block. 17 patients were either right bundle branch or the left bundle branch block patients. So initially we were doing mainly his bundle pacing. I think I should thanks Dr. Shanmugam because he came 15-20 days back to our center. Okay, I'll stop then. They want to go to live, I believe. Okay, sure.
Where is everyone? Who's managing this vent?
break. Can you hear us?
Oh yeah, I was gonna, if you guys have a moment, I was going to show you guys, I'm doing a sheath and sheath. So just so you guys can see it, this way you get to see everything we do. So what we're planning to do is take this multi-purpose right and put the C315 through it. So you always want to get a sense of how much of the 315 you want out of the other sheath. So I want at least this much out, and you can always use it as a telescoping mechanism. So I'm going to come back and then I'm going to mark where on the CS sheath you'll need to cut. Turns out somewhere about here. And then I'll use my scissor that I don't have anymore. And I cut the sheath. And then I put the 315 in through it. And so now this entire system looks, so it gives you the stiffness of the CS, and I can always pull this back in, and so it becomes telescoping, and so the distal portion can just give me the septal curve, and everything else can come from the CS sheet, depending on how much we need. So I just wanted to show you guys this, and then hopefully we'll see if this helps us get there.
Thank you.
So after he came, we have started doing left bundle branch because he trained the team for left bundle branch pacing. We were not able to achieve a very good results with the left bundle branch pacing. So 11 cases after that, we have left bundle branch pacing. And now we are changing, as I said, to more of a dual chamber pacemakers. And we have now slowly, we are not putting the RV backup lead for these cases. Out of these 51 cases, 4 cases we have in whom the threshold has gone up. I would like to share one more case. This is a 58-year-old male, diabetic, CAD, old anterior myocardial infarction, severe LV dysfunction with EF of 25%. He had a bifascicular block on the ECG. I'll share the ECG, QRBB with LHB and the PR of 180. He had one episode of complete heart block, hospitalization, renal dysfunction, and after some time recovered, CHB recovered. And cardiac MRI showed 53% scar, along with the LAD territory and the patchy scar. So this is the baseline ECG. It's a QRBB, left anterior hemi block, and normal PR. So this patient, when we took, got a, I think it's a good his pacing you got. It's a VO pacing with the at 2.25 volts. And you can see right bundle has been corrected, and your LAHB has been corrected. 2 has become positive, 3 is negative, AVF is equiphasic. So it's kind of a physiological left bundle, left axis. It's not pathological left axis. It's not LAHB. So I was happy with this result. But the thing is, when you do DDD, that was VO pacing. When you do DDD pacing, this was AV delay of 100 millisecond. When shifted and the device connected, you can see this still RBBB. QR pattern has gone. QRS has narrowed down, but you can see LAHB is there, and there is an RBBB. Now, why this is happening? Then I thought, okay, let's check. What I did was I switched off RV, and I just kept DDD only his pacing. The same patient with the DDD only his pacing. Again, you are having that QR pattern with the QRS getting narrowed down, and LAHB is persistent. So why this is happening? So this, we all know that if your lead is above the your leaflet, tricuspid leaflet, that is the penetrating bundle branch, it's you're having a proximal hiss, and this lower, if you pace, it's a distal hiss. So this may be because it's a bundle branch block, so our lead is below. Your lead is below the tricuspid valve, and maybe the AV conduction till the penetrating bundle of hiss is very robust. Because when you make it DDD, your RBBB and the LHB is still there. That means there's a robust conduction across the node and at least proximal part of the hiss bundle. And you're getting a fusion. That's why you're getting a narrow QRS. So what we did was, we didn't shorten because your AV delay is already 100 millisecond. You should not come below 100 millisecond. Your P should not be getting truncated. Your stim should not come on the P wave. Your stim of the V should not come on the P wave. So what was done, this patient was not on antiarrhythmic. He was not on any beta blocker because he had a history of complete heart block. The only thing done was he was started on beta blocker and sent, and he came after 2 months for the follow-up. And you can say same patients with the same setting, with the normal PR what we had kept, you are having that your LAHB has gone and right bundle branch block has gone, the same setting. Last but not the least, it's just a small data. This work already has been done. So, but we know that with the epicardial CRT lead, there is a transmural dispersion of the repolarization, mainly with the LV lead. So because we had done few His bundle cases, we thought let's compare our CRT cases with the His bundle to see T peak to T end, which is a marker of the transmural dispersion of the repolarization, and the ratio of T peak to T end and the QT. If it is more, it's more dispersion. If it's normal or less, it's a less dispersion. So what was done in this, just divided, like it's a retrospective data we collected, 13 His bundle cases and 16 age and sex match CRT cases we took, to just see what is the difference in the T peak to T end and the ratio with the QT interval. So this is the way, this is one of the CRT cases, is the LBBB, and you can see this is how it's measured in the lateral lead, like the lead V5 usually. If you have no good T wave in the lead V5, you can measure in the lead 2. And this is the how you measure T peak to T end and the corrected QT interval. And this is the same patient in whom RALV pacing is there, post-CRT. And this is how you measure the, if it's a T wave is negative, you can measure the T peak to T end. This is one of the CRT patients, one of the His bundle patient in whom T peak to T end was measured. So you can see at the baseline, there was no difference in the His bundle or the BIV pacing. It was not statistically different. But immediately post-implant, in the His bundle group, your T peak to T end and the ratio both are better with the His bundle pacing group as compared to the patients with the CRT. And this thing was maintained even with the 6 weeks post-implant. And if you compare this in the patients with the CRT versus His, the T peak to T end was better and the ratio was also better in the patients with the His bundle as compared to the patients with the CRT. So only thing is it's a very small data, and it says that the conduction system pacing appears to have some beneficial effect on these repolarization patterns, although this study was not powered to evaluate the arrhythmic risk. So only thing is we have to take this as just a small data with a pinch of salt, because it's a single center and we collected the data retrospectively in the very small sample size, and we didn't do like inter-observer variability for the ECG parameters. Thank you.
That was really good experience that you have shared with us, Dr. Daljit. Can you elaborate that why, I mean, initially you took all the the AV node junction ablation and this kind of patient, and you said that you always used to put a backup lead. So
because we are doing AVJ in all of them.
Okay.
AV junction ablation in all of them. So you should have a backup.
You used to take a dual chamber pacemaker.
CRT, because you are taking atrial lead also. Most of them, except I said 3 cases in whom we have not put atrial lead, and we have done dual chamber, His and the RV, His into atrial port and RV into RV port with the DVI mode.
Okay.
So the 3 cases you showed us seem to have the same theme, like they had AFib with RVR, uncontrolled. You put in a His bundle lead and did the AVJ, and then they reverted back to sinus rhythm. What kind of medical management was given for AFib? Like
First lady which I showed was on amiodarone, and she had phototoxicity rather. She was 5 years amiodarone 200 BID. She had all skin changes with that. She is improved. Second case, as I said, multiple cardioversions attempted. All of them are either on amiodarone. These patients were on amiodarone. Few rheumatic patients were on flickierite or sotalol. So, or during the thing when we attempt cardioversion, some patients we give abutylite, but all of them were some or the other rhythm control management.
I'm sorry, I'm not aware how the AFib ablation works here, but
these are the cases which are having lot of comorbidities, not the run-of-the-mill cases. The cases which I'm showing, which like first was autoimmune disease lady with the CKD on dialysis. Second was COPD patient with the huge biatrial enlargement. Third was 76 with the EF of around 20%. So we didn't take any of them for ablation.
Okay, that makes sense, because usually we offer ablation first.
But these are, that's what I said, these are the sick patients. Thank you.
Dr. Parikshit, hi, this is Dr. Avinash.
Yeah, hi.
Can you please tell what is going on to the audience?
I tried to tell you guys, but I wasn't sure you can hear me.
Well, now you're back.
Okay, perfect. So I now have a sheath in sheath, as you can see. The proximal sheath has given me a little more support. So in fact, a second ago, can you guys play the last cine shot? See that?
Yeah.
So with that sheath and sheath support, I was able to get through the septum. Unfortunately, I wasn't very happy with the morphology. And as we went back RAO, that whole system had dislodged. I think we must have gone through there.
That's right.
So everything just pulled back. So now I'm just finding a slightly more proximal location. In the previous part, we were slightly more mid RV. Now I'm trying to pull back and get just slightly distal to the his with the better sheath and sheath support and try to get through again. Flora? So you see how here with the sheath and sheath, it isn't bouncing as much as it was earlier? What's the impedance here? What's the impedance here? .630, okay. All right, go off pacing. Flora? Yeah, no, that's why I went back to. Okay, pace and give me impedance again. I got this for a second. Okay, fluoro. Okay, fluoro again. Okay, go off fluoro, pace again. Okay, what's your impedance here? 896 from 6 what? 630. 630 to 896, okay. Back on fluoro, please. Let me adjust the sheet a little bit. Okay, hold it like this. Fluoro again. Pace again. What's the impedance? Okay, go off pacing.
So what's the impedance, Dr. Parikshit, here?
It's gone from 630 to 880. Let's go LAO. Give me some contrast. Because I can't tell why is that lead tip pointing down like that. Fluoro?
Excuse me, why that lead is pointing down?
Yeah, that's why I'm see that? I'm actually through the septum and then it points downward on the left side. Here, I'm in Synetis.
Can we see the
Yes.
electrograms? Are we seeing anything? Does the polarity reversal is there?
Give me saline. Just gonna have to pull back.
Impedance is 800.
More perpendicular. So use more LAO now.
It looks inside the myocardium still.
It is inside the septum, but I
Yeah.
think it's projecting downward. So what I'm going to do is I'm going to just pull it back and reorient the sheath so that in LAO it points more vertically. Okay, can we put up that as a reference? Stop there and put that up. That's fine. Yeah, put that up as a reference. Good. Now let's go back RAO. Fluoro. So we're clearly having better luck getting through the septum with the sheath and sheath than we did before. This is the second time, and I think it was the angulation that didn't let us get through perpendicular, but now if we use LAO, we'll be able to appreciate that better. But the 315 by itself was definitely not making us do that. I need a little more. Yeah. Thank you. No, she's conducting. Conducting with left on the bench. Maybe it's that atrial tach that's back. Fluoro? Okay, let's go LAO. Give me another pair of gloves. Okay, fluoro. Okay, go back RAO for a moment. See where I am. See, we're back to pacing. There's something interesting here. Cine? I mean, fluoro? Oh, very interesting. Okay, hold this here. You can go off pacing, you can go off fluoro and go on pacing, please. $750, $758. Still positive. Little high, it's okay. Fluoro? Okay, let's pace here and let's go LAO. $680. Okay, fluoro. Huh. I mean, the angle is better than it has been. This needs to be a little bit more. So if I can make this a little bit more vertical, horizontal like that. How's that? That's better. Okay, hold it like that. Okay, back on. Okay, go off fluoro and pace. So the QRS morphology isn't changing. Impedance is 740. Let's get some more contrast. Cine? Wow, did that just pull back as I was just injecting contrast? So I have a beautiful image of lead dislodgement as we're injecting contrast into this. I mean, it looked clearly like it was. Go back RAO, please. doesn't want to get through. I'm going to try this one more time, get a little more of the sheet of that. Okay, pace here.
Didn't you try there, Parik, before?
I'm sorry?
Do you think you have to, I thought you tried at that spot before.
Yeah, I did, but I don't know if we got through in a perpendicular fashion. So I'm going to try to see if I can give a different, you see your AV 2 and 3 are a little discordant here. Earlier they used to be very concordant in the past couple of spots. We were a little bit higher. So I'm going to see if I can get the CS sheet to support it a little bit more, make this system a little bit stiffer. Okay, go off. Yeah, but no, my fingers are sticky, so they're not really even catching on to the lead.
Looks like it went in,
Change
right?
my gloves again. I've changed 4 already. Yeah, so they're just sticky. They're not. No. All right, let's pace here. 940. Okay.
That's looking good, actually. What's the
Measure that
QRS
pace
duration?
QRS. Let's
You want
not
to check the
say-
LVAT at 5 volts and 1
Let's
volt.
not say anything just yet.
Don't shoot the contrast.
Okay. No, not yet. Not yet. Fluoro for a second, please.
You want to check the LVAT at 1 volt?
Not yet. I need to give it one more turn. You said the impedance was 9 what? Okay. Go off pacing, please. Fluoro. Okay, let's pace again. Almost. Yeah. Okay, what's your impedance now? 832. Okay, now let's go LAO and give me some sailing, some contrast.
Why don't you do ring capture, Parik, if you're concerned about dislodgement again?
No, I'm not concerned about dislodgement now. I just wanted to see the impedance starting to trend down, which it is.
It is, and as we discussed, sometimes you might not see the QR or
Right,
bundle
exactly. That's
pattern.
why I wanted to see if I get there. But in V1, there is a little hint of intermittent. If we do 10, let's do our LVAT before
Yeah,
we
that's
do
why.
contrast.
Yeah.
So what's our LVAT? This is 5. 80 milli, how much is it?
That's
90, okay.
9.
Okay, let's do 10 volts. Okay, let's update and measure our LVAT again. About the same. Let's go to 2 volts. Up data measure. About the same. Okay, so LVAD is fixed.
Yeah.
We
What's
like
the QRS duration?
impedance. The QRS is 120 to 125 is what they said. Probably
More to the left.
125, but okay. So impedance rose up to 950 and is down to about 850, 830. It looks like the lead is nicely through the septum. Morphology is good. LVAD is fixed and short, relatively, for a left bundle. So now that's what contrast. Okay. Angle's a little bit funky as always. Now please don't dislodge on me, because I will kill you.
Maybe you can check the ring capture.
See, look at that. This is the 3rd time this has happened. Look at that. Can you just hold that? Did you guys see that?
Yeah, that's very unusual.
Santosh,
I asked you to pace the ring.
I can't hear you. Did you see that?
I saw that, I don't have any explanation for that. We should have just paced the ring to see if the ring is inside the septum and assess the depth that way.
Why does that happen? I mean, we got such a good, finally got a good morphology at this point. Okay, let me just try another spot.
Yeah, the septum is thin, probably.
Okay. I don't know why LAO looks so really funky. Go back to RAO, please.
Dr. Parikshit, there was one suggestion that your CS sheath is not coaxial and it might be causing the dislodgement.
Yeah, so it looks like in LAO it isn't coaxial, and that's true. But I'm trying to counter it into the septum, and it works against me. So I'm just keeping it at a spot where it gives my other sheath support, but it is not septal or lateral. In LAO, I'm not able. His heart is so funny that in LAO everything looks off. So if you look at this, the reference image we've stored on the right, the entire septum is completely bowed out. Audio. Go off, Flora. Can I get another 315 sheet, please? Yeah, just to make sure there's nothing that... You don't have to take everything out, just we'll take the 315 out. No. Look at the amount of tissue that's stuck. And it was really into the septum. Without doing anything. Just with trying to inject contrast. We didn't adjust any of our other sheets. The torque of the sheets didn't change, because I was worried about that. Maybe it's the fact that we made a hole there and went through the same hole again. I don't know. Yeah, so we're going to try and switch out the old 315 sheath for a new one at this point, because I feel like it's also lost a little bit of its curve with the reshaping it multiple times and all. So I'm going to do that and then see if that gives us better support, and maybe try a slightly different position. Maybe in case we've already been through that space like Santosh was highlighting earlier, maybe that's the reason for dislodgement. I think the new sheath will give us a better angle anyways. You can, no, we don't need a Okay. Okay, Flora. Go RAO, please.
Dr. Parikshit, have you changed the lead or it's the same lead?
The lead's the same. I just changed the sheath first.
Okay.
See, that new sheath is giving me a higher reach already.
Yeah, it's a new 315.
Okay, let's pace here, please. Okay, hold on. Oh, it's bouncing up. Hold on one second. It's just bouncing up. Let me see. Okay, pace here. Just over to it, right? I'm doing this case Shanmuga style. I've changed 4 pairs of gloves already, Shanmuga.
My tech used to calculate the duration of procedure based on the number of gloves I use.
I
So he'll
see.
come and count the gloves, and if it's like 6, 7, 8, oh, you have spent more than 1.5 hours. So
I see. Okay, stay on, Flora. So this is 4 turns and I'm through. Pace, please. $988. Okay. What about continue pacing just for Santosh's sake? I'm going to pace the ring. Here's ring pacing.
Very. look at the morphology.
Yeah, so it's on the right side of the septum. It's not through.
No. I thought AVL was negative too, but
No, it's more. It's predominantly AVR is negative, AVR is positive.
yeah, I agree.
Okay. Go off pacing. You said the impedance was 980. What was the starting impedance? Okay. Fluoro? Oh, sorry. Okay, off fluoro, pace again. Pace. $994. Okay, what's your pace QRS here?
The morphology here now, if you see, the AVR, AVL are negative, 2 and 3 are positive.
So it's pointing a little bit more outflow tract.
I agree, yeah.
What's the more pace QRS?
Why don't you try on the inferior aspect?
Yeah, that's where I'm going next.
Yeah. There, try see if you can. Let's see what the morphology is there. It takes you up.
Just wants to keep pointing upward.
Counter. There.
Okay, pace here. Okay. Not bad. How much? Okay, go off. Not yet. Okay, pace. Impedance. Okay, go off pace.
That looks decent, Parik, I think.
Yeah, I'm gonna try and get through here or see if I can borrow through.
Yeah, it is. Buckling looks like, but you can try here. It's trying.
Okay, I'm through,
There,
I think.
that went in.
Okay, let's pace here. Pace, please.
What's the impedance?
600.
Did it go down?
Okay, hold on. Let's pace ring. Pace here. So we basically went through in 4 turns. Okay, let's go off pacing, please. Yeah, so that's how I'm going to go, just more distal. Right about. I don't want to go inferior. It's a little bit further distal. Pace here, please. That's okay. I just wanted to see morphology. Okay, pace again. Give me impedance and morphology. Okay. Okay, this is again only 4 turns. Space. So how much did it come down from 9 watt to what? Okay. I mean, there's a R prime, finally. Question is, where is it going to stay? Okay.
I think it's a great job. I think here.
No, I know, but we've had this result a couple of times. I'm just not getting too excited until the lead stays. So we're going to pace ring here. This is ring pacing.
I think, Parikh, this is the first time I think we see the QR in V1.
Yeah, I know. I
so
agree.
I think
Ring pacing is only capturing every other beat.
Pace at 5 volts. Pull the sheet back.
I'm connected to the ring.
There it captures. What's the ring impedance?
What about now? Try pacing now. Impedance
There
here?
it captures. I think
2,900, partly because it must be in the sheet. Okay, let's just do a contrast shot here before we keep doing anything more.
Are you sure? Parikh,
Yeah.
do we really need to do contrast here?
Yeah, that's what I'm doing next.
Good luck.
His voice is totally gone. Okay, let's go LAO, please. Okay, this is the first time it looks a little bit promising in LAO in terms of the orientation. I'm going to give a very gentle puff of contrast because I don't want it to dislodge my lead. Cine, please. There. That's good. Go back, RAO. Let's do LVATs, please. 10 volts. Yeah. 77 or 80, so that's better than what we had earlier. Okay, 5 volts. Update and measure LVAT again, please. It's about the same. It can be shorter. Okay, let's go to 2 volts. Okay, so LVAT remains the same, about 75 to 80 milliseconds at 10 volts, 5 volts, and 2 volts. We have a QR in V1. The contrast shot clearly showed us that at least the tip of the ring is touching the septum. It's probably far enough. I don't want to go any further because our impedance has already started demonstrating a downward trend. And LVAT is stable. Morphology is good. The only other thing I want to check is, can we hook it back to Pruka so I can look at injury current?
And also you can see like a fulcrum.
You can go off pacing.
Just ahead of the ring electrode, you can see like a fulcrum.
So there is an injury current there on the unfiltered. You can clip it, yeah. Okay. So injury current also is a good marker, because if you don't have it, that means you must be through. So that's why I like to make sure that we still have it. Okay, let's fluoro for me. So now we're going to slowly pull this sheath back without making sure we don't dislodge any of this. Fluoro. Okay, now let's go ahead and test this. Give me more thresholds. So 787 lead impedance, so about 100 ohms, 120 ohms lower than the peak. Okay. We don't have any of the local electrograms.
No, you cannot use the AV.
We don't care about impedance. Let's put it through Pruka.
Just normalize the, play with the AV delay.
Okay.
And then you normalize it.
That's space now. Mm-hmm. Okay, that's 2 volts. Come down.
Yeah. No, you, once you adjust the AV delay. No, once you adjust the AV delay.
So loss at 0.7. So 0.7 at 0.4. Let's check bipolar. Okay.
Is that bipolar pacing?
Yeah, this is bipolar here.
So QS in V1?
No, go back to 5. Yeah. So with 5 you have anodal capture. Can we make V1 green, please, on the live screen? Okay, so now you guys can focus on it. So look at V1, there is no R prime.
Also
So-
notice the local electrogram.
Sorry?
Also noticing the local electrogram.
Yeah, sure. So, okay, so now come down to 4. 3. There's subtle intermittently. There's 3 with a
change in local.
Change in the local electrogram, as well as loss of the anodal capture. In
Alternating.
V1. Yep, it's alternating. Go to 2 volts. So that local V isn't pulled in. So I think this is selective left bundle capture.
Agree.
And come down now. Give us total loss. Keep coming.
No, he's below that.
Keep coming. So loss at 0.6 with bipolar.
It was pure.
Okay. And what was the pace QRS? No, it's a little bit further. Okay, that's fine. So 120 to 130 milliseconds. All right, so LVAT was short about 80 milliseconds, so that's good. We like our numbers. Thresholds are good. The lead is not too far into the septum. Morphology looks good. Time to slit?
Yes.
Any questions at this point? I know you guys have been awfully quiet. I'm exhausted too, but at least we got this done. It was not the easiest anatomy, but as we suspected again, this would be a patient that would either be distal His or proximal left bundle disease, and that's exactly what we found again. Yeah, are you guys still with us?
Yeah. So you know what? There's a loud cheer for the team which worked hard there. You were just quitting. Yeah. Koti sir, you may actually ask the surgeon if it's possible for closing the pocket or whatever. Yeah, I mean, we can go off from the screen. The same.
No, we'll hold both of these. The outer as well. No, let's lift this first. Okay,
Anyway,
Fluoro. Fluoro. Sure. Fluoro. Okay, go to RAO for a moment. Show me slack. Get suture, please.
Parishit, you will do RA Backman bundle?
I'm sorry?
RA Backman bundle?
Good one, Ulas.
No, I thought you will never get tired.
Oh, I can keep going. But not in this case anymore.
Somebody is saying
On the next one.
RA Backman bundle hot.
Good. I mean, in this case, I don't think there's intrinsic AV that's contributing as much as incomplete heart block or Wenke bulb. Let's see again. Let's see that again. Yeah, it looks fine.
Koti sir, you can actually ask for the surgeon if you think, for the closure.
Not yet. We'll take the last sheet. Sure.
So you know what, the people in Accord will like to go to Accord and then
We'll take the J, please. Whatever we get, we'll take right. Whatever you give us, we'll take right. Whatever will get us out of here. Laura?
Babu or somebody, they need to be going to Accord.
That's good. That's nice.
Call Babu, that is Babu. Tell them that people go to Accord and they come.
Oh, that's enough.
1 second.
Can we get
Parikshit,
yeah.
Can you hear us?
Yeah.
Wonderful job. I think you demonstrated, your perseverance, your skills. We are all charged up here.
all I demonstrated was that I can be persistent, that's all.
All right. So great, you people, finish that case, and Koti and Ram Kumar, I think from our side will be around. And I will be waiting for both of you. And then we'll all go together to the hotel or the venue, right?
Okay, yeah.
Okay, right.
We should come up in like
So thanks very much, and all the people in the lab, thanks.
Yep,
Thanks
thank
from
you
our
everyone.
side. All right, okay.
Thank you for putting up with everything. You're fluoroing, yeah? Yeah, he is.
And I'm sure everybody is coming, and then tomorrow we are starting early again.
No, you're okay.
Today, because we waited for a while, but tomorrow, I think we just
I think you're extended.
by 8 o'clock.
Let us start. You are standing.
You are extended.
So this is the mic.